good. There's probably an old high school ring, an anklet, or a necklace you wore when you were a child, a ring Aunt Sally gave you that you never wore. And altogether, it becomes real money. Bring it to us, and you'll get real money for it. At Mark Sadowski Jewelers, you'd be surprised how much you really have. Use that real money to buy something special.
Can you guys hear me okay? Hopefully you can hear. Sound check. You can see my screen. We're going to share the screen here with you. Share the desktop. Hopefully you're going to see the VA intranet, which is what I want to show you. And now you're going to see the standard desktop. Let's see. Let's make sure.
Doreen, can you hear me?
I hear you. Yeah, I know. We got our links crossed here. So it looks like I finally have everybody. Good morning, everyone. Thank you for being so patient. We have many things. So I got to send you a different link, Lisa, but I got to do that at a later time, okay?
Okay.
We're a little bit behind. I see T's on there. Good morning. T, so I'll send a new link to you guys, okay?
All right.
Okay.
Thank you, guys. All right. T, are you still there?
Yes, I'm
So
here.
the first person I think that's going to show up for you will be Irene Herrera, okay?
Okay.
And that'll be at 10. I don't think wound care is coming. And yesterday she told me no. It would be surprising if she did.
Okay.
But you never know. Miraculous. Okay, so we're going to get back to it, okay, guys? So, all right, great. So, good morning. Welcome back to New Employee Orientation. I hope you're not too frustrated right now. I hope you're relaxing. I hope you're enjoying your favorite beverage for the morning. I saw some of you had written that in there. And I want to take you through, because we had the wound care nurses yesterday, they emailed and said that they were having some issues with staff and they were being pulled to a labor pool. What I'm going to do is show you another video that they had done a while back, and that's what got us all crossed up. So hopefully that's going to work, though. It looks like you're hearing me, and I do want to just go over. I understand that these things buffer and they break up, so hopefully you got the email and you don't have any questions about the QR code, or that you need to email Mr. Charles Williams to get the TMS. So hopefully that is also known to you and you understand those steps that you need to do. And that, you know, we have everyone's demographic in, so we're processing and sponsoring you today. We're working on all those things today. Bring 2 forms of ID when you come in on Friday. For my Kerrville nurse, Chris, you will be able to get a PIV card at Kerrville, and you will be able to get everything you need at Kerrville. You shouldn't have to come to Audie Murphy. Okay, it's PIV is only there once a week, and so that you'll just have to schedule on that day, and you'll get an email from our ad pack explaining to you exactly what you need to do. All of you will get this email, and I will show it to you on Friday. Also on Friday, when you come in to the room C303, we have a packet for you to give to you. That packet's going to contain some good information. Hopefully you find it to be good. We printed out the booklet, the Launchpad booklet that we've sent to you electronically. It's a lot easier to read in there. In that booklet, there's a QR code in there also. And if you scan that QR code with your phone, it will give you onto your phone all the important numbers so that we talk about through these presentations. So that would be the wound care nurse, that would be palliative care nurse, that would be the PIC nurse, that would be the AdPACS number, enterprise help desk number, ethics consult pager number. So we've tried to put together a good collection of important numbers. Not every number, because there's no way we could keep up with every number, but so it's inside the folder, in the booklet, in your own Launchpad, which I emailed to you. I think on page 13, I think there's a QR code. Also in the booklet, we have what you need to know about working on a COVID unit. If you're floated to a COVID unit, how you need to prepare, what you need to do. So along with a lot of other important tips about working in that environment, how to don and doff your PPE, and many other things. So you'll get that booklet when you go in on Friday. Also, for all inpatient acute care nurses, be sure and look at the back of that schedule. Hopefully, I hopefully sent you the correct schedule. And on the back of that schedule, it tells you where you need to report. So Caroline, John, Victoria, and Janelle, which I think, I'm sorry if I'm saying that wrong. I noticed you signed your name, Trina. You all are going to report to clinical skills and validation for inpatient nurses, and that's on Monday. All right. So I'm just going to look down and see if you guys are having questions about anything. Yeah, that's fine. Not to email him till Tuesday because it's not going to be there today anyway. We just wanted to give you the information. Yeah, so Chris, yes, you have a PIV already. So if you're a transfer and you have a PIV, just don't use it until someone tells you that the transfer's been complete. And your nurse manager can tell you that if you download that AdPack phone number, if you call the AdPack on there, that he can also tell you that. So we're in transition right now. I can't give you an AdPack name because we don't really have one. Our service doesn't have one. We have an acting, which he just got removed from that role, and then now there's someone else acting. So it's like 3 layers deep. So the best person for you to reference when you need help right now is your nurse manager. So for you, Chris, when you have, or for anyone with their PIV, if you're like, well, can I use it yet? Either I can help you or your nurse manager. So Chris, on Friday, ask your nurse manager if that's been transitioned. She can look that up for you, okay? On Friday, if you're in C303, we can check for you if that transition's been done. It's just because our service is in between AdPacks right now. Sam, you're right. You are not on the list because I just discovered you yesterday. So just consider yourself an acute care inpatient nurse and put yourself right in that list. We'll have a packet ready for you, but you still need to go to clinical validation on Monday and Tuesday. And we've given you a list of those skills that you're going to go through. And really, it isn't any more training. It's more you finding out the products that we have here. For example, what kind of central line dressing change do we use? What products do we use? And then demonstrating. And we give you our policies so that you understand the policy. So I want to move into this because I do have a little extra time because I don't have a speaker coming. We're going to watch a video of the same speaker. But anyway, so if you can just turn your attention again here to what's on your screen. You see this is our desktop, and I want to show you some key things that you need to know about. So if you're looking over to the left, you can see there's the intranet right here with the halo. And I'm not sure if it's lighting up the way it lights up on my screen for you. That is Intranet Explorer. That will take you to our intranet page. This is your Outlook right here. Outlook is, there's no more login. That's your email. And then just below that is your IT. This is if you have an IT issue, like I forgot my password. I don't know how to sign in to my computer. You can put in an IT work order or call the IT help desk. And you will be calling IT help desk on Friday. So hopefully, just remember if you have an IT issue, you can do a work order or call them on Friday. You're going to call them. We've given you that number in your booklet. It's in that QR code, so you should be able to download that number. Microsoft Edge, don't access TMS through Microsoft Edge. It won't work. All right. So there's just so many little nuances here. Most of the time you can just use this Intranet Explorer. Don't use Microsoft Edge for TMS. TMS won't work, and then you'll be frustrated. And then right here, this is probably like what you care about the most. Under the star is where all of our applications are. This would be BCMA, barcode medication administration. So if you're administering meds, you use BCMA, and this is CPRS. This is our electronic health record, and you're going to get training in all of this. So an overview training, you're going to see how all these things work. Plus your preceptor will show you in hands-on also. So I'm just, again, we're giving you an overview so that you know, okay, where do I find this and that? Now, a lot of the presenters you're going to see today are going to show you notes from CPRS, and that's what we're talking about, the CPRS. So you're going to get that tomorrow morning, CPRS training. All right, so this is your desktop. Now, Microsoft Teams, so if you're wondering where do I get all these, where do I get the slides from RME yesterday or infection control, or where do I get the slides from whoever's speaking to you, that you're going to find them in Microsoft Teams. And so you just click on Teams, and you're going to go, once we get this open, hopefully it'll open, you're going to go to New Employee Orientation or NEO and Launchpad, and then you can just open each one of these PowerPoints, find all the information that we've given you. It's all right here in your New Employee Orientation Launchpad. If you need any of these slides or any of this information, it's all there for you. You can get it once you get logged onto the computer. All right, I do want to take you next. I want to take you over. Let's do this. This is our intranet page right here. And yesterday, this is the chief referenced the fact that we have a lot of policies in this organization. I think it's over 478. If you'll notice, I only printed out 2 policies for you in the booklet. One is restraints and one is blood glucose monitoring. As she has pointed out to you, restraints is an issue in our organization. Not an issue, but we're trying to create a restraint-free environment, at which the CLC already is, but we still see restraints on our inpatient. But we seem to have problems in the documentation and the orders of restraints. So we've given you the policy. Quality management is going to come online tomorrow and talk to you about some of the issues that we're finding. And so we want you to really go through and read those 2 policies. Of the 478 policies we could have chosen to give you, we're really only printing out 3 of them. One is restraints, one is blood glucose. And for inpatient nurses, you'll get blood products, blood administration. All right. So where do we find those policies if I lost the printout that you gave me and I need to reference the information? Let's start there. So right-hander, if you look at the left-hand side of the intranet, it says Medical Center Policies. I'm highlighting that. You click on that, it takes you to a SharePoint. Again, we have over 478 policies. So it's hard if you just said, oh, it's a director's policy, or it's a education policy, or it's pharmacy, or whatever. The best thing to do is just use the search, which normally works really well. So let's say we're interested in how do we take care of PICC lines at South Texas Veteran Healthcare. Can I pull a PICC line out, for example, or whatever your question might be? When do we change the dressing? So then you just type in PICC line or whatever it is that you're looking for, and it's going to bring up every policy memorandum or SOP that has the word PICC in it. And then you can select the one that you need. So the search engine that is linked inside of this SharePoint site is very good. So I highly recommend that's how you search for policies when you need them. So that is on the left-hand side under medical policies, but I do want to show you a few things in addition. So under clinical resources, yesterday, one of the things that Randy talked about was how do I find out the manufacturer's instructions for reusable medical equipment? It's right here under one source. And the slides that he provided you shows you this, and how to log in and do all this so you can use one source. But the main thing is, how do I get to it? And it's right here, one source. Also under clinical resources. Nurses do a lot of education, patient education. And so I want to make sure that you know where these education resources are. We've given them to you in your booklet, but I'm pointing them out to you right here. The number one, well, all nurses are different. So some prefer to use Up to Date as a clinical resource for education. Some prefer to use, what's another one I always see? Use StatRef. You have access to that for education, for printing out for patients. Nursing Procedures is Elsevier's version of this. A lot of nurses use this. So this, the part that opened up right here, this is our procedure manual, but you can find patient education also. But first, since we're on this page, let's look at the procedure manual. So let's say Elsevier put together a quick group of clinical skills for COVID, and they just put it in a category. So say you're wondering about, I don't know, anxiety. So it shows you the extended text, a quick sheet. It shows you illustrations, videos, supply list, everything that you would need if you're wondering. And that's really not, I picked a bad one, I'm sorry. So for example, I guess the best way that you would use this, so for example, if you're saying, I work in the ED and I have to do a ear flush, an ear wash, and I normally don't do that, and I haven't done it in a while. I'm wondering if there's a policy here in South Texas of how do you do this ear wash, and you go to the policies and there isn't one. So then you wonder to yourself, well then what do I use? What's my guideline if I need to do this but I'm not sure? I need to review. And this is where you would use this database, right? How do I do a clinical skill that I'm unfamiliar with, but I need to review and I need to use the best practice? You would use the clinical procedure manual, okay? Eardrops, adult, easy to read. So here you can get patient education of how maybe you would send them home doing this. Another bad example. Let's see, what if we do a nasal packing? Maybe you haven't done that in a while. So again, here we are, an epitaxis, nasal foreign body remover. Here you're going to have a posterior packing. So again, it's going to show you, okay, what do I need to know if we're doing this nasal packing? What do I need to get maybe to prepare for the physician to do this nasal packing? Maybe I want to watch a video. I could do that on this. So this is where you're going to, if there's no policy and you need to review the skill and you're unsure, we recommend that you use nursing procedure and clinical skills. We have a lot of information here for if you're trying to do an evidence-based practice project. We have a phenomenal library. So here is also clinical key Elsevier, and so here's where you may find more information, drug monographs, patient education. So here's where you would use for patient education. So let's just pick, my patient has an AV fistula and I want to give them some information about it. It's new. You could print this out for them. You can email it to them. You have a lot of options, and this is approved by the VA. It's written to the level of 8th grade, which is what the requirement for patient education is. So let's go ahead and get back over to our web page. So under employee references, I want to show you a few things. One, TMS is located right here. So you can access TMS right here under employee references. Please read this, right? If you are a new sign-on, a new log-on, you need to read the directions, right? Password login for new staff, that would be you guys, right? Once 28 days pass, you'll be able to use single sign-on, and you'll use this link for single sign-on. So that's located under Employee Resources. The other thing I want to point out, you're going to have somebody from the board, the Nurse Professional Standards Board, to talk to you today. And I want to show you this website so that you can make sure that you know how to write a proficiency and you have the right references for your proficiency. So I'm going to show you two more things, and then we're going to move on to your wound pressure ulcer prevention training. So this is not available outside of the intranet, right here, intranet. You cannot get to this page from your home computers. And that is why, if you're new to the VA and you were asked to put together a packet, and under these standards, you were wondering, where can I find information on this? And maybe you couldn't find any information. Well, now, once you're here with us, you will be required to write an annual proficiency. And here's the website for those references, for that information to help you. How do I write a proficiency? What are my dimensions of practice? What is the VA handbook that guides this information? And that's all here for you. And again, the chair of the board is going to come and talk to you today. So I want to show you where that is. So under Employee Resources, under Nurse Qualification Standards and Dimensions of Practice. We also have written down those dimensions of practice for you in the booklet. If you're new to the VA, you may be wondering about VA acronyms. So we have a VA acronym page lookup. And then VATOS. VATOS is how you get time off. So if you get sick, if you need a day off, if you want to schedule some leave, you do it through VATOS. And there's a training guide here that teaches you how to use VATOS, but it's very simple. Your preceptors, your colleagues, your nurse manager, they'll all show you. But the first time, when you first log in for the first time, I don't know. This is new. Before, we didn't have a single sign-in. So it looks like you'll be able to use a single sign-in to log in. Let's see if it works. So it's going to give you information, right? The dates and schedules, when it's going to be down, and then you just go here, I acknowledge the above statements. So you can log in once with VATOS once you get your PIV with the single sign-in. And so I acknowledge the statements. I'm just going to show you what it looks like. Now it says, hey, you're the employee. What do you want to do? Do you want to do a leave request? What are you going to do? Now, most of you will do AccuStaff, and your schedules will be in AccuStaff. Even though it says schedule here, you don't have like a clock in, clock out kind of thing here. You are given your schedule, and that we have timekeepers who put your schedule into VATOS for you. If you have a schedule change, like I showed up late, I had an appointment, you will log into VATOS yourself and do that information. Again, they will show you this on your units when you get there. I just want to give you an overview that it's here, and this is how you access it. All right, so let's leave this. Any questions on the intranet? So the question was, can I access VATOS at home? No, you cannot access VATOS at home. So if you get sick, when you come to work the next day, as soon as you come in, you need to access VATOS and put your sick time in. Can you access your AccuStaff at home? I honestly don't know. We, in my department, we don't use AccuStaff, and not all of you will. Some of you will use AccuStaff. I think they use it in MICU, but they don't use it in Kerrville on some of the units. So it just depends. We hate to go over it until that's a unit-specific orientation. I don't know if you can access it from home. I think I see some of the nurses doing that on their cell phones, so then that answer would be yes. But otherwise, I think AccuStaff VATOS for sure, you have to access from a VA computer. All right, I wanted to give you an update. This is Mr. Sandler's, and then we're going to move on to our other presentation. And this, he sent it out yesterday, and I just want to let you know, because yesterday the chief nurse both talked about this, so if you, hopefully you can read this, but if not, right now in our facility we have 62 patients that are COVID positive and on COVID units. And so it just gives you a list. So we have 13 in 4A, 10 in MICU, 14 in PCU, 11 on 5A, 3 on 6A, and 11 on 6B. The rest of that large number of COVID patients are being managed in our home-based primary care, meaning that they're being called twice a day by home-based primary care. In addition to that, we have 10 humanitarian patients, which means non-VA patients, and they look like they're transitioning 4A, 4B, 2Z, and spinal cord into COVID units. We've also transitioned yesterday, she told you that we transitioned all of our CLC individuals that we had here in San Antonio to Kerrville, and we're moving the CLC, we're making it into a med-surg unit, and that they're working on that now. We've also moved HR out of where they were on the first floor, and they moved the ED, expanded the emergency department into that area and turned that area into treatment rooms. So, so that is why in the email I said this morning, please be flexible, understanding, knowing that you may be getting some content today that you think, I don't need this, I don't work in that area, why am I being taught this? Because a lot of our other nurses didn't think they'd be administering blood or working in areas where they're actually doing this work now. So we're giving you an overview of a lot of different information. All right, I'm gonna stop sharing this and we're gonna bounce over to another video. So let me talk to you about that for a second. This is a recording that you're seeing. It's recorded by our wound care nurse. Her name is Jenny Davis. Her phone number is in that QR code that we've given you. And she will talk to you about, you know, her being available. And she has, you know, they're very approachable. All of our wound care nurses, we have 3 of them at South Texas. And we have 1 for spinal cord specifically. So we have a lot of wound care champions. That's in the CLCs. So we have a lot of access to outpatients. They do outpatient clinic for wound care. So if you just have questions about wound care, I would say contact this team. So she is doing this video. She's not online with you. If you have questions, just type your questions in the chat box for her, and I will relay them to her, and she will get to you in an email when she can break away from patient care. All right? So we're going to stop this video. I'm going to check the chat, and then we're going to move on to another video. Okay, guys? All right, I'll be right there with you.
At least you can sit here with no mask on there.
Now, right?
And she'll tell you when she's ready.
Okay.
She has all this talking we've been doing, they can't hear us.
Okay. But I'm unmuted. So when she
You're
tells
not
me,
muted right now, she can hear you, but
okay.
We can hear you. We hear you.
Oh, you can hear? Okay, so now you're live, but you're not on camera.
Okay.
All right, guys, everyone should be back from the break, and now we have our wound care extraordinaire, and she is going to go over some really important technical information with you, so please take some notes, save your questions to the end, and we will answer all of those. All right, Jenny, thank you for coming, and I'm going to let you take over.
All right. Thank you, Irene. Good morning, everyone. My name is Jenny Davis. I'm a geriatric nurse practitioner. I'm also one of your certified woundostomy nurses for the facility. So this morning we're going to be discussing pressure injuries. And you're noticing I'm not saying pressure ulcers because a few years ago our governing bodies got together and they redefined the definitions, which we'll discuss later, but they also changed the term. So we went from bed sore to decubiti to pressure ulcer, so now it's called pressure injuries. And there's a few reasons why they did that. One is to really identify the etiology of these injuries, which is pressure, and then not all the stages are an open wound, so we're not calling everything ulcers. So it's pressure injury. So here we go. So our objectives today are identify factors that contribute to pressure-induced tissue injury and to describe the category and stage of pressure injuries. So y'all will all be experts at staging by the end of this, I hope, or at least feel way more comfortable if you're not already. So why do we need to know as nurses about pressure injuries? Well, there's several reasons. One, it's not on here, but as nurses, we don't own many quality indicators, but pressure injuries is all us because we are the ones at bedsides caring for these patients, turning them, cleaning them, helping them eat. So it's really a quality indicator that as nurses we own. So if you see a facility with the high pressure injury rate, that's a direct correlation of nursing, and we do very well here at Audie Murphy. We continuously have a low pressure injury rate because we have awesome bedside nurses here. But for other reasons that are listed, it's a geriatric syndrome, and that just means something we frequently diagnose in a geriatric population, and that is who we serve here at the VA, or tend to be elderly patients. Now this is, on the second one, it's an old fact, so I'm sure the numbers are quite higher, but 2.5 million patients per year in the U.S. alone will get a pressure injury. These wounds are very painful at times. It's an ischemic wound, meaning there's no blood flow getting to this area. I don't know, actually the other day I rolled my ankle and I put an ACE wrap on myself, and I woke up in the middle of the night with my ankle just, it was a pain I've never felt before, and what had happened is I had wrapped it too tight, so there wasn't blood flow getting to it. And so it kind of reminded me, that's how these pressure injuries start. It's an ischemia to the deep tissues, which again we'll talk about more later on. Number 4, our skin is our protection. So anytime we lose our skin, we run the risk of getting germs in there, which can cause an infection, a cellulitis, where it spreads to the surrounding tissue, osteomyelitis, where there's now an infection in the bone that's very hard to treat, and sepsis, where it gets in our bloodstream and we become very sick. There's a high mortality rate with these injuries, 60%, and this is talking about patients that develop a stage 3 or stage 4 are unstageable. There's a huge impact on family, and an example I use is a patient I saw several years ago in clinic who had gone in for an elective hip surgery. The surgery went well, but a few days after he went home, he had some sore bruises on his heels. And they really hurt, so he went back to his orthopedic surgeon that put him on an antibiotic, thought it may be an infection. They asked about, if he had hit it or any trauma, which there was none. And those bruises turned into very thick scabs. So he went to his PCP, went back to orthopedics. It took several months, but eventually he wound up in my clinic. And after taking a good history, I was able to identify that sometime during either the surgery or the hospital recovery stay, his heels weren't guarded. And so he had developed bilateral heel unstageable injuries. So now his rehab was delayed. This was a man that was very active. He played golf. He was still working. He was very active in his church. And these wounds were painful. The eschar broke, they were draining, they smelled. His wife was now pushing him around in the wheelchair. So these are never acute wounds. These take very, very long to close for these patients. So it can affect not only the patient, but the family, finances, which can lead to depression, all types of bad things. And many of the time, 97, 98, 99%, these injuries are preventable, and it's up to us at the bedside to prevent these injuries from occurring. And we'll talk more about prevention in a little bit. Just a little financial data here. It's a huge cost to treat these injuries. Medicare no longer pays for this hospital-acquired condition, so the facility takes the cost for it. On number 4, you can see that these are lawsuits, and myself have been involved in a few of these here at the VA. But you can see about 90% of the time it favors the patient with these lawsuits, and that's again because these are avoidable injuries. You did not come into the hospital with these wounds, and you should not leave with the hospital with these wounds, and it's up to us nurses to prevent these wounds from occurring. And it also increases length of stay, which also will increase the facility's cost. If any of y'all are going to be working in our CLC or maybe spinal cord, this is just some data regarding nursing facilities, long-term facilities, but they're kind of interesting. Residents age 64 years and under are more likely than the older residents to get a pressure injury. Excuse me, I didn't see that one with the ulcer. But I'll just let you review that so I can just keep moving. So here it is, okay? So again, back in 2016, the National Pressure Ulcer Advisory Panel and the European Ulcer Advisory Panel got together and redid the term for pressure injury and then the definitions. So this is a long definition, okay? But the reason why I don't mind them being long is because they're so good to direct us on what the etiology is, and then with the different stages, what you will and you won't see in the wound. So here we go. A pressure injury is localized damage to the skin and or underlying soft tissue, usually over a bony prominence. So a bony prominence is sacral coccygeal area, your elbows, your knees, the back of your head, your occiput. It's just where the bone sticks out. The bone is prominence. So if you have a wound over your abdomen, unless it's device related, it's most likely not a pressure injury, and we wouldn't stage it using the pressure injury staging definitions. So it's usually over a bony prominence or related to a medical or other device. Excuse me. The injury can present as intact skin or an open ulcer that may be painful. The injury occurs as a result of intense and or prolonged pressure or pressure in combination with shear. So the shear component of a pressure injury is this. It's two forces moving in opposite directions. So, for example, you have a patient that has slid down in bed, and instead of grabbing a transfer sheet, you and another nurse get on either side of the patient and go under his arms to scoot the patient back up in bed. Well, if the skin's a little moist, what's going to happen is the skin's going to stick to the surface, but when me and the other nurse pull the patient up, the vessels, the capillaries, the tissue underneath the skin moved, even though the skin stayed in place because it was wet and stuck to the surface. So you have the skin staying put, you have the underlying vessels moving up with the patient. So what happens is they're kinked, they're torn, they're ripped, they're damaged. A good example that you would be able to see is if you ever have we commonly see it in a sacral wound, when you have undermining of the wound, meaning you have wound that goes underneath the skin, That's the shear component of the pressure injury, is that undermining part, because that's where the skin has stayed put and those underlying tissue was ripped and damaged. The tolerance of soft tissue for pressure and shear may be affected by microclimate. Microclimate is just a fancy word of what's the environment around the skin. Is it hot? Is it cold? Is it wet? Is it dry? Nutrition, perfusion, comorbidities, and condition of the soft tissue. Perfusion's a huge one, especially with our heel pressure injuries. We've had a few hospital-acquired heel pressure injuries due to undiagnosed peripheral arterial disease. I will say many of our patients will have a past medical history of coronary artery disease, or a CABG you may see, so CAD or a CABG. So the evidence is, if patients have atherosclerosis, they have plaque in their coronary arteries, there's a high correlation that there's also plaque in the peripheral arteries. So you may have a patient, so always look at the comorbidities, with a history of CAD, so that should alarm you that, okay, so their peripheral arteries and their legs most likely have some plaque in them, therefore I need to be guarding these patients' heels from pressure. Another big one, of course, is diabetes. Not only does diabetes affect circulation, but also we get diabetic neuropathy. So they may not feel that their heels hurt on the bed. They may have totally lost sensate to their feet. Another evidence-based piece of data is that the research says if patients has had diabetes for 10 years or longer, they have some level of peripheral neuropathy. Okay, so again, I mean, these are our patients. A lot of them have diabetes, a lot of them have CAD, already putting them at a higher risk because of they won't have tolerance of soft tissue like you and me may have. And we'll go to the next slide here. So a medical device related pressure injury. So this is a device. So these result from the use of devices designed and applied for diagnostic or therapeutic purposes. This results in a pressure injury, and that generally conforms to the pattern or shape of the device, and we stage it using the staging systems. So some devices that have caused pressure injuries here, nasal cannulas. We used to have hard plastic nasal cannulas, and we actually had some stage 4s on the top of the ears. And so you think of the ear, a stage 4, I mean, that's not a deep wound, but you have to think, when we go to the staging part, it just doesn't take some millimeters, but you're already in the cartilage, and that's a diagnostic indicator of a stage 4 pressure injury. So we actually did a lot of investigative work, and we have brought in some soft silicone nasal cannulas, and pleased to say that we've negated injuries from nasal cannulas due to that. A couple of years, we had an epidemic of injuries to the nasal bridge from ill-fitting BiPAP mask, and those can be very dangerous. Again, it's some millimeters, and you're there at bone, and anytime you have exposed bone, that puts the patient at risk for developing osteomyelitis in the future. TED hose. We've had some patients injured from anti-embolism or TED hose, whatever you want to call them, around the toes. We had a patient about a year ago. He had undiagnosed peripheral arterial disease, and after surgery became hypotensive. So unfortunately, when you become hypotensive, the skin loses out. All the blood shunt to the vital organs. And so this patient had developed several injuries on his feet from the squeeze of the TED hose, and also with the ischemia he had in his leg. Mucosal membrane pressure injuries are found on the mucous membrane, so things like soft and hard palate, inside the nares. Sometimes we've had, this is kind of an outlier, we've had just maybe 1 or 2 since I've been in this role, injuries from an NG tube inside the nose. So when you have one like this, with a history of a medical device in that location, we don't stage it because of the tissue with the mucosal membranes, but you just want to describe it. So, you know, if it was on the patient's lip, you may just want to, just describe it. Is it purple? Is it maroon? Is it red? Is it partial thickness, full thickness? Maybe some measurements. But you can't stage these type of injuries using the staging system that we're about to review. So what causes pressure injuries? We've kind of discussed some of these. But pressure, okay, so this is what happens. So my heel's laying on the bed, okay, so there's this squeeze that occurs there. So the skin and fat, they're pretty tolerant to ischemia, but muscle is not. It cannot tolerate that ischemia. So when there's that squeeze, there's no blood flow getting to those deeper tissues. So what happens is that deep tissue dies. So the injury starts right at the muscle bone interface. So there's the injury starts deep down there, and then it evolves upward, and it can take hours to some days for the nurses to actually see changes in the dermis. And typically you'll start seeing a maroon, purple, dark discoloration that's not blanching. So these are not surface injuries. These are deep injuries. So we use the analogy as when you do finally see changes in the skin, that's just seeing the tip of the iceberg, because the damage goes all the way down from where the muscle and bone are in contact. So then, who is at risk for developing a pressure injury? And y'all, if you're familiar with the Braden scale, you might see that these first three, activity, mobility, and sensory perception, are part of the Braden scale, and that is the risk assessment scale we do use here in the hospital, and we'll review that later on. So activity. Activity mobility have confused me, but this is how they see it. Activity is what the patient can do independently outside the bed. Mobility is what the patient can do independently inside the bed. So activity would be, are they getting out of bed to a chair independently? Are they getting up ambulating independently? Mobility is, so what they're doing in bed. So are they turning themselves every couple hours to offload the sacrococcygeal area? Can they make minor turns, but they need our assistance to really make a significant turn? Are they totally dependent on us for turning them in bed? Sensory perception, ability to respond to discomfort. We talked about diabetic neuropathy. You lose your sensory. We have a spinal cord unit here that they are not able to feel pain, so they're a very high-risk population. But just another side note on that, nurses, they've studied nurses that perform the Braden scale, and we tend to be cheerleaders for a patient. It's just an inherited trait of being a nurse. But really, if you're performing the Braden, you have to look at what the patient can do independently. So for example, I see several quadriplegic patients that are in their electric wheelchair all day moving around. And so the nurse will put chair bound. But you have to think that quadriplegic patient was not able to transfer from the bed to his chair independently. It either took a lift or a caregiver. So really that patient should be identified as bed bound. Even though we see him in that chair quite often, he was not able to do that on his own. So always think when you're doing the Braden, what can the patient do by themselves when you're doing the activity mobility part? And number 2, tissue tolerance. So there's certain extrinsic factors. Moisture is a huge one. We're always fighting moisture. You'll see part of our skin bundle is we don't allow diapers while the patient's in bed, because what they do is they hold the moisture to the skin. So your skin is wet, so it's fragile, and then they, let's say, slide or scoot, and then you just get that top layer of skin torn off, and that's the classic way a stage 2 injury will occur. It's from by wet skin and a little bit of friction, either with a slide or a patient scooting. Intrinsic factors, nutrition, perfusion, those are 2 big ones with that. So pressure leads to, we talked about this, hypoxia. So you get metabolic waste products and free radical generation. So I think of it kind of like the heart attack of the skin and deep tissues. So let's say you had a heart attack, right? That part of the muscle dies. So your heel's resting on the bed, that part of the muscle dies. And then we go take the patient who had a heart attack to the cath lab and we put a stent in. Well, now there was this, during that time of injury, there was this accumulation of waste products, free radicals. But when we get the stent in, they're pushed out. So there's even more damage to the surrounding muscle. That is a very similar way of thinking of a pressure injury. The heel was on the bed for extended time. Now we go and relieve it. We offload the pressure. So there's going to be this reperfusion injury, as you'll see as in a heart attack post-stent. And then number 3 with the compressive forces, that is just where you put some compression on the cell and it causes cell wall deformation, which will injure the cells. All right, let's get to the fun part. Staging pressure injuries. What is a stage 1? That is non-blanchable erythema of intact skin. Non-blanchable erythema. That means I go to the skin, I lay my thumb in, put a little pressure in about 5 seconds. When I take the thumb away, the skin is not turning white to red. It just stays red. So that is non-blanching erythema. Intact skin with a localized area of non-blanching erythema, which may appear differently in darkly pigmented skin. Pressure of blanchable erythema or changes in sensation, temperature, or firmness may precede visual changes. Color changes do not include purple or maroon discoloration. This would be another stage, which would be a deep tissue injury. So stage 1, again, you're over that bony prominence or under a medical device. You have not lost skin, but it's non-blanching redness. Stage 2. This is the most popular stage to use with my nurses. And it's used a lot inappropriately. So this I really like this definition because it's going to tell us what we will see and what we won't see in the base of this wound. So a stage 2 pressure injury is partial thickness skin loss with exposed dermis. So I have only lost the epidermal layer of the skin and I'm in the dermis. So it's partial thickness skin loss. The wound bed is viable, pink or red, moist, and may also present as an intact or ruptured serum-filled blister. Serum-filled blister is important because there's another stage that will have a different fluid in the blister. Adipose fat is not visible and deeper tissues are not visible. Okay, so here it is right here. This is a good sentence. Granulation tissue, that is that red, bumpy hamburger meat type of healthy tissue you see in a wound. You will not see that. You will not see slough and eschar. So slough is that, excuse me, hey Joe, I'm presenting, I'll call you back. So you will not see slough, which is that yellow, brown, kind of chicken fat looking devitalized tissue in a wound, and eschar. Eschar is that black, thick, leathery, dry scab that you'll see in wounds. You will not see granulation tissue, you will not see slough, you will not see eschar in this wound because you're not full thickness. You're, again, just partial thickness. These injuries commonly result from adverse microclimate and shear in the skin over the pelvis and shear in the heel. And we had talked about that. Adverse microclimate, meaning you got wet skin and you scooted across and you sheared off that the epidermal layer of the skin. So if you had to have a reference right now, I would think of like wearing a new shoe, and you developed first that straw-colored serum-filled blister somewhere, and then that blister de-roofed. So you had this very superficial, pale, pink, red, viable, moist base. That is your stage 2. What happens is sometimes we get very superficial stage 3s, and the nurse will call it stage 2. But when I go and see it, I see some yellow tissue in there that I identify as slough. even if it's only 2 millimeters of depth on the sacrum, I can see slough. We are no longer a stage 2. We're a full thickness loss, and we need to stage it appropriately, okay? And so I really think the stage 2 definition really helps the nurses to the proper staging. So that's the stage 2. Okay, stage 3. Full thickness loss of skin in which fat is visible in the ulcer and granulation tissue and epiboly. Epiboly is a fancy word for a closed wound edge. You can see it right here. You don't have to really worry about that too much. Are often present. Slough and or eschar may be visible. The depth of tissue damage varies by anatomical location. Areas of significant adiposity can develop deep wounds. So I have a really good example with this one. I had a patient who was 500 pounds who sat in a wheelchair where the cushion was ripped. And so he was sitting on the bar of the chair and did not realize it. And when I first saw him and measured the wound, he had 5 centimeters of depth on his right buttock. But I was still in adipose. It was all fat that I could see in the wound. So I was not at a stage 4 because I had the diagnostic indicators to say this was a stage 3. So it was full thickness and fat was visible in the ulcer. And so that was just a good one of a really deep stage 3. Undermining and tunneling may occur. Now listen to this one. Okay, so fascia, muscle, tendon, ligament, cartilage, and our bone are not exposed. So you see fat, you see, like on this one right here, you see some slough here. This is really nice textbook granulation. So this is a nice example of a stage 3. But I do not see bone, I do not see fascia, muscle, tendon, ligament, or cartilage, because that would be a stage 4. Now, if slough or eschar obscures the extent of tissue loss, this is an unstageable pressure injury, meaning if there is too much devitalized tissue in this wound where I cannot see the extent of the injury, I'm going to classify it as an unstageable pressure injury, and I think the next one, or maybe after 4, we'll look at one of those. So stage 4 pressure injury. Full thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. So I can either see bone, excuse me, no, I'm so sorry. Woundostomy is Jenny. Hi. Hey, I'm actually presenting right now. Are you with us today?
No, I'm not.
Okay. Can you call me back in I'm presenting. Can you call me back in an hour? Okay. Okay, sorry. I forgot to hand off the work cell phone when I left. Okay. So let's just start over because I lost my train of thought. So full thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. So I can either see it or I take a Q-tip applicator and I can feel something hard. That would be palpable. Slough and or eschar may be visible. You may have the epiboly. Undermining and or tunneling often occur. Depth varies by anatomical location. If slough or eschar obscures the extent of tissue loss, this is an unstageable pressure injury. So our diagnostic indicator for a stage 4 is I can either see or directly palpate fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. So even if a wound was like 80% eschar, but in that 20% I saw the bone right there, I would that's classify. I have a diagnostic tool of that bone being exposed to go ahead and stage it as a stage 4. Okay, so the unstageable pressure injury, you just can't see what's underneath it because there's too much devitalized tissue on it. Slough is covering it, eschar is covering it. So when we debris it, we're going to be full thickness. So we either are going to have a stage 3 or stage 4, but we just don't know right yet which one it's going to be. And just ignore this last one with the stable eschar. We don't need to worry about that. So again, this is just where you cannot see, you cannot palpate anything that would be diagnostic of a stage 4, which again would be muscle, bone, tendon, cartilage, fascia. So deep tissue injury. This is the bad boy of pressure injuries here. So this is persistent, non-blanchable, deep red, maroon, or purple discoloration. Or you could have epidermal separation, meaning you've lost the epidermal layer, but the wound base is dark. It's usually purple, maroon too. Or a blood-filled blister. So this is your other blister, okay? So stage 2, you had serum-filled, which is your straw colored blister. And a deep tissue injury, you'll have a blood-filled blister. Pain and temperature change often precedes skin color changes. Discoloration may appear differently in darkly pigmented skin. This injury results from intense and/or prolonged pressure and shear forces at the bone-muscle interface. The wound may evolve rapidly to reveal the actual extent of tissue injury or may resolve without tissue loss. I will say the research shows about 70% of deep tissue injuries will progress to a full thickness wound. So most likely it will not resolve without tissue loss. If necrotic tissue, subcutaneous tissue, granulation tissue, fascia, muscle, or other lining structures are visible, this indicates a full thickness pressure injury, unstageable stage 3 or stage 4. So this picture down here, that's a good picture to really see where these injuries start. So here's skin, here's skin, there's a lot of skin. There's fat, this yellow part. Here's muscle and here's bone. So right down here where the bone and muscle interface is where the injury occurs, and then it takes again some hours to some days for it to evolve where now we're seeing these skin changes, these color changes in the skin. So that's why we say it's the tip of the iceberg, because you have all this damage going down. So a deep tissue injury. So what you have to do with this stage and of course all the stages is our first nursing intervention is to get the pressure off. I cannot say that enough. It does not matter what dressings we put on it. I tell my patients all the time, we could spend $1 million on hyperbaric treatments, skin substitutes, whatever. But if we do not remove the injury, which with these is pressure, it will not work. These wounds will continue to get worse. I've had patients that they get worse, they go to the bone, they get septic, and these patients have passed from complications with a pressure injury. So these are very serious wounds. So let's say, for example, you identify a sacral pressure injury. You are automatically not allowing that patient to lay flat on their back. We have turn systems that you'll see on the units that you will use to just turn the patient a little bit to the right, a little bit to the left every 2 hours, and avoid laying flat on the back. If it's a heel pressure injury, I will hold up that leg until someone brings me an offloading boot to put on, because I just know how important it is for the plan of care. Number one thing to do is to relieve the pressure with these wounds. So here's an example of some of my patients. This patient had a wound from his prosthesis. This is a posterior residual limb. And it was too small of a prosthesis for him. So you can see the shear component right here. Every time he was trying to get his leg in and out, you can see the shear part going vertically there. So this is eschar. You see some granulation here, and there's some slough, but I cannot identify anything to either, I know it's full thickness, right? It's not a stage 1 because we've lost skin. It's not a stage 2 because I'm seeing diagnostic indicators that we're beyond a stage 2 because I have eschar, granulation, and slough. So it's either a stage 3, a stage 4, or is it an unstageable? Right now it's an unstageable because I have no identifying factors that I could call this a stage 3 or stage 4. I could not see bone, muscle, fascia, cartilage, tendon. I cannot palpate it. So this is a good example of an unstageable device-related pressure injury. Here's another one. This is kind of a weird one. This patient didn't have any feeling in his leg, and he had a bolt in his wheelchair. that he constantly rested his leg on. So this was another device related, and this is an unstageable because pretty much it's 100% eschar. You can see the surrounding cellulitis here. But I am not ready to stage it, but I am going to treat this infection and start debriding. So I call him to California and order some of my maggot friends to start helping me debride this wound. So this is the same patient. This wasn't just after one treatment of maggots. This was several months of debridement. But now we have this beautiful granulation tissue. So I see granulation, I know it's on a stage 2, but centrally here, running through the leg, is a tendon. The maggots were helpful and showed me where my tendon was, so when I put a wound back, I could protect it. So now I have a tendon visible. So a tendon is an indicator of a stage 4. So this was a stage 4 pressure injury because I can see that tendon. Okay, this was a patient that was admitted with an infected leg, and it was wet gangrene. So he had several trips into the OR for debridement. So down here, his feet, up here would be his head. And so this is also a nice picture because it shows that lateral shearing, and what we think happened is just him going back and forth from the hospital bed to the gurney to go to the OR, or the OR table back to the gurney, but you can see this lateral shearing injury. You know, if we were just looking, you could call this right now a deep tissue injury because you have this epidermal separation with this dark area in the base. Okay, this had developed, once we got all this dark purple area off, it was a stage 3, but right now we would call this a deep tissue injury. So this is a great picture because it has all the stages pretty much. So this is one of my patients who had a history of stroke, and after his stroke he constantly crossed his legs. So his family got a pool noodle actually to separate his legs. But this patient had a limb ischemia, so even the pressure from the pool noodle, his tissue, we talked about the tissue tolerance, could not tolerate that amount of intense and prolonged pressure from the pool noodle. I know it's crazy. Who thought a pool noodle could cause a pressure injury? Anywho, so down here, you see the large tendon running here, so that is your stage 4. Right here, this is a good example of a deep tissue injury because this is not just non-blanching erythema, which would be a stage 1. This has maroon, and you can see this darker purple discoloration, and yes, it was non-blanching. So this is a good example right here of when your skin's intact, but it would be a deep tissue injury, not a stage 1, because of this darker purple maroon discoloration that we see here. Let's go up to this one. So right here, there is some purple discoloration, but if you were just looking at the open sore right here, you can see that it's partial thickness. I don't see bumpy tissue like down here. That's granulation tissue. I just see a moist red surface. So the wound right here, that would be a good example of what a stage 2 injury looks like. And then let's say right here, this was non-blanching erythema with your skin intact. That would be a example of a stage 1 pressure injury. So we have a stage 4, we have a deep tissue injury, we have a stage 2 with this open wound, and then we could call that a stage 1. I think this is a stage 3 up here, but I can't really see it that well. So this is a sacral injury. This patient I followed from a nursing home. So it's kind of hard to see in this picture, but there's muscle exposed in this wound. So that's one of my diagnostic indicators for stage 4 is I can see muscle. Why I use this picture is because I'm going to go back to why it's so important to keep the pressure off these injuries. So within this stage 4, you can see this area of this black purple darkness here, okay? So of course part of my wound care orders was do not allow this patient to lie flat on the back. We had purchased from the VA a airbed, but airbeds don't offload, okay? They're just high level pressure redistribution. The only way to offload is to totally remove the pressure. So I wanted the nursing home just to go right to left, right to left. They said they were doing it, but the wound told me otherwise, because this dark area, that's an ischemic event within the wound. So this is like a DTI within the stage 4 pressure injury, okay? So the wound will tell you too if there's not pressure being taken off. And just like your typical DTI, I lost all this tissue here, so I had an even deeper wound to try to heal. So what do we want to do? Well, we want to eliminate the causes, okay? And so we're going to go now into what we do here to prevent the pressure injuries. So part of our hospital policy, our hospital-acquired prevention program is to document, of course, right? And so the notes we use is called VANOD. So if you went into CPRS and just opened a new note and type in VANOD, you're going to see new, these titles come in every day. So I'm going to click on this screen, okay? So I typed in VANOD. So the first one is your skin initial assessment, and then there's one right below it that says skin reassessment. You do the skin initial assessment only when the patient gets admitted to the hospital. So he's coming from home, the ER, from a clinic, from an outside facility. He's admitted to a unit. That's when you do the skin initial assessment. Every hospital day after is a reassessment. Even if the patient goes from MICU to 5A, 5A to 2 West, whatever, it's a reassessment because we only do the initial assessment when the patient is first admitted to the hospital. Reassessments are done every day thereafter. So this note that I'll show you is a little bit different than what a skin inspection is. A skin inspection is just what you'll document in your 24-hour nursing shift assessment, or if you're ICU and a centrist. It's like, what was the turgor? You know, you'll document the wounds, but just what you inspected. This note is a comprehensive skin assessment. So this is only done once a day on your unit, and some nurse managers assign it to different shifts. So your nurse manager and your preceptor will let you know who does this note for the daily coverage of it. So it's comprehensive because we have a risk scale in this note. So again, we use the Braden scale. If you had any questions about what the categories of the Braden were, you can click on that blue link and that will pull up the Braden scale for you. So you can go and read and assign the number to the patient. I will say if you're teeter-tottering to is he constantly moist or very moist, just go with constantly moist, okay? You're just going to give this patient a lower score and we're just going to put more interventions in to protect the skin. It's dangerous to give the patient too high of a score. That's actually how some of our hospital-acquired injuries have occurred. We've had patients that the nurses gave them a Braden of 19 or above. So that indicates that patient has no risk of developing a pressure injury. And really, when we looked back and did the chart reviews, they should have never been given that high of a Braden. They should have been somewhere below a 19 where we were guarding his skin from developing these pressure injuries. Okay, so you start the VANOD note opens up. The first thing is the Braden score. So you've done the Braden score, you add it up, you click to put them in some category of risk, and then the next part of the note is your skin inspection. So is there any like medication patches, EKG leads, what's the color, what's the temperature, what's the moisture, what's the turgor? Are there any skin problems? And so if you put yes, you could, of course, do abrasion, surgical wounds, bruises, yada, yada. But this is where you'll click to put yes, that they do have a pressure ulcer. Now, this is a national note, and they are trialing right now a new VANOD note with the new definitions on it. Our current note has still the old definitions that that you can still use, of course, but I just want you to know these aren't the new definitions. So you would click on whatever, stage 2, and then there would be other menus of where it is, and then you could have there's an area where you could free text if you wanted to put more description of, say measurements, the health of the peri-wound skin, there's drainage, what's the base look like, any description I think is good to include when you're documenting on your wounds. So the last part of this note is nursing interventions. So take time on this part, because I will say it's just a little suspicious, okay? So we have a patient, maybe a braiding of 18, puts them at a mild risk, and the only thing we did was provide a little education, okay? So that was upon admission. But here comes day 3, now we have a hospital-acquired stage 2, and now all the interventions are clicked. You, as the bedside nurse, you are doing all of these, so take credit. We've all have been ingrained in our brains, not documented, not done. So you are doing them, take the credit for what you're doing to help protect the skin in this part of the note. So the interventions are a really, really important part, okay, to fill out completely. At the bottom of the note, you can click here to initiate a wound care consult. That will go to my team. And you can also initiate a nutrition consult, because that goes, patients at risk or that have a pressure injury. Nutrition is a big part of this. So you can consult both us and dietary. So you've done your BANOD, either initial assessment if this was upon admission, or a reassessment for every hospital day. You gave him a Braden below 19. Now you've documented all these nice interventions of what we're doing, but I want to show you exactly what type of implementations we here have at the hospital, okay? So I'm going to show you something called a skin bundle. A skin bundle should be implemented with all patients that have a Braden of 19 or below. The skin bundle are not physician's orders. You do not need these orders in CPRS to implement, okay? These are all nursing interventions. So if I'm getting a report from the ER, patient comes from nursing home, rule out CVA, I'm kind of already doing the Braden in my head. I came from the med-surg unit, so just like I would go grab my vital sign machine or MRSA swab, I would start grabbing a lot of these skin stuff, so I would have it on the bed ready to go by the time the patient's brought up to me from the ER. So let's go over these, okay? So the first one is Prevalon boots on all patients with a Braden less than 18. So the Prevalon boot is our only allowed offloading boot in the facility. We don't allow bunny boots. Bunny boots are those light blue boots with that one strap. Those do not float the heel. The weight of the heel goes right through it. So we have what's called the Prevalon boot. Now, when you grab the Prevalon boot from your Omnicell, it comes inside out like this, okay? So that's for a reason. They want you to take the boot inside out, and this would be where the hole is. So you line up the hole with the heel, the cushion part goes along the calf, and then you flip the sides upwards, so now the boot is right side in, and you can see that the heel is where it needs to be, which is in the hole, so it's floating. That's the only way to protect the heel from pressure, is by floating it in the air. There are no dressings out there, even though Rhett may tell you otherwise, that protect a bony prominence from pressure. All these dressings would do was protect from friction and shear. But if we have the heel, let's say, floating in the air, well, we've taken care of pressure, we've taken care of friction, and we've taken care of shear because there's nothing touching it. Okay, so the heel is floating in the air, there's color coordinated straps. Please ignore this wedge. We do not have one with a wedge. This is the only picture I could find that nicely shows kind of the process of applying it. Now, I will say, we get busy as nurses and we just kind of look inside the patient's room and check it off. Prevalon boots are in place, right? Cool. Well, be careful, okay? Because sometimes the heel will migrate where now it's up on the padded portion, and now it's no longer floating. It's no longer offloaded. So make sure you're frequently checking the heel to make sure it's in the hole where it needs to be. Because I don't know for sure, but I have a intuition that some of our heel injuries were caused by this, that the nurses saw the Prevlon boots on, but they didn't actually check where the heel was. Especially if a patient has a little bit of foot drop, they tend to, of course, push on the foot part and their heel will migrate up. There is, if I show you this in person, a way to maneuver the boot to help with foot drop. But when you play with them more on the unit, you'll get a feel for these boots. But these boots are so important. These boots will save a limb for sure. And a lot of time when these patients develop a heel ulcer, they are the people that don't have enough perfusion or the comorbidities, and sometimes we cannot close these wounds and they will potentially lead to amputation. Okay, so the next one, so apply your Prevlon boots. Apply a sacral dressing. I don't think I have that picture anymore. Oh, look at Irene. Okay, so this is a sacral dressing. I'm gonna be flip-flopping, I'm sorry guys, back and forth. Okay, apply a sacral dressing to the sacral area to protect against sacral shear injuries. If we're using it just for prevention, you can leave it on for a week. They're waterproof, so the patient can shower with them on. Now this doesn't say protect from pressure wounds, because what this dressing does is this is a silicone border, so it when the patient scoots down in bed, it slides with that scoot instead of the skin getting stuck and not moving. So this dressing moves with that sliding, shearing component of these injuries. So you apply it on the lower back to the sacrococcygeal area. Sometimes I like to put it upside down. I feel like it maybe fits a little better this way, but you can just play with it. It is a silicone adhesive, so it's very skin friendly. We've not had any type of tears from the adhesive on it. And again, this will only protect from friction shear injury, not pressure. Now, saying this, okay, you have your C. diff patient, you have your incontinence patient, that it's like good luck keeping a dressing on that area for more than 10 minutes. So this is where you want to use your critical nurse thinking, okay? Don't use a dressing. Get a barrier ointment, okay? We have what's called Alavesta stocked in the Omnicell, so you don't need, it's not a medication, you don't need a doctor's order. This is a logistics item. It's stocked in the Omni. So if you have your C. diff incontinence patient that you're not going to be able to keep a dressing to stick, you want to just forget the dressing and grab the Alavesta barrier ointment. The way to use a barrier ointment, which is why I have the picture of the cake, is you want to frost the lower back like a cake. You put it on really thick. So when the patient soils, you only remove the top layer of the Alavesta. You want to avoid cleaning all the way to expose the skin again, because every time we wipe the skin, we're shedding some of the epidermis, and a lot of our patients are geriatric and the skin is thinned there, okay? So we put it on thick, it gets soiled, you only wipe the soil top layer off, and then you reapply another thick layer. And that's truly how you, that's why it's called a barrier ointment, because you're creating a barrier between moisture, between enzymes, and the skin. And a barrier ointment will also reduce the friction shear component. Never use both a barrier ointment underneath that sacral foam dressing, because this dressing is totally occlusive and you'll just have a macerated mess, potentially a stage 2, when you take off the dressing. So it's either one or the other. So you decide what would be best for your patient, okay? Okay, going down to the third one with the Alavesta, all our cleaning products are pump foam, our Perenel wipes, our bath wipes, they're all pH balanced to protect the lipid oil layer of the skin, because our skin's acidic and our soaps are alkaline. So when you use those products together, you damage the skin, but all our products that we have here are pH balanced. Okay, moving on. How to secure an indwelling Foley catheter. I would really advise you to just go into Google and type in Foley securement, and this will pop up and you can read it for free. But back in 2010, the CDC, Center for Medicare, Medicaid, Society of Urological Nurses and Associates, CAUTI, and the WOCN got together and published best practices for where to secure a suprapubic catheter and an indwelling Foley catheter. Why do you want to secure these properly? Well, I have some reasons listed here. It reduces internal trauma to the bladder, bladder neck, and urethra, causing reduction in bladder spasms. So there's two main reasons why you have bladder spasms. One is an infection, and two is a improperly secured indwelling catheter. So you have, of course, at the end of the Foley catheter, this balloon that we pump up, and if there's movement, it's irritating the lining of the bladder, causing these spasms, and then you get leaking of the Foley, so now your skin is wet, and you can't monitor output appropriately because it's leaking. So you always want to look, if you're having that problem, where is the catheter secured? The proper places for a Foley catheter securement is as followed. For an indwelling urinary catheter, secure catheter in the following manner. Suprapubic catheters. All suprapubic catheters need to be secured to the abdominal wall. Why is this? Well, we already talked about the movement of the bladder, okay? But also, if you secure it to the leg, there is a ton of movement where the insertion site is on the abdomen. So you're not securing it properly if you're securing it to the leg, because there's too much movement. It's going to cause erosion of the tract. It's going to introduce germs to the tract, which is going to increase your risk of UTIs. So 100% of the time, a suprapubic catheter is secured to the lower abdomen. You cannot use a leg strap with a suprapubic catheter, okay? It's not best practices. What I showed you is best practices that are published. Okay, so for an indwelling Foley catheter, the preferred site is the lower abdomen, but on a male you can also go to the inner upper thigh. And for females, it's to the upper anterior or inner thigh. Okay, so again, the same reason. You want to reduce the movement of the balloon, irritating the bladder, causing bladder spasms and leaking of the Foley. If you use a leg strap to secure an indwelling Foley, it's going to move. You can never keep a leg strap where you want. So then you're still not eliminating the movement there. Of course, for my service, I'm always looking at what causes pressure injuries. So a Foley that is secured to the lower thigh or the outer thigh, the curvature of the male genitalia is a curvature upward. So if I secure the Foley downwards, the tube is going to be on the posterior aspect, causing injury there. And I can't say the word because I got kicked out last time, but I hope y'all know the area I'm talking about. But we're going to cause a device-related pressure injury to that area due to the tube sitting on this skin. And those who have had experience maybe in spinal cord or a nursing facility may have seen this type of injury where that area is split open down to the base, and that is a device-related injury that is totally avoidable if we secure it upward following the internal and the external anatomy of the male, okay? If I was here, this would all make more sense. So again, just going back to this list, there are just so many reasons. Now, since this has been a hot topic for my service, I may get a consult just to order a specialty bed, but I will see that this patient is admitted for a UTI or urosepsis, and he has a suprapubic or an indwelling Foley catheter. I will go up and see that patient, and I have noticed that none of these patients' devices are secured properly. And I'm not saying that securing a device properly would totally avoid UTI, but there is a big correlation in the research between improperly secured catheters and UTIs, urosepsis. So this is a minor thing, but it's very important and can really affect the outcome of our patients. So Irene has put this nice picture up here. So right here on the lower abdomen is where your suprapubics are gonna go. And then really on the male and the female, go for the inner upper thigh. So I'm talking about groin area, high up and inside. Okay, I'm going to go back to the skin bundle here. Sorry. Okay, so one ultra-absorb pad at a time as needed. So you don't want to put a bunch of absorbent pads underneath the patient, okay, for several reasons. One, all our ICU beds are high-level, low air loss support surfaces, and we do rent those throughout the facility. So the way these air beds work is it has tons of holes pushing air up to the patient to keep the skin cool and dry, and you can only have 3 layers between the surface and the patient. So let's say I use a fitted sheet, and then I have a transfer sheet, and then 1 ultra-absorb pad. That is my 3 layers. If they were wearing pajamas, that would count as a layer, so I may have to eliminate the fitted sheet, the cotton fitted sheet, because I can only have 3 layers. So if I start stacking a bunch of ultra-absorb pads on top of the bed, I've lost my function of this nice, fancy, low air loss support surface. Also, they will start bunching, you can get redness, again, that microclimate, they keep the skin moist and warm, and that's all you need. You still have to turn the patient to clean, so that's our policy, is one ultra-absorb pad underneath the patient. We talked about this earlier, absolutely no briefs while the veteran's in bed. We talked about that affecting the microclimate and some friction, that's how we get our stage 2s. Turn in position every 2 hours using the Sage tap system. I'm sorry we're not together to show you how this system works, but and I can't show you the video, it won't work well, but there is, if you Google just Sage turn in position, there's a really nice video of 2 nurses using it. But what this is, it's this blue with the handles is the transfer glide sheet, and then you have a full-length body absorbent pad, and we stock these independently, so you don't have to open up a new kit every time if you just need a new ultra-absorbent pad. And then there's 2 wedges. You'll see one that has this tail and one that doesn't. So the one with the tail goes right underneath the buttocks on the posterior thigh, and then the one without the tail goes underneath the shoulder. And what that does is it puts a patient in a nice about a 20-degree turn, because we don't want to turn a patient over 30 degrees, or we'll put bony prominences in jeopardy. You'll have like the lateral malleolus, the feet, and the ankle there. So we want to turn patients every 2 hours using the Sage tap system, even if they're on an airbed, even if your airbed has something called turn assist feature. That does not, a turn assist feature on a bed does not turn a patient to offload the sacrum. It is to assist with the turn. You still have to stick wedges or pillows, but preferably these wedges, underneath the patient to offload the sacrum. And when you slide your hand in between those wedges, you will feel that the coccyx is just about an inch above the surface. And that's all you need when you're floating something. I don't need it 6 feet in the air. I just don't need it touching anything. If a patient's on an air surface, make sure you're doing sacral checks. This is a very subjective test, but it's all we have. But an inherited risk of an airbed is just, it's going to lose air. So we have had beds fail on us and patients get injured from the failure. So when you turn a patient, you put their hand under the sacrum. If you can feel the frame of the bed, it's too soft and you want to make adjustments to make it a little bit more firm. On the other side of that, if the patient's floating on top of the surface, that is too firm and you need to soften it up. The rule of thumb is that you want 1/3 of the patient's thigh submerged in the air mattress. That's when you know it's an appropriate firmness, but you still want to perform your sacral hand checks. I also advise to check it when you sit, let's say the patient's going to eat in bed, so he's up at like 45 degrees. Check it at that time too, because some of these air mattresses won't respond to that drastic of a head elevation. And so you just want to make sure that the patient's not sitting on the bar at that time. And then the last one is provide the patient with a Gaymar Striker seat cushion. This is, again, for either stocked in your Omni or you can call your SPD technician to go get you one, but this is already filled with air. And we prefer this design over the donuts because the donut with the hole in the middle actually puts more pressure over the ischial tuberosities. This, being a square, evenly redistributes the pressure to the back of the thighs and the lower back. I use this a lot. I'm also y'all's ostomy nurse, so if my patient had surgery and there's a perianal incision, this just really helps with the pain. If you have a skinny patient, just grab this. They can take it home with them. They can use it on their recliner, you know, kitchen chairs, whatever. You can't put this cushion on an electric scooter because it'll be too high. But a manual wheelchair and pretty much any seat is safe to use this type of cushion. Let me just go back and make sure I covered everything here. I think I did. And I didn't get kicked out this time, woohoo. So again, the skin bundle or nursing interventions, use your critical thinking. You do not need to wait for a doctor to order this for you. These are just really good interventions that you will use to protect the patient's skin from developing a pressure injury. So this last slide here, and I think Irene has put also in your packet for orientation, but this is my email. This is also my partner's email. This is our extension is 14413. Our cell phone is there too. Please don't ever hesitate to call us. We're both, I feel like, very approachable people. I know we're at a weird time in the hospital, but we always welcome and we love it when the nurses that are going to be in the inpatient acute side spend a day with us while you're on orientation. You get a really good idea of doing a good wound assessment, why we choose the topical therapy that we do, how we look at the skin, how we look at things, and it's just a good day just to focus on the skin. So you're more than welcome to spend a day with us. Elizabeth asked, do we need an ND order to initiate a wound care consult from the VADON note? Excellent question, Elizabeth. Yes and no, okay? So anything pressure, we want to be consulted on. So we will take consults from nurses and physician. So even if you suspect it to be pressure, go ahead and put in the consult. Now, if it's a venous stasis wound or a dehisced surgical site, we ask the doctors to put in the consult because this is why. We had a patient several years ago who had a leg wound. The nurse consulted us, the team went with vasculars, there was conflicting orders, so we had to figure out a way not for that to happen again. But I always say, when in doubt, put in a consult, we will review it, and if I discontinue it, I'm gonna tell you why. I'm gonna be like, podiatry saying in this wound, or whatever. I'm not gonna come and yell at you or anything. So I would just say, yes, consult us, and let us investigate it from there. But we do want to know about all pressure injuries. On our consult, there's our cell phone number too. So if you're reporting a hospital-acquired pressure injury, that is the only time we'll accept a stat consult, and you can also call us on our cell phone, but that's all in our consult as well. Any other questions out there?
Hi, Jenny.
Hi, Irene.
Hi, good job. There's
thank
a
you.
little gap, so let's give it a minute for other questions.
Okay. Sure.
I sent out the link to the video so they can view that later.
Okay.
And I also sent out the link to the best practices.
Oh,
When using the Prevalon AirTap patient repositioning system, please keep the following in mind. The Prevalon AirTap is designed to assist with turning, positioning, boosting, and lateral patient transfer while reducing healthcare worker injury risk. Place the glide sheet alongside the patient with the printed arrow pointing toward the head of the bed. Unfold the glide sheet and align the upper edge with the patient's shoulder. Smooth out any wrinkles and raise the bed rails. With the power off, insert the nozzle into the quick connect valve and make sure it is secure. Turn on the air pump and allow the glide sheet to fully inflate. Using the black handles, line up the patient's hips with the hinge point of the bed. Insert the anchor wedge tail first with the black fabric facing up. Place the upper wedge at least one hand width away. Turn the air pump off. If needed, perform a micro-turn to position the patient at the appropriate angle. Check to make sure the patient's sacrum is offloaded. Raise the bed rails. Remove the wedges prior to boosting patients. Turn on the air pump. Once the glide sheet is fully inflated, use the black handles to move the patient to the desired position. Turn the air pump off. The gray extension handles can aid with patient positioning. To perform a lateral transfer, lower the rails between the transfer surfaces. Move the surfaces as close together as possible. Set the receiving surface about an inch below the height of the sending surface. With a caregiver on each side, turn on the air pump and allow the glide sheet to fully inflate. Gently glide the patient to the receiving surface. With one caregiver holding the patient in place, turn the air pump off. When the glide sheet is fully deflated, separate the support surfaces and raise the bed rail. If the microclimate body pad becomes soiled, remove it and replace it with a new one. To remove linens, turn on the air pump. Starting at the head of the bed, lift the corners of the linen. Gently pull toward the foot of the bed while holding the glide sheet in place. Remove the linen and turn off the air pump. To place linens, tuck the bottom corners of the linen beneath the pillow, glide sheet, and the patient's shoulders. Anchor the top corners of the linen. Turn on the air pump. Gently pull the linen down while holding the glide sheet in place. Anchor the bottom corners and turn off the air pump. Smooth out any wrinkles. To learn more about the Prevalon AirTap
Doing a sound check. Can you hear okay? Are we back? Do we get the video? Can you guys hear okay? I do want to show you one more thing. Okay, great. Okay, so all patients, I don't know, like you asked a question, do all patients get it? This is a big facility, so I'm not sure it's on every single unit, and certainly I don't know if it's in every unit that we have just stood up for all this COVID stuff. So I can't answer that question because we've had a lot of transition and change and movement. So that's a little bit difficult to answer. We do stock the turn assist device that Jenny was referencing in the Omnicells, but again, many of these new units have new Omnicells. And so if there's something that you need in an area where you're at, then that would be something that you could ask for. Like ED, I'm not sure ED has that at all. I know they don't have turn assist. So again, when you get on your unit, this is just to give you an idea, an overview, but every unit, and now that we have all these COVID units stood up, and I'm not sure where each of you are gonna go, and be prepared to be floated to other areas, you know, how that's going to look. So don't take me exactly for that. So I do want to show you, hopefully that answered your question without answering your question. I think I should be a politician. All right. So I do want to show you, let me see if there's, okay, so Lisa's here and she said, yeah, here we go. What's an Omnicell? So that the Omnicell is the machine, the device that we use to store your supplies. We call them Omnicells. I don't know what they called them in university or where you were from, but for us it's an Omnicell. All right, so I do want to show you this little, one more thing here before we start our next presentation. Well, maybe not. Actually, I'm not going to do that because she should be here any minute. So I'm going to go upload her slides. Our next speaker is going to talk to you about our respiratory. She's our respiratory hygienist, and she's going to talk to you about our respiratory hygienist program. You're all going to be fit tested on Friday, and the Kerrville nurse, you will be fit tested in Kerrville. There's a fit tester there, and they will. We've already sent your name to them, and they will be reaching out to your nurse manager and you so to make sure you get fit tested. All right, so let's see, hold on one second. Let's get the slides up for our next speaker, and then we'll keep moving along here, okay? Okay, T or Lisa or whoever's online, or did Irene show up there? What's going on? Tania?
No Irene just yet.
Okay, thanks. Thank you for letting me know. So Irene Herrera is our respiratory hygienist. You can see her name on there. There's her phone number. That phone number is not included in your QR code. But while we're waiting, did you guys have any questions on that code, that QR code that you need to use for screening to get in on Monday? Any questions on that? You just scan it. Okay, so T just sent a message, no Irene yet. You just scan that code, it's gonna come up with like 4 questions. It's gonna say you're good to go. Hopefully you've all done that today and you're good. You don't have any questions. You won't need that for Friday. You just tell them you're a new employee and you'll go through the screen. They'll just ask you questions. But on Monday, you will want to have that. All right, we'll give her a few minutes, Lisa. She's usually like running around trying to do 10 things at once. So we'll just give her a few minutes. I'm just gonna check while that's sitting there. We're just gonna check to see if she accepted it. She almost always accepts it. Yep, she accepted it, so. All right, so we're just kind of waiting for our presenter here. So Chris, I'm not sure about the screening process in Kerrville. I don't think that they are using that process. I think they're using a labor pool. And so we use a labor pool also, and the screeners do temperatures only right now. And so they are doing temperatures only, but I'm not sure that they're going through the code, but I would keep it in my back pocket. Yes, this is a daily thing. Every day you have to, so once you get that code on your phone, all you got to do is open the app, go to history, and then it's just going to give you the history. Click the one that you want, which is the VA screener code, and then just re-answer the questions. And then when you get done, it's gonna say, you're okay for today, and it'll give the date. So the screener knows that you did it every day. So every day, and that's every day. That's weekends and holidays, and every shift, that's nights and mids, and you know, everything. Okay, every person who comes in our organization is screened. This is for employees. This didn't go out to our patients. Our patients are screened by a screener at the front door. And again, we have limited access in and out of the facility, so not every door is open, and every door that is open, there's a screener that's being posted there. And again, for Kerrville, for outpatient clinics, if you're in an outpatient clinic and at the Audie Murphy campus, then you are, going through the same process. But if you're working, say, at Frank Tejeda, which I don't think any of you are, or another one of these outpatient clinics, there may be a different process there. So you'll have to discover that. Let's see. Lisa, are you still with us on the YouTube Live? Lisa Hooter, she was with us. So I guess there's no questions on that. I wish I had her cell phone. Yeah, me too. So we're just looking for our speaker right now. Um, so we're trying to find a cell phone so we can reach out to her. So I'm not ignoring you, but let's see. I think you guys are all here with me, but I'm still getting your emails that you're we didn't get the link, but we're all together now. So we're looking for Irene's cell phone number. Hey, Tania, are you there?
Yes, I'm here.
Can you see if Sandra has that cell phone number? She may have it.
Yes.
All right, so it looks like she's on her way. So, hey, we haven't done anything on time today, have we?
Irene,
Yeah.
I already reached her department. She's on her way. She left the department before 10.
Okay. All right, I got it. Thank you. I just had Tania go ask Sandra if she's got it, but
I already talked, yeah, I talked to somebody and they said she left at 5 till 10 for nursing orientation. So she's in between her department
It
and,
looks like she's on her way.
yeah.
So, hey, we haven't done anything on time today, have we? Yeah. We have a delay there, okay?
She's on her way. She
That's what's happening. You have to turn down your YouTube. All right, well, we're just waiting on our speaker, but
Miss
she'll be here
Irene's
any
here.
second. And we'll have you guys going along. We'll stay on time. Yesterday someone said, are we getting overtime? I think we're 4 minutes over. I don't think we'll be over today though, okay?
I promise you I won't be over. Thank you.
I
I'm back.
know, you're always wonderful. Thank you, Irene.
All right, I'm ready to get started. This is my, sorry.
Take over as presenter right on top.
Okay, I'm ready. Get it. Oh, I'm sorry. I'm in charge now, guys, so be careful. Good morning, and on behalf of our safety staff, welcome to South Texas Veterans Healthcare System. My name is Irene Herrera. I'm one of the many fit testers we have here. I'm also the industrial hygienist, which is a fancy name for just a chemical manager. So we're going to start off with the prevention of tuberculosis in the healthcare setting, but I'm also going to put in COVID because that is one of the main topics that we're dealing with here in the healthcare setting. We're going to start off with our objectives. Many of you, because it's been on the news, know the difference between the N95 and a surgical barrier. But again, I will demonstrate that on a PowerPoint, so a picture, so that you can really differentiate the difference between an N95 respirator, which is worn by the user to prevent facial particles, aerosolized particles from their breathing zone. And then a surgical barrier does have some uses, of course, in healthcare, but quite differently from an N95 respirator. We'll go ahead and do the maintenance and the disposal of all of our N95s and when to wear N95 respirators. We've been real lucky in that we were able to buy some CAPRs, which is another fancy name for Maxers or PAPRs, the powered air purifying respirators. And the next thing, which is really important, especially now with our COVID, is our negative airflow rooms. We've been very lucky that we've had several negative airflow rooms going from the 7th floor all the way down to ground level. So that part of our respiratory protection engineering controls has always been really strong because of the importance of isolation monitors, monthly checking, and also daily checking if they were occupied by a TB suspect patient. So N95 respirator fit testing is an annual requirement. It is an OSHA requirement, so South Texas does comply with that. But I do fit test as needed. If you go off and get pregnant, or you get facial hair, for some reason you can't get a seal wearing the N95 respirator, or even if you develop rash or acne, reach out to your supervisor. And then I have no problem coming in on weekends, nights. In fact, I'm coming back at 7:30 to fit test. My job is to keep you all safe. So please let me know if there's anything that I can do to assist with the fit testing of the N95 respirator. A surgical mask or a barrier is quite different from an N95. It's more of a loose fitting device, and all it does is creating a barrier between the mouth and nose of the wearer. We've seen this really often in the OR setting, where the surgeon isn't coughing into the sterile field. We've been seeing a lot more of that with COVID-19, and that we're stressing that people that cannot maintain a 6 feet social distance to please wear a surgical barrier to keep with their coughing and hacking from being aerosolized in the air. Now, the difference with the facial barrier is it's very loose fitting. You don't get a seal. There's a chance for leakage on the sides, and I notice a lot of people who wear glasses and so forth are complaining about the surgical barriers kind of fogging up their glasses, and that's because there is leakage involved. And to me, this picture here just nails it. You can see a person who's coughing and hacking, and that's what we're trying to prevent with a surgical barrier. We've been really lucky that we've had a very, very strong infection prevention practice in place for many years, and that was due, of course, for TB and also our immune compromised patients. So if anyone came in hacking and coughing in our clinics, like 1C, the IMC clinic, even Frank Tejeda or Chavano Park, our other outpatient clinics, people were empowered to hand a surgical barrier to someone who was coughing and hacking, and they would say, could you please put this on? We're not sure exactly what you have, but you're coughing and you're sitting in the emergency room in close proximity, and so we want to make sure that we keep not only you safe, but your fellow veterans. And about 20 years ago, we used to get pushback from our veterans. They would say, hey, what's wrong with me that you're making me wear a surgical barrier and so forth. But as of course, COVID has changed a lot of these practices, and people are more willing to put on a surgical barrier because they understand the importance of keeping with their hacking and coughing from being aerosolized. So a lot of changes with COVID. For our TB program, when we had a patient come in, we would mask the patient like we did with COVID, and when the patient had a visitor come into their room, we asked them also to wear a surgical barrier. We do not fit test patients or visitors with the N95 respirator, and that's because the N95 respirator does put a big strain on the cardiopulmonary system, which is why you were medically evaluated during your orientation with occupational health clinic. Again, an N95 respirator is not a surgical mask. It's designed to have a very close spatial fit, and it's filtering out at 95% a tiny aerosolized particle like SARS, anthrax, COVID, TB, anything that's a particle. It is not a purifying respirator, so you cannot use these respirators. I'm sorry. It cannot be used to purify, like something like hydrochloric acid or chlorine gas or sulfuric acid, bleach, anything that's in the air. It's not an organic respirator, but it is a particle respirator. So it's designed to trap a tiny particle floating in the air and so forth. And that's what N95 means, because 95% of what you're breathing through is going to a filter matrix. All our N95 must meet the NIOSH and OSHA standard. We're trying our very best, even at this time during our shortage, our PPE shortage, to only obtain approved N95 respirators, not just for TB control, but also for COVID. There are a number of respirators coming from foreign countries. I think you've all seen the KN95. I tried to test someone who brought one in, and he failed. That means he wasn't getting a good seal. So we trying our very best to only get approved respirators. And this picture here, you can see this is a surgical barrier. You can see how very loose fitting it is. But there is a range. I mean, it will filter out particles, but not as efficiently and as effectively as an N95 respirator will. You see these tiny particles floating around through the air like SARS, anthrax, TB. It'll filter here. One of the things I keep getting from the staff is, they can smell things. Well, you are going to smell things because it's designed to trap a particle and not filter out odors and so forth. So it's, saccharin, anthrax, TB, COVID, zombie virus, pig virus, anything. This is what this is designed to do. And you can see here, that's why they're called N95 respirators, because they filter out at a much tighter range, this little tiny particle floating around in the air. I can talk as much as I want. I think this picture nails it. This is a coal miner, and like coal mine dust, can be easily aerosolized into the atmosphere, and it stays suspended in the air like droplet particles. And you can see how well this fits. I mean, you've got the double strap here. That's always very important with our N95 respirators. Currently, they have to have a double strap. They work in tandem. See how well it fits underneath the chin and here up in the nose area. And very important that he is clean shaven. That's another thing. A lot of our staff will grow a beard, and then when I come by and test them, they will shave it off and so forth. But as this COVID thing has come out, we've had more people shaving and so forth. So again, I'm available to fit test you as needed. We wear N95 respirators primarily before for TB control, then also now, of course, it's for COVID, but it was also used for things like chicken pox and measles and so forth. Again, these N95 respirators, because they're very good at filtering out a tiny particle, could be used for flu and all kinds of items. They are all kinds of other airborne infectious diseases. They also could be worn for Ebola if you wore extra PPE on them. Airborne precautions, of course, with COVID, you're going to have more signage on the door. You're going to have to wear an N95 respirator. On top of that, you're going to have to wear a facial shield. At this facility, we want you to wear a full face shield along with your N95 respirator and your 2 pair of gloves and your impervious gown. For TB, they have the signage would be posted, and again with COVID, we'll have signage posted and you'll be wearing an N95 respirator. It'll tell you exactly what kind of personal protective equipment you need. The nursing staff, of course, is responsible for posting the signage and removing the signage. Just to give you an example of the number of confirmed TB cases we've had over the fiscal year starting from 2007, and this is 6, so this is the highest level we had with 6 cases in FY18. FY17, we didn't have any cases of TB, and last year we only had 2. So you can see before COVID, we had very little infectious airborne diseases, and we were really doing a good job of managing it, putting our patients that came in coughing and hacking in the clinics. Staff would immediately hand them a surgical barrier, explain to them the purpose of the surgical barrier. From there, they could be put in a negative isolation room. Frank Tejeda and our various clinics like Chavano Park, North Central, all had negative airflow rooms that we could isolate a patient if necessary. And then over here, if we needed to transport them, we would put them in a negative isolation room. And what that means is that there's many more air changes to that room. It could be anywhere from 6 to 8 air changes per hour. Because remember, you have a particle, an infectious particle like COVID or TB floating around in the room. You don't want it to stay suspended in the air, because when someone opens the door to the patient care room, it could go out into the hallway. So that's why we have the door closed. We have them under negative pressure so that the air particles can get sucked through the ventilation, go through a HEPA filter, and then sucked out into the environment where direct sunlight kills TB within 5 minutes and so forth. So that was the purpose of having these negative airflow rooms, is to make sure that we dilute the particle that's floating around the air. And that's the same concept that we're using for COVID. You know, instead of having a negative isolation room because we've been overrun, we have made the units negative so that we can maintain that whole area negative so employees can go in there with their PPE and so forth. Again, this is just another demonstration of how negative airflow works. We want the dirty air contained in the room and not enter in the hallway. When we have inspectors come by, they will ask the staff, how do you know this room is negative? You can use the tissue paper test. We also have some smoke powder that you can test it, you know, for another visual inspection. The nurse managers, I handed it out to the nurse manager. So that's just another visual way of knowing that your negative isolation rooms are working. Real important, especially now with COVID, because if there's no negative airflow, there's a chance that the COVID can flow out of that area and infect people that are walking around in a green zone or an area that we have not designated as a hot zone. And so therefore they weren't wearing their PPE and so forth. These rooms are so important that we have isolation monitors attached right next door to the room, letting us know if the airflow is working properly. Our engineering staff check it once a month to make sure that they're still under negative flow. But the nurses, you know, they check for fan belts because these rooms are under such stress with the mechanical HVAC system that sometimes the belts break. So that's why they put an isolation monitor. We have various brands, but this one here that I'm hovering over will be the main brand, and it will be hardwired to our engineering staff so that you'll be able to get an email text to the nurse managers, to the staff, knowing that the negative airflow has been compromised. And green is good. When it goes into red, that's when we have issues. Please, I always tell our auxiliary or support staff, like nutrition and food service, pharmacists, and other support staff, that if they're walking by the area and they hear the alarm, to alert the nursing staff. You know, we're all in this together. We don't want negative dirty, contaminated air, infectious contaminated air to go into the hallway, which is why we maintain negative airflow. These respirators, because 95% of what you're breathing is going through a filter matrix, does put a strain on your cardio and pulmonary system. So we do have medical evaluations. If anything you change with your health within the year, like you get pregnant, maybe you develop asthma, emphysema, please let your supervisor know, because we may have to find a different type of respirator for you, or maybe even put you in a PAPR. There are options. This happened several years ago. We had a nutrition and food service employee. They're enrolled in the program because they go into these negative isolation rooms to to deliver trays. And he lost part of his lung. Nothing that we did. What happened was he was a smoker, so he lost part of his lungs. And trying to put an N95 respirator was so detrimental to him that he almost passed out from wearing it. And the nursing staff called me and said, hey, I think you need to look at this gentleman. He almost passed out from wearing the N95. So we were able to work with the staff and pull him from that unit and give him another job so he didn't have to go into these negative isolation rooms to deliver trays. And that's something we all can work together and help each other out. We just don't fire people. There's always an option. Please work with me. Now, that slide I showed you about how many cases of TB we have, what we have a lot of is actual rule-out TBs. So when someone shows up coughing and hacking onto the units, coughing up blood, night sweats, the typical symptoms of TB, they will isolate them in a negative airflow room until we can rule them out. And usually those patients don't have TB, because you saw that we don't have that much TB here. They'll have things like lung cancer, emphysema, asthma, some other lung ailment. But in the interim, rather than expose all the staff to TB without having a surgical barrier, or even putting them in a negative airflow room, or even using the right precautions, we will err on the side of caution, put that patient in there, and then find out later, oh, he didn't have TB. When I first started working in the healthcare industry, we had many of our employees who were exposed to TB. Come in. Sorry, I'm in a comp. Hold on. Hold on. Just someone's trying to come in. Sorry. So, I forgot what we were talking about. It'll come to me in a minute. How you doing? So our N95 respirators are stored in there. Sorry, let me put on my mask. The N95 respirators are stored in the cabinets, but at this time, due to our supply shortage, the N95 respirators will be handed out by the nurse managers or your supervisors. We have several respirators, but before COVID, our two main respirators were the 3M 1870, which is a one size fits most, and the Kimberly-Clark, both size small and regular. Tomorrow, I will bring all 4 different types of respirators to see which one fits you most appropriately. This is the N95 respirator. I like this one. This is our primary one because it's individually wrapped, and it's got some perforations right up here at the top, so your glasses will fit a little bit better, so you don't have all the fogging. You better not have too much fogging on that. And I like underneath that they have a little tab so you can pull it down underneath the chin. Again, this N95 respirator does meet the OSHA CDC guidelines for TB exposure. And don't worry about this. Tomorrow we'll walk through how to wear it properly. I will fit test you tomorrow. This is a Kimberly-Clark. If those of you that were in the service are really familiar with this one, our military really likes the Kimberly-Clark that comes both in a regular and a small. All our respirators are latex free, but again, if you have any issues with acne or rash on the face, please reach out to me. Like I said, we can find another type of respirator to fit test you with, or if I have to, I may have to put on a PAPR on you. So this is the fit checking process, which is really, really important. Tomorrow we'll walk through the fit testing process again, and to make sure that you get a really good feel when you're going into the COVID unit or dealing with a TB suspect patient. We will go through the fit testing protocols. I do this annual thereafter, and we'll be looking for facial scarring. If any of this happens, you have cosmetic surgery, you have maybe 4 or 5 teeth removed, you have significant loss in body weight, like maybe 20 pounds, let me know, or even less than that. I have no problem coming by to fit test you as needed. That's my job. I want to make sure that you guys are safe and have the proper PPE. For right now, we are going to be reusing our N95 respirators, but what I mean by reusing is that we are going to put it in a paper bag and put it in the, that's for TB. For COVID, we're going to write our names. The nurse manager on your area will walk you through on how to properly identify your respirator with your STV, your location where you are, and a code and we are going to reprocess these N95 respirators. We are concerned, currently we have enough N95 respirators, but we're not sure what's going to happen in October, November, December. So we're getting ready. We're sending these respirators off to be reprocessed using a hydrogen peroxide system used by Battelle. This is an FDA emergency authorized use of the hydrogen peroxide. These respirators will be stocked and held at a climate control building in Kerrville. And as we dwindle through our primary stock of N95 respirators, then we will send your reprocessed N95 respirator back to you. If you properly mark your respirator, that respirator will come back to you, so you won't have to wear someone else's N95 respirator. This hydrogen peroxide sterilization is currently being used in SPS to sterilize our medical equipment, such as, the surgical instrumentation, but it has not been formally approved, but it did receive an emergency authorization use during COVID. But again, we are trying our very best to get N95 respirators to you guys. Facial hair. The Max Airs or the cappers, we have been using these for at least 10 to 15 years. I noticed that some of our males, they like to wear beards, especially those who have retired from the military. There's also other healthcare providers who cannot wear an N95 due to medical condition like a shortness of breath, maybe anxiety, emphysema. And so I had to look at alternatives. It's not fair to just send in the same people into a negative isolation room if there are alternatives. And one of the big things that we had was the facial hair or pappers that can be worn with facial hair. They're battery operated, and I'm going to show you the one we have here. This here is the N95, or the filtration process is here on top of the helmet. So dirty contaminated air like COVID, SARS, anthrax, TB, Ebola comes in through here. Now for the Ebola, we would change it to a double shroud, but for right now, we don't need a double shroud for COVID. And you see there's the facial shield. So we do have these on the units. I'm sorry to say, due to supply lines, we don't have any more small shields, and I'm really sorry. I really like these. We worked very hard to get them for you, but unfortunately, the facial shield size small are on back order. These are great for those who are doing one-on-one observation. About 15, maybe 20 years ago, I think it was during SARS or MERS or H1N1. I don't even remember. I've been here like forever, guys. I came in and one of the staff members coming out of a negative isolation room, and she was wearing a gown and an N95 respirator and gloves. So she was sitting in a TV isolation doing a one-to-one on one of the patients. And I said, when she came out, I said, oh my God, I thought she was going to pass out. I said, are you okay? What's going on? And she said, Irene, I'm doing one-to-one on there and I have to wear my N95 respirator. I said, oh my God, that's horrible. What can I do for you? So I started researching and that's where this Max Air came in. At that time, we had those huge 3 Aramates that you saw being used for Ebola, so we bought those. And then this is another generation of powered air purifying respirators that came out, and we were lucky enough to get a whole lot of them. And our nurses had been using them on the units. Some of the units liked them a lot more than other units. And my goal was to issue 3 per anteroom so that you could have readily access to a PAPR. Let's say you came in and for some reason you fell down and have a huge bruise on your face and you don't think the N95 respirator is going to, seal properly. You can grab a PAPR or someone. I've missed fit testing you for some reason. I haven't been able to get to you. You can put on a PAPR. They're very easy. No fit testing is required and so forth. So a lot of the staff like them, and I'm hoping that we can open up our supply chain. And I'm sorry to say that I think COVID is going to be changing our stance of personal protective equipment. When I told you I've been here forever, I'm not kidding. I started 33 years ago when I was 12, working in here at Audiel Murphy. And when I first started 33 years ago, we didn't have to wear gloves when we dealt with blood and bodily fluids. And of course, we had the AIDS come along and HIV. And I remember just like with the N95 respirator, when I first started fit testing almost 24 years ago with the N95, people complaining, oh, the respirator, it's difficult, messes up my makeup, my hair. Same thing with the gloves. We had the gloves, oh, my hands itch, I can't properly insert IV, I can't find the veins, I can't do this, I got a needle stick. There's always going to be a learning curve. Just work with us. Reach out to me. If you're coming from another facility that did something better with the N95 respirators or want to make a suggestion, I have no problem contact me. Reach out to me or reach out to your supervisor. We're all really in this fight together, and it's sad, and I'm kind of hurt by all that's going on, but we're going to get through this, I promise you. The other thing that had happened is I did provide each clinic, I think there's someone from Victoria on here, but each of the clinic, like North Central, Chavano, Victoria, South Bear, were provided 2 Max Airs, but due to the emergency here at Audie Murphy with the high increased numbers of COVID patients, we pulled all the Max Airs back. Once this is settled down, you will get your Max Airs back. Because again, this is going to happen again. We're going to have another high consequence infectious disease outbreak again. I remember in 2015 and 2014, after all this, we sat down and we're discussing what personal protective equipment we could get for the staff for the next time we had a pandemic. And so still out there. Thanks. All right, the next one, and this is the various components. This is here, the filters. You can see I've only had to change 4 of those Max Airs since March, since we've deployed them. I've been managing them for the staff because I know you all are very busy, so that's why we've been helping you guys out. Just turn them into me and I figure out what's wrong with them. And this is what a Max Air looks like. This whole shield can come off. This will come off and we'll put a double shroud on it. And then it's available for Ebola or other of those high consequence infectious disease that are also bodily splashes. I know I got a couple of questions, so I'm going to try and answer those. So let me go through here. Hold on. Let me see.
Do you see them, Irene? They're just marked.
Yeah, how many negative pressure rooms? We have well over 36 at Audie Murphy, and the clinics all each have a negative isolation room. Frank Tejeda, I believe, has 2. North Central has 1. So yes, negative isolation rooms are very important to us, and you can see how important it was for COVID, because remember, someone is coughing and hacking, or they have an airborne infectious disease, you don't want it floating down in the hallway. So the areas that have a negative airflow rooms, they will turn the alarm off, especially here on the units, because we use these rooms for other things and we want to prop the room open. So in the event that we have to use it for a negative airflow room, they'll turn on the alarms, and the nurses have the key code to activate the alarms.
So Irene, I think the question was, how are we making these units negative pressure?
Oh, okay. Well, we already have them. We have those 36 rooms. They were already under negative airflow rooms. So what they have is more air being sectioned out, ventilated out through a HEPA filter. Now, for the COVID units, we set up HEPA air units to make these rooms negative. So it involved a lot of engineering controls in place. And what they did was shut off some of the exhaust to make sure the room had more air coming out, and shut off some of the vents, and it's exhausted outside and it goes through a HEPA filter. We make sure that the air that's exhausted outside does not come in through a return air vent. So I can tell you our engineers worked very hard on setting up the negative isolation COVID sections up on the 6th floor, 5th floor, and 4th floor, and other areas. It's a really tightly controlled process. So we make sure they check those rooms periodically to make sure they're under negative airflow. Question from Victoria about reprocessing. We will be setting up a reprocessing site, and instructions will be sent to Victoria. We'll make sure that all happens. Things are moving so very quickly. We'll make sure Victoria gets that. And what happens at Victoria, the same thing too, you will label your N95 respirator and make sure it's clearly labeled. And there is instructions I can I'll send those instructions to Irene, if that's okay, Irene. And we can hand those out and make sure that we've had training here for the nurse managers. And of course, Victoria will make sure that Victoria gets the information they need. I know who to reach out. It's Stacy Clark, and the other lady's name just completely flew out of my mind. But yes, I'll make sure they get that information. And what happens is you have to make sure that these N95 reprocessed respirators, before they get reprocessed and you're disposable, they have to be in a dirty isolation room, because remember, they're coming from a COVID area, and so you would put them in an isolation room. Now, at Kerrville, you're not seeing COVID patients, but if you're wearing the N95 respirator for other things, then I still want them to go in a negative isolation room, and I mean a negative dirty room. They get collected, they get sent here to San Antonio, and then from San Antonio we can send them to Battelle, and then we'll send them back to, again, we'll send them to Kerrville, and we will hold on to them until we run out of respirators, and then we will push these out. Right now, we're only going to try and reprocess them 2 times. Over at the Battelle, usually can reprocess them 20 times, and I know other facilities who have gone through their stock of respirators, and they've had to reprocess their respirator at least 5 or 6 times, and we're really trying to avoid all of that.
Right. So as of right now, we are not using reprocessed N95s, but we are reprocessing them.
Yes, we are. We're getting ready because, again, we don't know what our supply line will be like in November or December.
Okay. All right. Any other questions out there? Let's see. So Chris, who asked about how are we doing it here, he said in Spokane they boarded windows and cut holes with exhaust fans. Unfortunately, they used wood, so the patients had no daylight. For reference. Mm-hmm. He's just saying how they did it there.
Yeah, thanks a lot. Yeah, we every facility did it a little differently, and I have nothing but the utmost respect, and our people who did our rooms did an excellent job. And this is the reason why is because they've done negative airflow for other areas. It wasn't something like, oh my God, let's just read up on this. Our negative airflow team, let me back up to that. We have an asbestos crew, and part of the asbestos crew requirements is anytime they go in a room to remove asbestos-containing material, that room has to be under negative airflow. So they've had, gosh, I've been the asbestos crew, been here 20, 30 years, so they've always set up negative airflow. So they're very, and they're very strict criteria for setting up containment in an asbestos area. So our guys it's second nature for them because, like I said, we have so much. We're an old facility, 1975, so there's asbestos still contained in the area. We've had an asbestos survey, so we know where that is. So before they come to work, they check to make sure, and then they proceed on setting up negative containment because asbestos is aerosolized too, so they got to make sure that it doesn't go into the hallway. So our guys had already had a lot of experience setting up negative airflow, and in addition to that, to give you some reference point. In OR, all our rooms are a positive pressure, right? Because when you're having someone crack open your chest, you don't want dirty air going in the room. So the air is filtered before it goes in. And in that room, and in that situation, when your chest is cracked open, you don't want the dirty air coming in. You want clean air being pushed out into the OR cores. Well, we had a TB patient here who had to have emergency surgery, and he just refused to have his last third clearance of TB. I mean, we were pretty sure he didn't have it, but our policy says they have to have the 3 sputum clearances. And so he refused. So everyone tried, police officers, chaplains, social workers, begging, and he refused. So our asbestos crew had to set up one of the rooms as a negative airflow in OR. And if you can imagine how crazy that was. They had a tonneau built. Again, they had the negative airflow machines put in. So again, I have nothing but the utmost confidence in our asbestos crew and our engineers who designed these negative airflow rooms.
Okay, thank you, Irene. We're good.
Can I ask you one more question, Irene?
Yes, ma'am.
I have 2 pharmacy new employees that are coming that need to be fit tested. Can they come in tomorrow to one of the classes?
Yes. Yeah, bring
Okay,
them in, if you don't mind, bring them in at the 12:30 session.
Yes, ma'am. Thank you so much. I appreciate it. Again,
Yeah.
welcome aboard. See you tomorrow.
Okay, thank you. Bye, Irene.
Bye, ma'am.
Okay, so just a few other things since we're kind of on this topic, and then we're going to have a break, okay? So, one, I've had two questions, so I just want everything to be out in the open. One, our campus, on our campus, you're required to have a mask, some type of barrier over your face anytime you're on campus, unless you're in an office with the door closed and you're alone. So if you are at lunch, we need to try to schedule lunches individually. You can't be all in the same room. If you're working in an office with another person, you have to have a surgical mask on. And so when you enter our building, there are long lines to get in the building. You have to have a facial barrier, not a surgical mask. Any kind of mask you've been wearing to go to HEB or to go anywhere, you know you have to have a mask. It's the same in our facility. So please bring your mask that you have been wearing to walk into the facility. And that includes on Monday when you're walking into work, okay? Now, if you work in a patient care area, when you get to that patient care area, they are going to give you a surgical mask and a face shield. Everybody who is encountering patients has to wear both, whether it is a patient, a COVID patient or not. You have to wear a mask and a face shield, okay? If you work in a COVID unit, you will be given that unit's level of PPE that they're using. So if it's an N95 and a face shield, or if it's one of these Max Airs that you see on the screen, they will outfit you when you get to that unit. And we also, because we are very serious about safety, you will have a safety partner with you who will be ensuring that you have both put on your safety equipment correctly, your PPE, and taken it off correctly and safely without exposing yourself. So we have taken this very seriously, and everybody who is putting on this level of PPE is doing it with a partner or a buddy so that they can be safe. Now, the other question that came up was, if I'm answering these screening questions and I work on a COVID unit, how do I answer the question? And so Lisa reached out to our infectionist preventionist, and she has told us that the question really relates to the idea if you are in unprotected exposure. So the answer is no to the question unless you're exposed outside of work or due to interaction with a COVID coworker when your mask or PPE were not being worn, okay? So if you are fully protected and you know you're in a COVID unit and you have all your PPE on, the answer is no. But unless, say, for example, Mary was at work last week and you and her were talking and neither one of you had a mask on, and she called in sick, or yesterday, and she called in sick and she said, or she called you because she was your friend and said, I just tested positive for COVID, then the answer is yes, okay? Does that make sense? All right. So let's see, any other questions that came up here? Let's see. All right. So let's take a break. Our next speaker comes at 11. This is always a really fun topic. You guys should be very engaged. This is how you get promoted. This is how you were boarded. So this is how you get paid more, and that's why you're here. You want to know, how do I get promoted and get paid more? And what does the clinical audit look like? So come on back, be here at 11. I'm in the chat box if you have other questions that I can answer for you. I hope I've answered all your questions or seen all of them that have come through. So let's see. So we are on break until 11 o'clock, okay? Eggs, not F's. All right, guys, let's just do a little check here, make sure that we're all back and that you can hear. So if you can just let me know that you can hear. All right, and we'll be getting started again. Let's just do a hearing check. We'll be starting in just a few minutes. We're waiting for another speaker. Can you guys hear me? Okay, all I need is one. I can hear. Okay. All right, it looks like our speaker is here. So he's just coming online now. Hi, Daryl, when you get online.
Good morning, I am here. Sorry I'm a little bit late.
No, you're not late. You're just perfectly on time.
Very good.
All right, so hopefully where everyone's getting back from their break. We had a little break, and as we've done every other time, try to hold your questions to the end, and I will share them with Daryl, and he will answer them online. So I will be typing those questions in the chat box for you, Daryl, as they come across, okay?
Very good.
So I will let you take over as presenter, and you are on your own, okay?
Alrighty, here we go.
Oh, one more thing.
Yes.
Just so you know who you're talking to. You have RNs, LVNs, and a health tech, okay?
Very good. That's going to help me in the backside of the presentation.
Good. All right. Bye now.
Okay. Good morning, everyone. My name is Daryl Reed. I am the informatics nurse for the South Texas Veterans Healthcare System. I also serve as the chair for the Nurse Professional Standards Board here in South Texas. Also, I am the consultant for the Nurse Professional Standards Board for all of Visit 17. Additionally, I serve as a member of the Central Office, VA Central Office Nurse Professional Standards Board. Today, my presentation is going to be talking to you about the Nurse Professional Standards Board. Essentially, it's going to be looking at what your proficiency is and how you can be an active participant in preparing your proficiency on a yearly basis, and in the same vein, take care of your career. So let's start by going over what the NPSB is. The NPSB is a local all-RN peer-reviewed body. We did have boards for LVNs and for CNAs and techs, but right now nationally they are undergoing a restructuring. So those boards for the time being has disbanded, while national comes up with what they want this new entity to look like. But the RN board still continues on. As we serve as members of the board, we don't work for South Texas. We don't serve for South Texas, even though we work at South Texas. Our commission, our appointment is via central office in Washington, D.C. So when the boards meet, that is who we represent. Every single proficiency that is produced on nurses within South Texas, we read every single one of them. So there are, goodness me, 500 to 700 nurses within South Texas. That's how many proficiencies that the board reads. We facilitate all the processes in South Texas. All the Nurse 1, Nurse 2, and Nurse 3 actions. That means promotions. Every year your proficiency is done. It comes before the board, and we read it to see if you meet all the criteria that is set forth for promotion. We do all of the appointments for all of the new employees. Every single one of you had your packet reviewed by the Nurse Professional Standards Board, and we made that determination on what your recommended grade and step would be. In addition to all of that, we do probationary reviews. Every single new employee for the United States government automatically gets a 2-year probationary period. At the end of your first year, while we do the proficiency review, I will typically, as chair, ask the question, is this person a keeper? You really want that answer to be yes. That means that you've learned how to play nicely with all the other children in the sandbox. You're getting along well. You're doing your job, and you're performing the way that you were hired to perform. And so you will continue to keep your job. If for whatever reason the answer to the question of is this person a keeper is no, or some other issue comes up and your supervisory chain decides, no, this person's just not working out, they will make a recommendation for you to go through what's called a summary review. A summary review is a way that we look at the performance and behavior of probationary period employees and make a recommendation whether or not that person gets to keep their job or not. And remember, as probationary employees for summary review, because you are probationary, a conditional employment for that first 2 years, you can potentially be let go for any reason whatsoever. Those are the functions of the NPSB. So you're probably asking right about now, exactly what does all of this have to do with me? The answer to that question would be everything. Let's start with your proficiency. Your proficiency is really just your annual performance evaluation. Everybody gets a performance evaluation every single year. It is supposed to be written with input from you. The one who has the responsibility to write it would be your manager, but they're supposed to be soliciting input from you. The proficiency addresses dimensions of practice, and it puts everything in a narrative format that is reviewed by the Nurse Professional Standards Board. And we look at that again for promotion. As we review each dimension and criteria, and I'll have a slide in just a few minutes that will go over what each and every one of those dimensions and criteria are, we look to see that each and every one of those are addressed and that they include at least one extremely specific example. As we look for each of those areas, we ask and look for what was done. What did you do? What was the action that you took? We look at who did you do it for? That would be the population that was serviced by whatever it was that you were doing. The biggest question that we look to have answered is, what difference did it make? We look for outcomes. To me, the question I'm asking is, as I'm reading the proficiency, I'm asking, so what? The outcome is really answering that so what question. What difference did what you did make, either to you as a professional, to your unit, for the hospital as an organization, to the region, or perhaps to the VA on the national level? And when did you do it? Is what you did a one-off deal? There was a minor problem, you fix it, and it'll never happen again? Or is this something that is going to carry on long past what the problem area, whatever it was that you decided that you needed to do? And this is talking about sustainability. Those are the areas that we look at. So here's some things for you as new employees that you need to keep in mind as you prepare to launch off into your VA career. I would tell you that beginning today, you begin collecting information about the things that you do, the committees that you serve on, things that you've been asked to do, classes that you take to enhance and improve your performance as a nurse or whatever job you're doing. Keep a record of it. You need to keep that information in a place that's easily accessible. What my recommendation is when you get your computer access, everybody will have a U drive. That's for a user drive. Within that user drive, you create a folder that's labeled proficiency. Within that proficiency folder, you write every year down. And for that year, you have a Word document. Every time you do something, you go to that Word document and you make a note of it within that document. What will happen is at the end of your rating cycle, at the end of your year, when your nurse manager asks you for input into your proficiency, you can just go and either email that document to them or print it out and give it to them. That way you have the information readily available, and you don't have to try to sit back and try to remember everything that you've done in the past year. Because if you're anything like me, you don't even remember what you had for breakfast this morning, let alone what you did a year ago. This is what you need to do. I'd highly, highly recommend it. I'm one that I have been doing this for many, many years. I can go back at least 10 to 15 years, and I've got that many folders for my proficiency with input into my proficiency for every year. The other thing that you need to do within that folder is keep a copy of your functional statement. That's extremely important because your functional statement tells exactly what is the scope of your job. Sometimes people get upset that they say I do all these great and wonderful things, but it's not reflected in the proficiency. Well, if you have your functional statement, it lays out what's your job and what's above and beyond. So have a copy of that so you'll know what the minimum expectations are of you in performance of your duties. Also, you need to meet with your manager on a regular basis for feedback and formulating goals. Let's say you want to go back to school. You want to go and get a certification, or you want to go back and get your associate's degree or your BSN for nursing, or you want to do something else. You want to serve on a hospital level committee, or you have an idea for an improvement within your unit or your section. You should work those ideas through your manager, because your manager has the broad scope of the things that need to be done, and they can be your entree into those areas where you wish to work. All I'm saying here is that you really should make your manager your partner, because they can help you to attain the goals that you set for yourself and that you set in conjunction with them. Now, earlier we talked about the dimensions and criteria of nursing, and this is what they are. There are 4 dimensions and 9 criteria. When your proficiency is written, each and every one of these areas must be addressed. In order to be promoted, every one of these areas has to be successfully addressed. So this is what it looks like. When I'm chairing the boards and your proficiency comes before me, I have a worksheet that has check boxes on one side, and on the other side it lists out all the dimensions and criteria. And as I'm reading, or as someone is reading your proficiency, I'm making notes and checking off boxes. And the promotion process within the VA is quite simple. If at the end of reading your proficiency, all of those boxes on my worksheet are checked off, every single one, congratulations, we're going to recommend you for a promotion. Conversely, if even one of those boxes is unchecked, it is a non-promote. So this system is either go, no go, pass, fail. There is no ifs, ands, or buts about it. But the good thing about it is if you don't get promoted, there is a system in place for you that you can do an appeal, what we call a reconsideration. And this is the important piece. What happens after the initial reading, if you get a non-promote, there is a memo that is issued and should come through your management to you. Your manager is supposed to bring you in, sit down, and go over this memo with you. They are to have you sign that memo. Your signature on that memo, or even the lack thereof, is an important part, because that starts a 30-day clock. What you have is 30 days to decide whether you want to file for that reconsideration or appeal of your non-promote status. You have 30 days to get the information together and resubmit it back to the board for review. Now, the good thing in the reconsideration piece is whatever areas of the dimension and criteria that you've already passed, we're not going to look at those areas. We're only going to look at the areas where you have not met. Additionally, you have the opportunity to add more information. Let's say you didn't do a good job of explaining what you were doing. You can put more information, or you can even add brand new information that wasn't in consideration before. The board will get that information, they will read it over, and again make the decision whether you have met the rest of the dimensions or criteria. If you did, then again, there will be a promotion for you because you've met all the dimensions and criteria. If not, you will be issued another memo of non-promotion. That's not the end, however. At that point, your manager should go over that second memo with you, and you have another decision to make. That decision is, do you wish to have another and final appeal that will go to central office in Washington, D.C.? You have 30 to 45 days to get a packet put together to be submitted to Washington, D.C. You cannot add any further information to that packet. That will go to Washington. The board in Washington will look at it, and they will render a decision. Whether that decision is is promote or non-promote, that decision is final. There is no further appeal. Now, based on that, I think for me, as a testament to how good a job that we do here in South Texas in reviewing and being fair in the promotion process, we have never had a decision of non-promote overturned at the central office level. Every time that we've had someone appeal the central office, they have upheld our decision. So, but that is your right to be able to do that. Now, as far as career paths, back in the days when the dinosaurs roamed the earth and I first started working at the VA, there was only a select few areas that a nurse could actually work. They could be at the bedside taking care of patients or at the clinic taking care of patients, and their highest aspiration would be to be a manager. But in order to get that, you had to wait until somebody either retired or died, and then you could apply for those positions. In the intervening years, the careers paths for nurses within the VA has exploded. Now you can decide which of the 4 different career paths you wish to operate in. You can decide, I want to stay in the clinical arena and stay at the bedside, taking care of patients, being a direct care nurse. Or you can decide, I want to go back to school and get my degree and become a clinical nurse leader and direct education and training for nurses at the bedside. You can decide, I want to go back and get my degree and become an advanced practice nurse, a clinical nurse specialist, or a nurse practitioner. Perhaps you want to go into leadership, become a manager or some supervisor, or even go into executive leadership and try to become a nurse executive for a hospital system. Or you could do like I did and go into the consultants track, quality management, recruiting, infection control, education, or in my area of specialization in informatics. You get to choose where you want to practice. Now, the good thing to remember is it does not matter which career field you decide you want to practice in as a nurse within the VA. The dimensions and criteria that we just saw 2 slides ago are the same no matter what area of practice you decide to go into. The difference is based on what area of practice you're in, your proficiency will be written tailored to the job that you do. And we have people that represent every single career field on the board. So there's no problem of maybe they don't understand my job. But we have people on the board that understand your job and can help in rendering decision whether you've met all the dimensions or criteria or not. Okay. The VA career ladder. This was something I thought was very interesting because, again, this was something of several years back was not very clear. In fact, as I was in grad school, one of the papers that I wrote was how the VA lacked a career ladder. This now is something that in the intervening years the VA has developed and put out. And it really follows the progress of growth and development and the gaining of knowledge and expertise as a nurse. So as you gain in knowledge and expertise as a nurse, you climb up this ladder. So for instance, as a nurse 1, that's pretty much a nurse that's just graduated from school and they're learning how to be a nurse. So you progress through the levels. Once you get up to that nurse 2, you've been a nurse for a while, perhaps between 2 to 5 years, and you know what to do. It's not we're trying to figure out how to be a nurse. Now we're working together. When you get up to that nurse 3 level, then you are what we consider an expert nurse. You're working at a higher level. You're making decisions and working on things that affect not just the area that you work in, but perhaps the entirety of the hospital or even at the VISN or national level. Just for FYI, there are 2 more steps above the nurse 3 level, but you cannot be promoted to those. That's a nurse 4 and a nurse 5. Nurse 1s through nurse 3s are what we call rank in person, meaning if you can display that you have the confidence, the competence, and meet the dimensions of criteria, you can be promoted within all the way up to nurse 3. But nurse 4s and nurse 5s are what we call rank in position, meaning the position of nurse 4 or nurse 5 is based on that position. Those positions would typically be, for nurse 5 would be the chief nurse in the hospital, or for the nurse 4s it would be what we call our associate chief nurses. You can apply for that position, nurse 4, nurse 5, and if you meet the criteria to hire, then you can become a nurse 4 or a nurse 5. What happens if you decide I no longer want to be in that position? I want to go back to being what I was doing before. Well, when you leave that position, you lose that grade, that nurse 4 or nurse 5, and you would go back to being what you were prior to getting that job, be that a nurse 2 or nurse 3 or whatever you happen to be. Okay? So just real briefly in review, the scope of practicing as you look at going up that career ladder, the nurse 1 really has 3 levels to it, and it's about individual growth and development of that nurse. Again, you're a new nurse, you're a baby nurse, and the only thing you know about nursing is what you read in books or what you experienced in clinicals. Now is figuring out exactly what it is to be a nurse. You have lots of questions, being shown how to do a lot of things. But as you progress through the level 1, level 2, and level 3, your confidence and competence as a nurse continues to grow. Once you make it up to the nurse 2, that scope is, I'm not trying to figure out what it is to be a nurse. I already know it. You are what we consider the journeyman nurses. At a nurse 2, again, you've been practicing for 2 to 5 years. You're the one that people come to when there's an issue or a problem. You're the one that when things happen on your unit or in your area begins to fall apart, you're the ones that have the skill and the expertise to bring everything together and make sure it doesn't fall to pieces. You're the ones that when the doctor writes an order, you can look at it like, that's kind of crazy, doc. Don't do that. You're catching and correcting mistakes even at that level. You can show that leadership. You are mentoring nurses. You're precepting nurses. You're serving on those unit-based councils and maybe even those councils within your sections. You're the one that when something goes wrong, everybody turns to because they know that you've got the answers. Now, when you talk about making it up to the nurse 3, again, you're demonstrating sustained leadership that goes beyond the unit or the section level. You're working on things that impact the hospital. You're working on patient satisfaction. You're developing policies and procedures or working on plans within the various units of the hospital in preparation for the IG or Joint Commission inspections. You're doing things of that level, or perhaps you're working on committees, developing policies and programs at the VISN or regional level, or even at the national level. When I made my nurse 3, I was the BCMA coordinator here in the facility, and I was serving on the national team that was developing the policies and procedures for how BCMA would be used in every hospital across the country. I was also a subject matter expert and was speaking at conferences related to the legal aspects of documentation, preparing people and explaining how your documentation could potentially wind up in court and how if you're not careful in your documentation, that could come back and create a problem for you and for your facility. But you're working beyond just in the unit level. You're doing stuff that's impacting a broader scope. So just real briefly in conclusion, again, Nurse 1, it's all about me. I'm a baby nurse. I'm trying to figure out what it means to be a nurse. When you get to Nurse 2, it's all about the team. No longer just about me. It's about us as a team. It's all about us. Yay, team. Go team. Come on, we can do this. When you're at Nurse 3, then it's beyond just the unit level. You're at the program or the section level, or you're affecting things at the hospital, the regional, or even the national level. For LVNs, your process runs a little bit differently than it does for the RNs. The RN's rating process runs based on the date of hire. For LVNs, your dates run from on a fiscal year setting. The fiscal year runs from October 1st through September the 30th. You were boarded at appointment, and the nurse manager is the one, at least the way the process is now until we get the new process in place. The nurse manager makes a recommendation to the nurse exec, and the nurse exec will sign off on that. When it comes time for your proficiency to be done, your manager should ask you for your information. You complete that self-evaluation and everything else that you need to do, you give it to the manager. If they feel that you meet the criteria for promotion, they'll write a memo and submit that to the nurse executive. They will review it, and if the exec agrees, they'll sign off on it, and congratulations, you've been promoted. But just like for the RNs, you need to keep track of the things that you're doing on a yearly basis so that when your input is asked for, you have a document that you can reflect back on that shows everything that you've done. For our CNAs and health techs, your process runs the same as for the LVNs. You get boarded at appointment, and your year runs again on that fiscal year basis, from October 1st to September the 30th. Just like the LVNs, you'll have a self-assessment that will need to be done. Your manager will ask you for input, and you too should have that folder with information kept in it of all the things that you've done during the past year, so that when you're asked for input, you can submit that to your manager and not have to come up or try to remember all the various and sundry things that you have done. And that brings me to the end of my presentation. In the next 5 minutes or so that we have left, are there any questions?
I'm here. Hold on. Let's see. We have to give it just a minute. You're still talking. Now you get faster and faster at that.
I always try to keep my eye on that time and make sure that I leave room at the end in case there are any questions. Sometimes there are none, sometimes there are quite a few.
All right, this is from Chris, and I think Chris is from another VA. And he says, my understanding is that at the end of the first year, you can be reviewed for promotion. I was not evaluated for promotion at Spokane at my 1 year due to lots of leadership changes. Am I eligible for review for promotion now?
That would depend on when your annual proficiency is due. Unfortunately, the way things are set up, if your prior facility did not review your proficiency, and I don't know how they could have made a recommendation for a first year review to be kept without reviewing your proficiency, because the proficiency is the basis for that first year review recommendation of whether you're a keeper or not. But if they didn't do that, then coming into this facility, we would have to, there is no mechanism in place nationally to review that. If they didn't do it, it would be done on your next review period, whenever that is due, at the end of your rating period. Okay, somebody is asking, where do I get my functional statement? Your functional statement, you get that from your nurse manager. As a part of your orientation to the unit, you should get a copy of it. If you don't get a copy of it, then ask. Someone else is asking, do we get a step increase for certification? That just depends. For certifications, there is something that is submitted to the board for review, and it could either be a step increase or it could be a cash award. Mostly here in South Texas, they're not doing, I don't believe we have been doing step increases. It's been a while since I've seen a certification come across the board, but they've been doing authorizations for cash awards. But there is something that is there for you that's submitted from your nurse manager to you for that step increase. I mean, for that certification.
Okay, Daryl, this is easier to read than type.
Okay.
Because I think other people might be confused. We initiate the nurse professional standards process, or does it show up in our TMS? So how does it get initiated?
That's all on the managerial level. There's absolutely nothing that you need to do. The main thing for you, I think, is to make sure you keep track of, on a yearly basis, when your proficiency is due. In any event, at least 60 to 90 days prior to your proficiency being due, your manager will contact you and say, hey, it's time to do your proficiency. I need some input from you. But that's really your manager's responsibility to keep track of when that's supposed to be done.
Okay, and then somebody asks, can we get a copy of this PowerPoint? So for this, for your reference, what I will do is I will send you a link to your VA emails when you get them. So that you can reference this information when you need it. And also remember, this morning I showed you where you can find the nurse qual standards on the VA website, right? So, and then there's another question, how do we get a copy of the levels? So that's on the nurse qual standards and corresponding pay. I don't know, corresponding pay, that's your question, Daryl.
I'm not real sure what they mean by corresponding pay. Do they mean what your pay is for whatever your grade and step is?
Yes.
Okay. Again, that's something that would come from your manager or from HR. But certainly your manager can get you a copy of the pay scale, the local pay scale.
So Chris is saying you answered his question about getting reviewed for promotion. Mm-hmm. So he's saying on December 6th, 18th was his hire, and he never got an annual appraisal until April of 2019.
Okay. In that instance, I would say so he was hired in December of 2018 and got his proficiency done in April of 2019. Am I hearing that correct?
Actually, he said it was April of 2020 when he got his first year appraisal, which should have been done December of 2019.
And he didn't get it until when?
April of 2020.
I would say that it was probably done. If they did it, probably did it late. But sometimes it takes HR a while for the paperwork to catch up with you. Or the only other thing, since I wasn't there, I don't know. I'm just speaking off the top of my head. It's just a guess on my part. That it was either the paperwork caught up to you late, or it was submitted late and you got it in a timely fashion, but just it was processed late. In other words, instead of it being processed in December, it wasn't processed until February or March. Here is another question. Do we get specialty pay, i.e. ICU cath lab? That's an HR type question and a question for your manager. I don't really have that answer. Off the top of my head, I would say no. There is no specialty pay, but I would refer you back to your manager to get that answer. How do we submit our certification is another question. You get your certification, that is submitted through your manager.
So, Daryl, just to be clear on that, if they came to us with the certification, that's already been accounted for in their.
Correct.
If
if you came here as a new hire and you had a certification and you submitted that you had a certification in your hiring packet as you worked with the nurse recruiter, the board has already taken that into account.
Okay.
Nothing else you need to do. We've already reviewed and noted that you have this certification.
But if you get one, well, now that you're new, you get one, you give that to your nurse manager.
That is correct. If you get one subsequent, yes, you make sure you work with your nurse manager so that that could be noted in your HR portfolio record and a submission to the board.
So, Chris, what I'm going to do is I'm going to let you and Daryl take this offline because this is really unique to your situation, what happened, where you were at before, and how we're going to proceed here. Because I'm not sure that we're going to answer all these issues with you right now.
Yeah, there's only so much that we can do here locally, especially with transfer employees. The best that we could do is at the appropriate time reach back to the prior facility for information, and that would be work through the manager so that we could get whatever we need so that you can get a full year's proficiency that was done. If your rating cycle includes your full year here, then the only thing that we can do is just make sure that your information you would work with HR to make sure that whatever information came from the prior facility is in your EOPF.
Okay.
But yes, certainly you can reach out to me, and I will be gladly speak with you and see if I can answer your questions offline.
Okay. And then for Victoria and Daryl, just correct me and make sure I've got this. She says, I got my certification after I was hired and offered the position. So Victoria, in your case, when you're getting ready to, you can submit that to your manager, but you would also add that into your annual proficiency, right?
That is correct.
So that as you sit down to write that proficiency after you've been here for your year, you will want to include that information, but you're welcome to submit it to your manager now.
Yeah, absolutely. I would absolutely submit that information to your manager right now.
Okay.
You got it. You want that recognition that you have it.
Okay. All right. Great. Any other questions out there? I think we got them all.
Nothing in the chat window. And while we're looking for questions, I just want everybody to, on screen, on this slide in the middle, there is that website that's listed there. That is the web address to get to the National Nurse Professional Standards Board webpage for the VA. It is a wealth of information for RNs, LVNs, and CNAs, health techs. I encourage all of you to make sure you have that, write it down, visit it as often as you can, and get the information that is there. Will be helpful for you and to your career.
Absolutely. Thank you, Daryl. It looks like we're on our way.
Very good. Glad you could all be here. Welcome to the VA. Look forward to meeting all of you.
All right. Bye now.
Bye-bye.
Okay, guys, we have another presentation, but I want to preface this next presentation before we start it. One, I've sent you an email. I've been sending emails to you, so I want to talk about some of these things. Yeah, so Carol, just to answer your question, my proficiency is due in September. Do I use information from my prior VA? Your nurse manager should have, where you were at before, forwarded the information to the nurse manager here so that it's a combination of both, because you're at the end of, I mean, it's August and your proficiency is almost due. So, yeah, so July, August, 90 days, they start asking you. So you need that information from your nurse manager, the things that you've done, to be sent forward, because yes, you need to use that on your proficiency and write a comprehensive proficiency. So yes, the answer is yes, you need to use that. But you need to make sure that gets forwarded to your nurse manager from your previous nurse manager, okay? All right, so let's talk about the next training, which is blood administration. Now, I know some of you are thinking, oh, I'll never administer blood, but you might be involved in either specimen collection part of it or some other picking it up or some other portion. So, you know, just be easy with this process. Also, I've sent you an email with the, if you have a printer, it would be great if you could print out at least the SF 518 that's filled out correctly so you know how it's done correctly, and use these documents that I sent you in email to help reference while you're going through the training. The trainer is Lisa Hooter, and she's going to say, we gave you a red folder, open your red folder. We can't give you a red folder, so I've sent that stuff to you in email. When you come on Friday, I will hand you a copy of the blood policy if you work in an area where you administer blood. So this would be ED and MICU. These are the two areas that are going to get this. And 5A, inpatient unit. So if you're working an outpatient unit, I'm not giving you a copy of it. It's like 42 pages, or 24 pages. It's a very long policy. And we're going to give you our cheat sheet, and we're going to give you a few other things to the competency that you're required to be able to perform. So for your reference, it's a complex process. So I really want you guys engaged and paying attention the best that you can. I know it's not ideal, but you know, we're just trying to, again, give you a good overview so that you're not caught off guard when you get onto your unit or in clinical simulation. You're like, hey, I don't know anything about what this person is talking about administering blood and specimen collection and filling out the forms. So this is the idea here. We give you an overview of this information. So if you haven't clicked over and checked your email, please do so. Now, your sponsor, the sponsors are coming through right now. And as I get these emails, I'm forwarding them to you. And I'm sending you what your new VA email is, so you can go ahead, if you don't already have a PIV card, and schedule to pick up your PIV card right from home. You can do that. All you need is that website that I've given you and your VA email. Now, I want you to keep in mind, though, as you plan to pick up this PIV card, if you have clinical simulation training, that takes priority over picking up the PIV card. So I would try to plan to pick it up. If you're in clinical simulation, then Tuesday afternoon is your best time. So again, be checking your emails about if you've been sponsored. I have sent you an email to your home email, and you can set up that appointment right from home. So you'll have time to do it today or tomorrow. All right, so questions on that, and I'm gonna check this out, and then I'm gonna go over and go ahead and start our blood administration. So we'll give you a second to see if there's questions. All right, I want to get started because I do want you to have your lunch. I know, Lisa, I know. Okay, I want to answer this question about the PIV, all right? So, if you're sponsored and you can schedule your PIV and you have a VA email, you can go ahead and schedule to pick up the PIV. Got it?
Hello, my name is Lisa Hooter, and I'm one of the nurse educators at the South Texas Veterans Healthcare System Nursing Education Department. Today I'll be presenting information regarding blood administration. Due to our social distancing requirements, this is a virtual session for many of our orientation classes, but you should have a facilitator present to answer questions. This presentation was created by Gay Padayo. She's one of the RNs on our bone marrow transplant unit, and she usually presents this in nursing orientation, but she's unable to join us today. The bone marrow transplant staff are a very good resource for questions if you have them later, because they administer a lot of blood products. Prior to initiating the process for drawing the type and you want prior to initiating the process for drawing the type and screen, it's important to do some education with your patient to explain what products the provider has ordered. You can talk to them about why they may be given, although this should have already been done by the provider, and informed consent should have been obtained already. But why is the product ordered? What kind of signs and symptoms might they see during the transfusion? What should they expect after? What kind of symptoms you would want them to notify you of immediately? We also do have a policy that governs blood administration, and the numbers listed on the bottom of this screen. And you can look it up in the South Texas Veterans Healthcare System homepage, and I will show the group how to do that a little bit later in this session. It is helpful to know that there are guidelines that govern administration of blood and blood products. For instance, it's reasonable to use a hemoglobin less than 8 or a hematocrit less than 24 for transfusing red blood cells, but there are times that the provider may need to wait a little bit longer or institute transfusions at a level of 10 for the hemoglobin. So that would be something the provider would need to document the rationale for administering products at a different level. But this screen gives you general guidelines for each product. For example, hemoglobin, it says level less than 6 to 10. For the fresh frozen plasma, it gives you different INR levels and so on. You want to make sure that you verify that consent has been obtained for the transfusion, and there are two places that you might find this information. If the veteran was admitted for, let's say, a surgical procedure, the blood administration is part of the consent, and you can find it in CPRS under IMED consent, but there also can be a separate transfusion of blood products consent form, and the number is shown up here on the screen. The consent, once obtained by the provider, and it is the provider's responsibility for doing that, the consent is valid for 60 days. It's good for one admission, so if a patient goes home, if they're readmitted, they would need to have consent obtained again. There are times this may not be the case, such as outpatient hemodialysis. Their consent requirements are a little bit different for chronic dialysis, but for blood administration, you want to make sure that the consent is valid. And I don't like to read straight to you, but there is part of our consent policy that I would like to read because, as I stated, the consent is valid for 60 days or unless rescinded by the patient. But new consent must be obtained if there is a significant deviation from the treatment plan to which the patient originally consented, or there has been a change in the patient's condition or diagnosis that would reasonably be expected to alter the original informed consent. So if there's a drastic change in patient condition, consent may have to be obtained another time. So prior to obtaining the type and screen or type and cross, you want to verify consent is there. You want to verify that the physician's order is in CPRS, and the provider must include in the order what type of blood products are to be given, when it's to be given, the number of units to be given, any modifications to the product such as leukocyte reduced or radiated, pre-medications if it's necessary, and sometimes maybe even the duration of the transfusion if they need it faster or slower. But those type of things should be entered in the order by the provider. It's important to understand a few of the terminologies that are associated with this process. There are terms used for the collection of the pre-transfusion sample that get confusing to some people, and one of these is phlebotomist. Our policy says a qualified phlebotomist is the person drawing the blood. So this can be a super tech, a health tech, a nurse, a physician assistant, or a nurse anesthetist. The medical techs in lab will not draw or verify type and screen in the inpatient areas. So if you are an RN and you're drawing a type and screen from a PICC line, let's say, you are the phlebotomist, and your second verifier would need to be another person that is a qualified verifier. One of the two has to be an RN. Same with transfusing the blood products. If you're the RN and you're going to be hanging the blood, then there needs to be a second verifier in the room, and that could be several people that are listed in the policy, but one has to be an RN. A little bit different, let's say a nurse anesthetist or a physician in the OR is giving the blood, the RN may be the second verifier. So, but one of the two people in both of these examples must be an RN. A few other things to talk about before we go through the process is the type and screen when drawn expires 3 days after the collection, and the day it's drawn is day 0. So today is, I'm recording this on March 30th, so if I draw a type and screen right now on March 30th, 2020 at, I'm not even sure what time it is 2:48, then that today would be day 0. So day 1 would be March 31st, day 2 would be April 1st, day 3 would be April 2nd. So my type and screen would expire on April 2nd, and it expires at the end of that day. So it would expire April 2nd at 23:59, so right before midnight. So it doesn't expire 72 hours after collection, but it expires on the 3rd day at 23:59. So hopefully that will make sense, and we'll talk about it again at the end of this presentation. The ABORH testing is needed to confirm the veteran's blood type, and if the veteran has received more than one transfusion at Audi since June 2010, they don't need the ABORH testing. But if they have never received blood or have only received blood one time, in addition to the type and screen, they will have to have the ABORH recheck, and that is a separate order in CPRS. The order will be, like it shows on the screen, will be a separate order, and it must be drawn at a different time than the type and screen. If it's done on the same day, it must be drawn by a different qualified phlebotomist, and the ABORH recheck does not have to have a second verifier. Prior to going to collect the specimen at the bedside, you want to collect your supplies, and you should have in front of you red folders that say Neon Blood Administration and Gay. Put all these together, and you have some samples in the left side of the left pocket of your folder. So you have some pre-printed labels, you have a copy of the SF518 form, you have a Type and X blood band armband, you have a pink top EDTA tube, and you have a sample of a patient ID band, and you're going to notice that your patient is Garfield, and then his armband is just a picture, since we didn't want to waste the armbands to do this presentation and then to make packets for everybody that's listening. There's just a photocopy of the armband. You want to make sure that you have your second verifier if you're collecting the type and screen, and that verifier must remain in the room with you as the phlebotomist at all times. So you're going to be doing the patient identification at the bedside in the presence of the patient with 2 people, the phlebotomist and the verifier, and you want to actively involve the patient if possible. So this is a picture of some of the things that should be in your folder. So your armband, your pink top, your labels, your Type and X blood band, and your SF518. There's a copy in each folder. And we'll talk about the part that has to be filled out, which is about the upper third of the paper. But we're going to go through steps, and you have copies in your folder of all of the slides from this presentation. The only thing you don't have is the next few slides. I've made some pictures to help you with labeling the tube, since we have to maintain our social distancing during the COVID-19 time. So you can look at the pictures that are up on the screen, but there should be a facilitator in the room that can answer questions as well. So the first thing that you're going to do is you and your second verifier need to immediately verify the patient's identity. So the 2 of you are going to be at the bedside, and one of you can ask the veteran to actively verify their name, their social, and to make sure that and their date of birth, to make sure that you have the right person. So you're going to take one of the labels that you brought into the room with you, verify that against what the veteran said, and then both you and the second verifier need to make sure that you both are certain that all of that information matches. And once you confirm that with the patient, you'll take one of the stickers and you're going to put it on the Type and X blood band, and there's a place that says place patient information here, and you'll put that label right on top after you verified the information with the veteran. Please note that this should not be done prior to entering the room, and this should be done at the bedside as soon as you verify the patient's information. Then the next thing you're going to do is there's a little piece of paper that you can peel off, and it will allow you to place the clear cover over the top of the armband that you just applied. And you'll just slide that over, smooth it on to the armband, and then you're going to put that armband on the patient's arm and put it on the same arm as the hospital ID band. Please note that when you're doing this, let's say 3 days from now, if you have to do another one, you want to remove the previous armband after that type and screen is no longer valid, because you don't want the patient to end up with multiple armbands. At this point, you're going to take the pink top EDTA tube and collect your sample. You're going to notice in the picture that there's no blood in this tube, because I was taking these pictures at my desk and I did not have an actual sample, but you want to fill the tube prior to applying the labels. If you notice in the picture, you may be able to see the expiration date on the test tube. You do want to make sure that your test tube is not expired prior to filling it. And you're going to take a label off the Type and X armband. There's a long tail of labels that comes off the armband, and you can actually detach these labels from the patient's ID band. You'll see the patient's name to the right of it. You'll see one of the IDs, the red ID numbers, or red and black numbers that cannot come off, and then 3 labels that are removable. And right after that, you'll see the little perforation lines where you can detach the tail of the labels, and then you're able to use that for this step here. And you're going to peel off the label that looks like the one in the middle of the picture, where it has the red and black ID number, the barcode, and underneath it you'll see the dotted lines, and you'll see the words applied to specimen tube and place patient label below dashed line. So this will be the first label that you'll peel off the armband, the Type and X armband, and you'll apply it to the test tube. And then you'll smooth that around the tube. And then the next step, you're going to take your patient label, one of the 3 that you took in the room, because one went on the Type and X armband, one's going to be for this test tube. You can enter the date, the time, your name, and if there's room for the second verifier, they can write on here, although the policy just states that they must write on the form that I'm going to show you shortly. So when you apply this label, you want to apply it, and I'm going to go back. No, I'm not going to do that because I'm afraid it will mess up the recording, but you'll apply it right below the dotted line from the previous picture, and you'll put that on the test tube. You'll smooth it around the test tube, and it usually fits just right, and it doesn't cover up the expiration date as you add that to the test tube. The form that you have in your left-hand pocket is the SF518, and you're going to take one of the Type and X armband labels from the patient's ID band. There's several that are that you can remove, but you're going to take one of those and you're going to put it on the form, the SF518 form, as well as your third patient label. So both of those will go on the form, and then the rest of the labels that you detach from the Type and X armband can be secured to the test tube. And the easiest way to do that is if you turn the Type and X labels over, the ones that you detach from the armband, you can see that you can peel off the center cover of the labels that look on the opposite side of the picture that's on the screen on the lower right hand side, and you're just going to pull off the cover of the center labels and then attach that to your test tube, and you can see all of those numbers match. So the label that I put on the test tube matches the labels that I attached. The long tail of labels that I attach, it matches what's on the form that's on the screen, and it also matches what's on your patient's ID band. This is the process of double verification. You, as a phlebotomist and the second verifier, must make sure all of this information matches exactly. And if any of this information does not match, you have to discard and start over. So this slide shows you the steps that you just completed for labeling the test tube, filling out the paperwork, and you can see that we've applied the patient label. We had applied the armband label from the Type X armband to the SF518, and then you need to fill out the top portion of this record. You have to put what blood component is ordered. You need to fill out any special requirements that the physician may have ordered in the sample on the screen. The orders for irradiated leukocyte-reduced red blood cells. You're going to mark in the center of section 1 if it's a type and screen or a cross match. You're going to enter the date. You're going to enter the date and time that you need this product. And then on the far right column, you're going to enter the provider that ordered the blood product, why the blood product is being given. Then you're going to sign, and your second verifier is going to sign, and then you're going to enter the date and the time. And the date and time on this form must match the date and time that are on the label that you applied to the pink top test tube. And it's very important that all of this matches before you leave the room. So again, this is all completed at the bedside in the presence of the patient. When the blood product is ready, you'll be notified by the blood bank, and prior to obtaining the blood product from blood bank, you want to make sure that you have valid consent, that it hasn't expired. You want to make sure there's an order to transfuse, that the physician hasn't changed his or her mind. You want to give pre-medications if they are ordered, and you want to ensure that your patient has patent IV access and vital signs are good and everything is ready for the transfusion. At this point, this is always when I would make sure I had a really good temp, because I wanted to verify that the patient was afebrile. If they had a temperature at this point, it makes it hard to know if you're having a transfusion reaction later if the temp continues to climb. So I always like to make sure I had fresh, very recent vital signs before I obtained the blood. You need to print a copy of the nursing transfusion order from CPRS, and you're going to send this to the blood bank so they know that you're ready for the blood. It's important to note that the nursing transfusion order is not required for transfusions that occur in the OR or PACU if the authorized provider is actually the transfusionist. Once you have sent the nursing order to blood bank and you're ready for the blood bank personnel will receive your order, and you always send that in a red carrier in the pneumatic tube system if you have that in your area to station number 9. I do understand that the ED does not have the tube system. I'm not sure about the OR, but most of the nursing units do have the pneumatic tube system. What will happen then is the blood bank staff are going to perform a process of two people verifying the blood that they pull and are sending back to the nursing unit. They're going to initiate a blood product transport form. They're going to pack the blood product in a clear zip pouch and put it in the red carrier. They're going to put a blood transfusion record form and the transport form into the pouch, and they're going to notify the nursing unit that they're sending the blood product, and they're going to send it to the nursing station. When it arrives in the nursing unit, it is important that somebody it should be the nurse that's going to transfuse, but there may be a situation where the nurse is not the one accessing and removing the blood, but that's ideal. You're going to enter the access code 1234 to unlock the tube system. You're going to enter the last four of the patient's social security number, and you must do that within 6 minutes of the blood arriving to the unit. If not, the blood is going back to the blood bank. So as soon as you pull that blood out of the pneumatic tube, or as soon as it's picked up from blood bank, you want to do a visual inspection of the bag of blood. You want to make sure it's not leaking, there's no gas bubbles, that nothing looks awry, that it's the right patient. You're not doing your full 2 verifiers yet, but you could quickly know if the blood is sent for the wrong patient. And if everything looks okay, you're going to complete this a section of the blood product transport form, and I'm going to show you that in just a minute, and send that back to the blood bank before you even leave the pneumatic tube system. This is a sample of the transport form, and you just have to fill out the area that's highlighted in yellow, so time received and who received it, and immediately return it. But if there's any problem, you want to call the blood bank immediately. Please keep in mind that only one blood product will be sent in the red carrier at a time. Blood bank will not send rare blood types through the pneumatic tube system. They will not send blood products for the OR. They will not send transfusion workup information or samples through the tube system, and emergency or crash blood will not be sent through the tube system, and we'll talk about that in just a minute. This is a quick diagram. It's a little hard to see on the screen, but it's how to obtain blood for crash blood. So you need this in an emergency. And it's important to know that this blood is not typed and crossed to that specific veteran. They're going to use universal blood for them. And so the process has to be initiated by the MD or designee to call the blood bank that they need crash blood. And there's a protocol to follow. So the areas that do this should be part of your unit orientation. The lab will only send so many units of blood at a time, or release so many units of blood at a time. And so arrangements have to be made to who is picking up the blood. And this blood is packed in the ice chest with special temperature indicators in it to make sure that the blood is maintained at the right temperature. And they will release crash blood for only up to 12 hours before it is time for, somebody needs to try to do a type and cross in that time frame. This picture shows you what will come to you in the pneumatic tube system, or if somebody picks it up from the blood bank, you will receive the bag of the blood product. It will have a tag on it that has specific information for that unit of blood, and you will also receive a copy of the transfusion record. So the caution tag that you see in the upper right hand corner is physically attached to the blood product, and it contains the veteran's full name, full social, the type of blood product that is being sent to you, the blood product unit number, any modifications made to that unit, such as irradiated or leukocyte reduced, the expiration date, the type of next alphanumeric sticker that corresponds with the veteran's armband, the ABO-RH type of the blood, and the patient. So all of that is on this special caution tag attached to the unit of blood. So the transfusionist will confirm the patient's identity by having the patient verbally state his or her name, and this needs to be done in the presence of the second verifier. The patient should state their full social and indicate any additional things like junior, senior, anything like that. And we want to make sure that that information is identical to what is listed on the patient's wristband, on the Type NX blood band, on the blood transfusion record form that came with the blood from the blood bank, and on the caution tag, and that all of this matches the order in CPRS. So there are several things that the transfusionist and the second verifier are checking. The second verifier will be present throughout this process and will confirm this information. And again, if at all possible, have the patient actively be involved in this in this checks and balances to verify that all the information is confirmed. The transfusionist is also going to confirm the identity of the blood product for the patient, and you want to explain to them what they're getting in front of the patient and in front of the second verifier. You're going to make sure that the blood product ABO-RH type on the label of the blood product matches the information on the transfusion form and the caution tag. So all of the items shown in this picture, you want to make sure that they all say O positive, and that it matches what's on the typed paper, which is kind of hard to see, but I can see it up on the screen. So all of these say O positive, RH positive. The blood product unit number must match what's on the blood product and on the transfusion form. So you're going to make sure that the unit number matches on the paper form, the tag, and the unit of blood. You're going to make sure that the type and X alphanumeric sticker matches on the caution tag, on the blood transfusion record form, and on the patient's blood band, the type and X blood band on their arm. The type of the blood product and the modifications listed on the caution tag should match what's on the transfusion order. The compatibility information on the blood transfusion record form is compatible with the product that you received. The date and time issued from the blood bank should be documented and verified, and you want to make sure the expiration date of the unit of blood or blood products, that all of those, that expiration date is not passed. Once you confirm all of this between the person hanging the blood and the second verifier, you're both going to sign the record that comes with the blood bank, so the transfusion record. You're also, before you hang it, actually very, very beginning, visually inspect that the blood looks okay, that there's nothing leaking, there's no gas bubbles, and you're going to do your verification at the bedside. And you have 30 minutes from the time the blood leaves the blood bank, comes through the pneumatic tube system, it's retrieved, verified at the bedside, and hung. You have 30 minutes to do that. So if any reason that's not going to happen, you must return the blood to the blood bank. For example, let's say you got your vitals, you verified Peyton IV, you sent for the blood, and you and your second verifier go to the room and the IV is gone. Well, if you don't think you can get that restarted and have the blood checked within 30 minutes, you should send that blood back to blood bank and then have it reissued when you're ready. And then you must make sure that the blood product is transfused within 4 hours from initiating the blood transfusion. So it's very important that you have everybody ready to get this process verified, started, and that you are able to transfuse the entire unit within 4 hours, and that includes what's in the tubing. So we'll talk about time frames in just a minute, but you need to make sure that you're administering it quickly enough that it can be done in 4 hours, but you don't want to start the transfusion off too quickly at the very beginning. So watch your transfusion time, and after the first 15 to 30 minutes, you can increase the rate to ensure that it'll be transfused within that 4-hour period. If for some reason it is known that this veteran cannot tolerate a full unit of blood due to maybe circulatory overload, they may be on multiple drips or IV infusions, it is possible to split a unit, but that has to be done by the blood bank, and that should be part of the order for that blood product. I saw this when my granddaughter was born, and she was in the NICU. She was born 4 months early, and she weighed less than a pound the first day that she needed a transfusion. I happened to be at the bedside when the nurse came in, and my daughter had already given consent, but the nurse walked in with a 10 ml syringe that had maybe 3 or 4 mLs of blood in it. And I asked her, what is that? She goes, this is her transfusion. So they were able to split units down to minuscule amounts because a 1 pound micropreemie can't tolerate very much volume. So it's very interesting to think about that. But it must be done in the blood bank prior to issuing the blood. So this slide just reminds you what things you need to take into the room to get your transfusion going. You need an IV pole, IV pump if necessary. In some instances, you don't want to use it. If you're giving a lot of blood quickly, you don't put them on the pump. But our Alaris IV pumps, you can administer blood through them. You just need to make sure that you have the IV administration set that is listed for blood administration, and it says it right on the package. You need your normal saline. You need to be able to monitor your vital signs. And the frequency of vital signs, according to our policy, we must do vital signs prior to the transfusion, 15 minutes after starting the transfusion, at the completion of the transfusion, and as needed. If you're used to doing vital signs more frequently, you can go above the policy. You just can't go less than what the policy states. So if you're on the more seasoned side like myself, I've been an RN for 35 years, I probably take vital signs much more frequently than required, but that's the way I was taught to do it. You also need to know that you want to fill out the transfusion record form that you get with the blood product, but you need to transcribe that into CPRS. And you have a blood transfusion note in CPRS, which I'm going to show you. You have the second verifier note, which I'll show you a sample of. And the things I don't have samples of, but they are in CPRS, are the critical care blood transfusion note that would be used in critical care, OR, PACU, or in dialysis when multiple units are being transfused rather quickly. It allows for you to put in more than one unit of blood. The other note that's listed first, a blood transfusion component note, just has the place to put the one unit of blood and the type and X number. And so this critical care transfusion note will allow you to document more if you're given multiple units. After the transfusion, you want to make sure that the blood transfusion record form that is sent with the blood product is scanned and sent to the patient's medical record. So each unit, you have a place that you keep those forms that do need to be scanned to the medical records, and make sure that the completed form is put there. This screen shows you the sample of the CPRS note, and this is the blood component transfusion note that the nurse giving the transfusion will fill out. Excuse me. It has the pre-transfusion vitals, it has your type and X blood band, the actual unit number, pre-medication, everything is in this note for you to fill out. Screen shows you the second verifier note. So the second verifier doesn't verify all the vital signs are complete or that your patient was monitored. It's just verifying that two people were at the bedside, verifying the patient and all the information on the blood product prior to initiating the transfusion. So the second verifier's note is a lot quicker. It will have the veteran's name, the type and X number, the unit number, that you verified consent was there, that you verified the orders, and that you were verified with the other person. You're going to sign it, so it's pretty quick. No talk about blood administration would be complete without talking about transfusion reaction. So it is important to make sure that the veteran and family, if they're at the bedside, understand what potential signs and symptoms of a transfusion reaction are. And basically, it's anything that's there now that wasn't there when you started the transfusion reaction. Your veteran may have gotten a lot of blood products in the past, and they may have pre-medication ordered because they have minor transfusion reactions, and that should be something that is you're made aware of up front. But let's say your veteran, everything is okay, but all of a sudden they have a rash. You have to stop the transfusion, call the provider, call the blood bank, and it may be the case that the provider orders the transfusion to continue. You just would want to make sure that you document that information. But more severe reactions, temp spikes, flank pain, hematuria, any of those things, you definitely want to consider that it may be a transfusion reaction. Stop the blood from infusing, and don't just open the saline. You do that at the very end of the transfusion to make sure you get all that blood out of the line, but at this point you don't want to do that. You want to stop everything that's going through that blood setup. Get a new bag of saline, a new set of tubing, prime it, break it down close to the patient and hang saline, and then just keep that blood bag and all the tubing that was part of the transfusion, package that up because it's going to need to go back to the blood bank. You're going to make sure that the provider is aware, because the provider must order a transfusion reaction workup in CPRS, and you're going to treat the patient according to the provider's orders, and then the blood bank will work with you to complete the transfusion workup. The most common thing that happens is misidentification of samples, although that doesn't happen as often now with all the safety mechanisms we have in place. But the first thing they're going to do is retype and cross that blood to make sure there wasn't a mistake made there. The other thing that you notice up in the upper right-hand corner of this slide is TACO and trolley. And if you've never heard these two forms, TACO stands for Transfusion Associated Circulatory Overload, and trolley is Transfusion-Related Acute Lung Injury. Both present with respiratory distress, so your patient may call you or their family members that they're having difficulty breathing, and so this could be a sign of either of these conditions. But with TACO, it's circulatory overload or fluid overload, and so usually the patient will also have hypertension, tachypnea, tachycardia. With trolley, it's a little bit more serious. They usually present with hypotension, but it's important to know that these should be documented. The provider should be called so treatment can be initiated. This is a sample of the transfusion reaction form. It shows you what part you need to fill out. You need to call the blood bank, describe what kind of symptoms that they have, and it's a very quick form to fill out. And then, like I said, the first thing they're going to want to do is to retype and cross. And so you'll have to go through the same process of doing the type and cross. And this is all part of the transfusion workup. It spells it out in detail in the policy. Then this slide just shows you the process for emergency release of blood. So this is blood that's needed in an emergency situation where we can't wait for a type and cross, and the provider must order it. There's a place to order it in CPRS. There's a form that can be filled out and taken to the blood bank, and as I mentioned earlier, the provider has to order it, and they can blood bank will release emergency blood for up to 12 hours, but after during that 12 hours, they expect that a type and cross is being obtained, so they can provide the rest of the blood as cross-matched blood, and they can give out up to 20 units of blood product with the emergency release. So let's kind of put a few things together. You have references for you on the screen. It is in your handouts as well. You can always go to the American Blood Bank, American Association of Blood Banks, the AABB, and they have information to review about giving blood and blood products. We have our South Texas Veterans Healthcare System policy, and you can get to that by going to our policy and procedure homepage. You have policy for consent for blood or blood component transfusions, and there is a policy related to use of the pneumatic tube system. If you look up the policy for blood administration, it is quite long, and I always like to tell people it can be overwhelming when looking at it, but if you go to the very last page, you have a table of contents, and it's easier to find what you're looking for in that policy. So the policy has information also attached to it, samples of the SF518 blood or blood component transfusion request form. It shows a picture of the Type NX armband. It shows the blood transfusion record form, which is issued with the blood, and this is the form that you record your vital signs on. It has a picture in the policy of the caution tag that we had in the presentation earlier. It talks about the emergency release form, transfusion guidelines approved by the Blood Utilization Committee. So this is the slide that talks about the hemoglobin needs to be less than 8 before they receive blood. It talks about the maximum amount of blood that can be held in the OR for a case. And this is very specific. There's an interesting page you can read on your own sometime, but it will tell you according to the type of of surgery that's going to be performed, how many units can be kept on standby in the OR for that procedure if it's one that typically needs blood during the OR. There is a copy of the request for blood product form from the OR, and there's also a description of the acute transfusion reaction. So this is all listed in detail in the policy. You also will be given a copy of the competency assessment checklist for blood administration, and it goes through everything that was just talked about in this presentation in that competency form. So this will be provided to you in the SIM A session that you are actually SIM B, I believe it is, if you're attending orientation during our COVID social distancing time. Otherwise, it will be given to you as part of your unit orientation. And then GAY usually has a little 5-question quiz to give you at the end of this, and so I'm going to go through this because it's a good way to review. And the first question says, consent for blood transfusion is valid for, and it's 60 days unless rescinded by the patient. A second verifier does not have to be present during the collection as long as he or she positively identified the patient and completed the boxes on the SF 518. And that is false. The phlebotomist and second verifier must be in the room for the entire process of collecting and labeling the specimen and filling out all the appropriate paperwork. The next one is a type and screen drawn on 3/11/2020 at 10 a.m. will expire when? And remember that the date you draw it is day 0, so that would mean that it expires on 3/14/2020 at 23:59. So it's not exact 72 hours after you draw it. It will be at the end of the day on the third day after it's drawn, and day 1 is the day after you draw it. So that's a little confusing. So just to remind you, the day you draw it is day 0, day 1 will be the next day, and so on. Unused blood products should be returned to the blood bank within 30 minutes of release from the blood bank. So it's not 30 minutes after it arrives on the unit. It's not 30 minutes after whoever went to pick up the blood picked it up and went and stopped and talked for 20 minutes in the hall. It's 30 minutes from the time it was released from blood bank, and that will be documented on the form so you know when your 30 minutes starts. And number 5, blood products shall be transfused within 4 hours of the time that you initiate the transfusion. So one of the options on here is spiking the bag. Well, you really shouldn't spike the bag until you're ready to prime it and use it anyway, so the spiking and the start time should be pretty close, but the policy says 4 hours from the time the blood transfusion is initiated. And at that point, if I was live with you, I would ask for questions, but you may be able to ask your facilitator in the room some questions. If your facilitator is not able to answer the questions, we can sure write them down and get back to you with the right answer. Thank you for your time and your attention. Have a great day.
Continuous PRN on call one time.
All right, guys, let's just do a sound check. If you can just let me know that you hear me. You see the slides here. So can you hear? Just a little sound check. All right, guys, let's just do a sound check. I guess you can. All right, our next speaker will be here in a moment. She's gonna just jump on in here like our last speaker. So you guys have been busy. Hopefully you had a really nice lunch. You were busy, looking at your emails. Hopefully you don't have any questions on blood. For those nurses that are actually gonna go into units that they administer blood, you're gonna get this, you'll see this again. And then of course you'll see it again in unit specific orientation. So don't feel like, oh my gosh, I gotta know how to do this. I will say when it comes to blood administration, most of the errors are occurring in documentation, in the specimen collection. So if that seemed a little confusing to you, that's where we're seeing most of the errors, and that's where when you go to clinical simulation, you really want to pay attention and get that right. Make sure you have a good foundation because you're new and we still see these errors. So obviously people who are not new still having the problems. So maybe you can come in there and help us recognize, when we're missing something. So our next speaker, she's from patient safety. You can see right there. And all right. We'll see if we hear her here in a second. And she's going to go over the JPSR. I think a couple other of our speakers have talked about that. I know the chief nurse talked about the JPSR. That's like our incident reporting system. Hopefully we're going to hear her in a second.
Hi, everyone. It's Kathy with Patient Safety.
Hi, Kathy.
Hi. I hope you guys are doing good today.
Yes.
So let's see here.
So just at the bottom, you can do this how you want, Kathy. I think last time you just took over and you wanted to show your desktop since you have more.
Okay. Absolutely. Let me go
or less time, and I know that JPSR is important to you. So okay, I'm out of here. I'm here, but I'm not going to talk anymore. You're on your own.
No worries. Thank you. Thank you. Okay, guys, I'm going to share my screen real quick. And let's see. Okay, so let's see. So I have about 25 minutes to talk with you guys. I'm real sorry about that. We have a lot of RCAs going on right now. But I want to show you patient safety reporting, which is the most important thing that I can show you. And I want to talk to you about what happens whenever you submit a report. So to submit a report, you see, you should be seeing my the internet home screen. And if you see right here, patient safety reporting, this is what you're going to click on. So you go to the internet and intranet, and you click on patient safety reporting. And this is what it looks like when you get in. You're going to click on Department of Veteran Affairs. And it's just going to verify that you are authorized to enter the system. It doesn't track who you are. There's a lot of confidential data in here, and of course they're not going to let just anyone in. So they're going to make sure that you have authorization to get in, and it's going to do that through your PIV card and having you enter your PIN. Once you enter your PIN, you are going to be automatically in the JPSR report. So I'm going to give you some few tips on this. First, you're encouraged to report all types of patient safety concerns or events, not just the ones that reach a patient. Anything with an asterisk is a required field. Also, after 10 minutes of inactivity, the JPSR will timeout and information will be lost. So try to finish it as soon as you open it. If you have to walk away and you come back and it's gone, it did not get submitted, you will have to enter it again, okay? So type of staff initiating report, you can just type in NUR. And whether you're a CNA or a nurse, it's going to show up here. So I'm going to say that I'm a CNA, okay? For reporter, if you notice here, if you do not feel safe or comfortable reporting, enter fear in lieu of your name or leave this section blank. So there's 3 things you can do here. You can put your first and last name. If you put your email, that's going to allow us to provide feedback to you. So, for example, if you put in an event related to a fall and you want to know what happened with the patient or what the actions were that were taken to improve, you can put your email here and you will receive something back from patient safety with a description of what the improvement was. If for some reason you don't agree with the improvement or you have a better idea, please feel free to email patient safety and let us know or respond back to the email you receive. You can also leave this all blank. That indicates that you want to remain anonymous, or like it says here, if you are really afraid of having a retaliation of some sort, then you can put fear. While it is rarely used, we do track fear in our system, and we do try to work with people to get that just culture that we're really striving for. So we want to make sure you understand the 3 options available to you. So here, of course, the event date, the event time. So this is another tip I'm going to show you. Under step 1, campus, if you just type in STX, you're going to see everything for South Texas. If you don't do that, let me show you. You are going to see everything in the nation. And who wants to try to go through all this to find out of 1,128 codes? No, thank you. So just type STX, and it's going to give you everything that's for us. We have Kerrville, One Tech, outpatient clinics, and then we have Audie Murphy. And as you can see, it auto-populates our medical center and our VISN number. And then for service line, let's say this happened on an acute care inpatient. And we're going, and as you can see, the other options are like critical care is a common one, emergency medicine. Those are all very common. Geriatrics and extended care, we'll go ahead and do that. Okay. And if you click here, let's say it happened at CLC1. It's going to populate. And then here, this is where the location was. Was it a bathroom? Was it a bedroom or a hallway? So we're going to say it happened in a single patient room. And in this event description box, you're going to put what happened. Now, if you notice here, it says enter information in SVAR format. Of course, we all like SVAR. SVAR is a tool that's recommended by high reliability organizations. But if you don't have time to really think this out, well, what is the situation? What is the background? What is the assessment? And what is the recommendation or response? Then just put a description of what happened here. You don't have to overthink this, okay? When you're putting in the description, please don't use names. For example, if Nurse Mary and Nurse Jane helped you, just put RN1, RN2, or if you have 2 CNAs, CNA1, CNA2. The reason for this is because NCPS does see all of these records, and we do not want to use anybody's name. Now, if for some reason you make a mistake and do that, don't worry. Patient safety does go through and take the names out and put them in a location where NCPS cannot see them. They're also looking at, is this an electronic health record issue? So if you have a problem with CPRS or anything CPRS related, you could put yes there. Is this a patient safety event or a near miss? So did it reach a patient, or was it a near miss close call? And then they also are looking at if it involved community care and if a patient was involved. So yes, a patient was involved. Once you click on yes, it's going to ask for the last name and the first name of the patient and the date of birth. Those are requirements through the Department of Defense, and since this system was based or created for them, we also will be required to put the date of birth. So the veteran number, while it's not a requirement, as you can see, it does help us to locate the patient quicker. So if you put the last four of the veteran there, that would be very, very helpful. For injuries, you can describe any injuries that the patient had up here in the details. You don't have to do this. This isn't a requirement, as you can see. Plus, it is rather lengthy. And let's be honest, when we're on the unit, who has time to really decide, was it a puncture or laceration? Let me find all these exact terms. Just, you can put it in up here, and that's perfectly fine, okay? When you're done, you're going to hit submit. Once you hit submit, you're going to get something called a patient safety record number, okay? And that number you can keep. If you want to, let's say you're working at night and you want to let the NOD know that you had a patient that fell, you could give them the patient safety record number if you feel comfortable. If not, you can just keep it for yourself, and that number is very useful if you want to reach out to us and provide additional feedback, or if you have recommendations for how we can improve. That would help us to locate that PSR really quickly. So now what happens once you put in a report? Once you put in a report, it goes into this database. It's very secure. It's National Center of Patient Safety sees it, and they monitor how many events that we're getting. And again, I want to say reporting events is actually a good thing. If we see reporting of events go up, that means that our culture is so just that our staff feels comfortable putting in events. And everyone should feel comfortable putting in near misses and close calls, because that is how we are going to quickly identify things and fix things before harm reaches the patient. So I can't express to you enough that putting in an event is not a bad thing. It is a very good thing. So they look at our numbers, they make sure that we are investigating them. And when I say investigating, it's more like an analysis. We're analyzing the system. Where did the system go wrong? And that's what patient safety is about, is we do not look at people, processes like, why did Nurse Kathy do this wrong? We look at what in the system may have contributed to Nurse Kathy doing this wrong. So for example, I had once had a nurse that had just gotten off orientation, and he came to me, and it was his first day off orientation, and he said, hold on one second. Correct. I'm sorry. So, for example, he came up to me and he said he was very, you could tell he was very alarmed. And I was like, what's wrong? And he said, I don't know if I gave insulin or heparin to the patient. And, we went into the room, we checked the patient. But, when you think about it, a punitive response would have been, what were you thinking? How could you not know? And that's what we try to avoid, especially in your teammates. If, people make mistakes, we are not here to criticize you. We don't want your team to criticize you. We want people to not feel ashamed when they make a mistake, and we want people to feel comfortable speaking up. So that would have been the wrong thing to do. So what we did was we went in, of course, the patient was okay, luckily. He didn't give them a full vial, or, he didn't give them a full syringe of insulin. But we look at those processes. Why would he have not known if he gave insulin or heparin? And we determined, we were using the same syringes for both insulin and heparin. That was one thing that would have caused a mistake or confusion. Also, the vials look similar for that facility. That's another thing that that the facility could change to do better, that would have been safer. And that is what we look at. We look at those type of things. We do not ever have a punitive response in patient safety. So that's what I want to make sure that you understand. So we look at these events and we score them. We analyze them. And when I say score them, we're looking at, was there mild, moderate, or severe harm? And we end up doing daily reports. We do a morning report and an afternoon report. So the morning report goes to the director and the executive leadership team. The director and the leadership team does review them, and they will talk openly about the events. They will try to find out if there's something that they can immediately fix so that veterans are not harmed or that the problem doesn't carry on. And that is so valuable. So on these reports, the only thing that is on them is a date of the report, the unit that the report originated from, the name and last four of the veteran, and the description of the event. Nowhere on there is the reporter's name. We do not do that. So just wanted to make sure that you guys were aware of that. And putting in JPSR reports does get things done very quickly. It does alert everybody as to what is going on, because not only does the director see them, but every service chief sees them. So they know very quick and timely if something's going wrong with dietary or pharmacy. People are aware and people are able to help. So that's very important. If you guys have any questions, you're welcome to let us know in the chat box regarding JPSR. Also wanted to let you know that we do, when we're scoring, if something does score as a catastrophic in nature, we do what's called a root cause analysis. So when we do a root cause analysis, there are times when we do interview team members that may have been involved in the care of the patient. And we just want to make sure that everyone knows that when we do interview people, we're looking for process improvement. Never are we looking to point blame or to make anyone feel bad or worse than they already do feel. We realize that there's a second victim in this, and that's always the person that may have been involved in the error. We want to make sure that we're there for you too, and that we're giving you support. But whenever we do these, it's RCAs, it's very important that we have your feedback, and we learn the most from frontline personnel who do these processes every day, and we get the biggest improvements from talking to you guys. So that's why that's so important. And like I said before, if you have a team member that was involved in an event or a mistake was made, remember that we're all in this together. We're all trying to learn from everything. And unfortunately, that's one way we learn is from near misses and close calls. But it's just very important to not have any punitive response when you're dealing with your teammate. Be supportive, help them, and work together to try to help find a way to mitigate any risks that the patients may have in the future, okay? Another thing that I'm going to show you, let's see here.
Moving on to the next section, MD.
Okay.
On the 2017 at 8:04, we had a out the operation began at 8. And then I thought it was important to mention our.
Hold on one second, please. I'm sorry, guys. I don't have a copy electronically of the codes and stuff, but I do want to go over that with you. I know that you guys already received a copy of this, so if you are in Kerrville, you may not have some of the codes that are available to Audie. So, for example, Audie does have a code blue in Kerrville. You will have to call 911 because that is a long-term care facility. You will also have to call 911 to have, there's not a code team that's going to arrive to help you. Or a DART team, I'm sorry. DART, D-A-R-R-T, Dedicated Acute Rapid Response Team. They do not have that in Kerrville. They have code blue, I'm sorry. But they do not have a DART team there. So if you have a patient that is going to, that is looking bad and you feel like they need to go out, don't call a rapid response team over there, call 911. Also, the numbers are different. So for Audie Murphy, 15555 is the emergency number. For Kerrville, it's 12911 is the emergency number. Also, we have code greens here, and code greens means disruptive behavior. So if you have a patient that has a either they're being verbally hostile or you feel threatened in any way by the patient or their family, you can call a code green. And here at Audie, when you do that, mental health professionals should come to your aid, and I can tell you that does help very much. And also VA police will come to assist you. So that's what a code green is here at Audie. And then we also have a code silver, and code silver is our missing patient code. So if you have a patient that is, you don't know where they're at and they're high risk, you would definitely call a code silver overhead and alert everyone. So both Audie and Kerrville have the code silver. When the code silver occurs, police will come and they will ask for a description of the veteran. They also have what's called a LINKS, all employee notification. And what that does is it pops up on everyone's screen that's on a desktop. And it will give a full description of the veteran and where they were last seen. If you see that on your desktop, it doesn't work on Workstation on Wheels, just so you know. Please alert others in your area, and please check your area, because veterans show up in some of the, people that have tried to elope or are confused will show up in some of the strangest locations. So don't assume that people aren't going to come on your unit just because it's locked. Or, for example, we had a patient that was able to go in behind a cart that logistics was pushing, and was able to get into their supply area. So, that happens. Luckily it wasn't a sterile where they kept surgical trays or anything, but, someone went in there to get, a supply and saw the veteran there, was like, okay, you don't belong here. Let's find where you go. So don't assume just because you're in a locked location or someone has to buzz people in, don't assume that someone didn't get in there. It does happen. And also over at the locked unit in Kerrville, we have had veterans that will wait near the door, and if someone opens it to bring in dietary trays, they will try to get out. So just be aware. If you see people waiting near the door or pacing, and they're high risk, they're likely, or if they tell you, sometimes they'll tell you, I'm going to get out of here and I'm going to leave, and they're telling you the truth, that they're thinking it, they're probably going to try it. So just be aware and take those precautions to get them on the level of supervision that they need, whether it's a close observation with a sitter or with Abasis, which is our virtual sitter in the room, to alert you that they're trying to leave, okay? Also, we are upgrading our WonderGuard system. It has been put on hold because of COVID, but we already have that approved, and we are upgrading that. We are also getting tamper-proof wristbands. We're in the process of getting those because, sometimes people can get out of regular wristbands. So those will be coming shortly as well. As far as RCAs, new processes do occur from them, and you will likely see notifications that will say RCA update through your email. Please look at those. That's going to make you aware of any changes that may have occurred in either documentation or processes that you should probably be aware of. And it'll also help you in your workflow, too, to know those changes. That way you're not caught off guard. So be aware of those as well. I'm very sorry, team, but I do have to step off. I have an RCA meeting after this, but I am very happy that you joined our team, and we're excited to work with you. And please remember that we want you to feel free to speak up. And if you don't feel free to speak up, then there's an issue, and we want to know, and we want to help. So we're here for you. Our extension is 13584 over at Patient Safety. So if you ever need to reach us, please feel free to call that number if you need our advice or assistance. Thank you.
Thank you, Kathy. If any questions come up, I'll forward them to you. Okay. I know you need to go.
I really appreciate it. Thank you.
No problem. Thank you, Kathy.
Okay. Bye.
Bye now. All right, guys, if you have any questions, Kathy really had to go. She had another meeting. We appreciate her popping in and spending some time with us. So let's just go back and do a quick review since we have a few more minutes. So again, I just want to remind you that booklet that we gave you, that's I don't know how many pages, 72 pages or something. I know it's hard to read in electronic digits, or maybe you like it that way better, but it is full of good information. And one of the pieces of good information is how do I call code blue, right? So let's see if we can go over, remember it's 15555. But what I wanted to show you was this web page right here. This is called, you can access this from your home computer or your own device, whatever. All of our patients can access this information. The chief nurse and the deputy both alluded to this, but I wanted to show you where it is. So this is our official website that really talks about like our quality of care and the measures of quality of care and where you find these and what exactly are we measuring and how do we compare against our colleagues. So it's right here, VA access to care. And if you go under hospital data compare, you find Texas, you find San Antonio, and then you just pick a measure. So we've already talked about catheter-associated urinary tract infections. Jenny talked about that in the sense of not securing them properly and how that could actually cause an infection. So here it is, how us compare to our colleagues, right? So this are everybody in our sort of area, and you can see there's Methodist, South Texas Spine, Uvalde. So this sort of South Central Texas Baptist Medical Center, there we are. So it gives you an idea. If I was shopping for a good place to go and get care, this is the kind of information that our consumers, who are our veterans, can look this information up. And they can see, let's see, how about overall rating of hospital? How do we measure up compared to our colleagues here? So let's see if we can get this to come up again. And the website's a little slow, but it does give you an idea. So here you can see it says higher is better. And so this is how we're measuring in our local area, right? Right there. VA top 10%. So we're definitely in the top, top 10 for sure. And you can see where our neighbors are measuring compared to us. So I think it's really important to know that veterans have a choice. They have, nowadays they have more choice than ever because of Veterans Choice programs. And they can really say, yeah, I want to get care there, and these are the decisions that I make. And for those of you who are coming here and you're wondering, am I at the best healthcare facility? Go ahead and, remember this website and mark it down somewhere, and you will definitely come to know that there is high quality of care, and most of these measures are measures directly of nursing care. So you're joining a really phenomenal team. Let's go ahead and take a look over here. So they do have a nice, this morning I showed you our latest numbers from the director, how many COVID patients that we have. But we can take a look at this, and you can sort of track this if you're into tracking information about VA and COVID information. And so you can, again, like the rest of them, you sort of pick, where am I? We're in Texas, and then you pick the facility. So if you're wondering, well, what's happening in some other facilities in Texas, you can pick those. So let's just pick 2 so we can sort of see. Houston and San Antonio. So then it's going to sort of give you at a glance, right? Between the 2, this is how many active cases that we have, how many people are convalescents, and how many known deaths. So let's get Dallas out of there and see what's just happening here. So we have 238 active cases, and yesterday I told you 62 of those are in the hospital. So then the other amount is out in outpatient or home-based primary care, being monitored by our home-based primary care nurses. They're also monitoring our convalescent cases, and these are our known deaths. Also, this tells you how many employees and veteran employees have contracted the virus. And as of yet, most of these contractions have occurred from employee to employee. And this is why we have a very strict mask policy in our organization. And we really want you to have your mask on, protecting yourself, protecting your colleagues, because we cannot afford for you not to be able to come to work. And we certainly don't want you to be ill or become ill in any way. So it's really important to follow those procedures. So remember, this is just type into Google access to care.va.gov, and all this information is available to you if you want to get in there and do more research on information. So let's head back over to our web page here. So remember, this is the desktop, and remember, tomorrow when you come in, you're going to check your Outlook, all right? And those of you who asked me for the slides for the Nurse Professional Standards Board, a lot of you said, hey, can we get this information? So that you would go here, you would go under, I think it's quality. And there it is right there. So you can download those slides. This is not hidden behind any kind of, password or special access. And I'll send you this link once I see all of your VA emails. And that way you'll have access to all of the information that we've provided for you, and information that we haven't provided to you yet, but it's here available to you for reference in the event that you need it in the future. And we're constantly building this. So, or if you have an idea of like, wow, I really wish that was there, please share that with me. So that would be a really good way to make our information greater and more powerful. So we get back to that home page. Remember, your electronic health record is here. Your BCMA is here. You're going to have BCMA this afternoon. BCMA stands for Barcode Medication Administration. The BCMA coordinator will be online with you in the chat box, and you'll be watching a recorded training. So at that time, I would recommend for this one and the CPRS that you get it on the biggest screen that you have so you can really see it well. I know if you're looking at it on a phone, that can be a little bit difficult. If you're working in an outpatient area and you're saying, do we have BCMA in outpatient? We do not yet, but BCMA has moved to some outpatient areas, not all. So, you never know when it may appear, or you never know at this point when you may be asked to come and work in a more inpatient setting and you will need to utilize BCMA. So we just do it because we want you to have a good overview. So a couple things here. Let's just review. So we said medical center policies were here, right? If I need to review a policy, we use that. We've had a number of speakers come and reference this. I just want to make sure that you really understand and know, where do I get these policies? Clinical resources were here, employee resources were here. This is where you found, remember the nursing qual standards. MyPay is here, but you can get MyPay anywhere, get it on your phone if you want, but it's there for you. The data safety sheets. So again, if you're wondering, how do I clean up a spill? Or if Joint Commission comes and asks you, how do you know how to clean up a spill? Or if they ask you, how do you know how to clean a piece of reusable medical equipment? Remember, use one source for medical equipment and those safety data sheets for cleaning up a spill. And then TMS was here, and you will need to log into TMS. The VETAS login was here. So a lot of important things are under that employee resources. I want to point out too, eComp. So this is your employee compensation operations management for reporting workplace incidents. So if something does happen to you and you don't think it's that big a deal, like, oh, this happened, I don't think it's that big a deal, but like you hit your head on a cabinet and it really, really hurt. And you're concerned that it may have done something, or you tripped and you sprained your ankle, pushing a patient. Please complete these eComps because it's our way of tracking to make sure that you're safe. And, in the event something does happen later with that ankle, and they'll say, well, did you complete the eComp? And you say, oh, I didn't think I needed to do it. So it's right there. It's very easy. Just click on it, go through the sections. Our employee assistance program is here. And again, all this stuff is in the booklet. Also, it gives you a good overview of everything. So I highly recommend that you get in that booklet. And again, we're going to give you a printed version of it. And you get in there and you find out some information about the employee assistance program and the employee whole health program. Because your benefit package is beyond just this idea of like, I get dental and vision and medical. All of these things are really included. You're eligible for a whole health coach as an employee here. You're eligible for some counseling in the event that you need it as an employee here through employee assistance. When you come in tomorrow, the packet that we give you, it talks about child care subsidies, because we know you have our employees have children and they're worried about what are we going to do, So all of those additional resources are available to you in the packet, in the booklet, on the website. So you have the ability to reach out and get help if you need it. So if we go back to that main page, so I want to point out here, this is the speak to the director right here. And if you have a question, a concern, something is going on with you, you can just click on this and you can type what is going on and someone will get back to you. Someone will get back to you. You can just click on that and you can type in your question and you can definitely get a response either from the all employee you'll definitely get an email from the director's team or from the director answering your question or concern. And he has it out there because he wants to hear from you. So that's why it's there. So if you feel like you're not getting the answers that you need, you can definitely speak to the director. Also, we just set up this COVID-19 Information Center, and this is full of really good information. So if you have questions about something that's going on, they have organized this very nicely. It's got a ton of good information. We'd had a COVID clinic, but we didn't reopen that. But, donning with the Air Max, there's a video there, and then you can see there's HR information, childcare information, different PPE messages about wearing your mask in the facility, or, what does our PPE stock look like? There's resource material for you. This is the frequently asked questions, virus fact sheet. Then there's the personal care guidance, right? So things like, what do I do with my PIV card? Self-care, managing COVID-related stress, and then miscellaneous information. Maybe you have a question about VA debt reduction. So if there's some kind of question going on and you're like, no one said anything about that, this would be a first, and it has to do with COVID. This would be a good place to start to get this information. So for staff, and then the one for clinicians is, if you're concerned about aerosol generating procedures, and I want to know more information about that, so you can go here, or suicide prevention, or how do I order the COVID-19 labs for patients? How do I do that? All this information is here. It's available when you need it, because if we show it to you right now, you won't be able to remember. We're showing you too many things, but what I want you to know is that the reference point is here on the internet. COVID-19, many questions that can be answered right there for you when it comes to COVID. Also, remember the patient safety reporting, we call it a JPSR. It's located on the front page of your intranet, right here, front page of your intranet. And then there's just a few other bits and bobs here, but also too, you might want to get in the habit of checking out, because every day, morning report, they're letting you know what's going on in the organization and when our next all-employee meeting will be. How do you access that? So this is a good bit of information for you also if you're wondering what is going on. That's a good place to go, and it's the intranet front page. So we sort of like sealed that deal. Hopefully you feel kind of confident about how do I navigate this page and how do I get information. And then again, use your booklet, use your QR code to download those important numbers so that you have them right on your phone and you're not running around the unit trying to find this information. When you're new, that's how it feels. So this is why we do it like this. So I'm going to stop sharing. Our next presenter starts at 2:30, so that gives you about a 15-minute break. So go ahead and take a break, and we'll come back at 14:30. And again, it's BCMA, and he will be in the chat box with you. But again, make sure you've got your screen blown up. You can really engage with the presentation so you can see, what he's clicking and what he's doing, so that you're going to feel more confident when you're faced with the piece of equipment and at least have an idea of how it works. Okay? Let me just see if there's any questions. Otherwise, you guys are on break until 14:30, okay? Okay, so there was a question. I'll just answer it, and then I'll also type in the chat box. But Christine said, who gives us passwords for Outlook? Your access to the computer is your password to Outlook. So tomorrow when you log in to the computer, you will have access to your Outlook. And then once you transition to the PIV, you will have access to your Outlook. Okay, there's not another password. I don't know if you can handle another password, right? All right. Do we have little reference cards for quick viewing? So we do, and it goes on, it's one of those things that hangs on the back of your name badge along with all the other things that hang on the back of your name badge, but really 15555, and that is how you call your code. The type, we don't have all the types of codes. The little name badge flag is a little outdated. We've added some since then. So you might make yourself a reference card you can put into your pocket based on the little booklet that we have. And these are changing all the time. So I'm not sure that answers your question, but it'll certainly get you started. So remember, we have code red, that's a fire, code blue, emergency, code green, that's a mental health. Like they should have taught you that in PD or PMDB, right? They should have talked about that with you. And then we have a code silver. This is someone who's lost or missing. And then we have the news 2, and we have the DART team. And that's specific to Audie Murphy inpatient areas. So, okay. Right? Okay, guys. So go on break, stand up, stretch your legs. The last presentation takes a little bit of time, and you're going to want to be refreshed and concentrated. So grab something that helps you feel energized, and come on back here at 2:30. We'll be ready to go. All right, let's just do a quick sound check. Make sure you guys can hear everything okay. And then I want to show you one thing because I got this little question after the last little break or before the last little break. So I want to make sure. So we're referencing a lot of different things. And I know right now you probably feel like this guy right here, the spaceman, just kind of floating around. You don't know where you fit in. You're not sure, you know. Can you hear me okay? So you're not sure where you're fitting in or how you fit in, but I promise we're going to get you linked in. You're going to not feel like the spaceman anymore, and you're going to have all the information. And a lot of the information is in this booklet that we've gone over with you. So I referenced another QR code with you, and someone said, where is that? I only got one. It's in the booklet. It's right here on page 3. This is the QR code that you use for your important numbers, okay? This has got that wound care nurse, PICC line, you know, palliative care. We didn't add Mike yet, but you would have BCMA coordinator. He's going to give you his phone number separate from this, but this is where this is located, okay? It's in the booklet. We're going to give you a hard copy of it. All those phone numbers are written in there too, but you have to go through the whole booklet to find it. So that's that. All right, we're going to go ahead and start your training. You just scan that with the QR code reader. It'll show up on your phone. If it's an iPhone, you might take a picture and it'll just show up, and then just save it, and then you have the information handy to you. Okay? So I'm going to go over. We'll start the other training, and you can ask questions in the chat box. The BCMA coordinator's name is Mike Patterson. He's online with you right now.
So, BCMA. Who in here knows what BCMA is? I saw one hand. Okay. BCMA, Barcode Medication Administration. It is a tool that nurses use to give medications. Within that tool, there's a lot of things you can do, but its main purpose is to help a nurse give medication safely. Okay? The foundation of BCMA is the 5, technically 6 rights of medication administration that you have to pull back from way back in nursing school. I know you guys already have experience, and this is a refresher. But real quick, can anyone tell me that? Tell me the first right, or one of them.
Time.
Huh? Right time, perfect.
Right patient.
Right patient.
Dose.
Right dose.
Right medication.
Right medication.
Right route.
Right route.
Education. Signs and symptoms.
Signs and symptoms. Yeah, that's a good one.
I'm thinking of the 6th right. I know.
Documentation. Okay, there's a lot more rights now, but those 6 right there. Right patient, right medication, right dose, right route, right time, right documentation. Okay? That is the foundation of BCMA. From the very get-go, when we jump into BCMA, you will see all those start. So I'm going to go ahead and flip to the screen. And on the screen here, underneath our icon, it's the same in every desktop. Let's let those icons load real quick. You will see BCMA pop up right here. Now this is where the live is. This is where you as nurses will go, double click that icon, and you will click on that very first image of the BCMA one right here where my cursor is, BCMA South Texas, okay? The one that has the exact same icon right next to that, that's the parameter file which you guys don't have access to. Now we're not going to go there today, right this second, because we have to go to the test site. We don't want to be messing with actual patients. So we're going to go to the test site. But that's where you would go to do your medications. Give this a second here. All right, so the first thing that it's going to pop up with is your electronic signature code. A lot of sites and other VAs have disabled this. We've always kept it open, but this is basically your electronic signature code that you use to sign your notes with, okay? Does anyone have any questions on that? You guys have that? Awesome. If not, I can help with that. All right, so the very first thing that pops up is what? Scan the patient wristband. Why are we going to scan a wristband? Why don't we just enter in a social or an MRN number or something like that? Safety, right? You're getting along the line. Safety. We're trying to reduce medication errors on wrong patients. So we ask you to scan the band because you want to prevent errors, right? Plus it's easier. It's easier to grab a scanner and just scan a band that already has it there. It's beep, you're done, right? So here I'm going to grab out my test patient. If my cart will turn on. So my cart's unlocked. I'm going to grab out my wristband. Okay. For those of you who've never seen our wristbands, let me actually grab both of them real quick, just so I can also show people here. So our wristbands are pretty awesome. Has the ability to put a picture. You have your barcode, tells you where they're located, and you can also add a couple different flags about the patient. Okay. Has anyone not seen our wristbands here? Perfect. So I'm going to use my test patient here. His name is Twill. So I say he's twilling. He's got a picture over here on a raft with his sunglasses chilling right now. And we're going to scan his band. When I scan, it's going to pop up. The BCMA says, well, I don't trust you. I want you to verify this again. So it's going to pull up the full name, social, date of birth, their current ward, location, any allergies, adverse drug reactions, or patient flags. Our policy here, pretty much to identify a patient, is 2 out of the 3, the full name, the full social, and the full date of birth. With BCMA, our medication policy says flat out the only 2 acceptable forms of ID is full name and full social, okay? And the key word of full goes before that on purpose because a lot of people, if you ask for their name or if you state name, a lot of people just say Mike or Joe or Bob. No one gives their full name, initials, the whole deal. Same thing with social. Everyone assumes last 4 since we use social here, okay? So, and that was a tidbit that was given to me by our Joint Commission mock surveyist individual who asked my nurse that question back when I was in management, and he said, make sure you're saying full. So I always emphasize that. So, once you have validated all this information is correct, including the ward and the room bed, if you're on the 4th floor and this guy shows he's on the 6th floor, we got a problem. Now, will it stop you from giving medications? No. But could it cause an issue later on? Yes. We're patient advocates as nurses, right? We want to try to prevent safety. While yes, you could continue giving your meds, just don't forget to get with your ward clerk and say, hey, something's not right with the location with this guy, okay? And they can fix it just in case he goes to surgery or some outpatient procedure or something. They don't send him to the wrong floor. All right, so you click yes, and you're ready to go. This is your virtual do list. You'll notice in the top left corner, it brings in the full information, the full name, full social, full date of birth, everything. Right patient, right? Over here to the right side of things, and that section over here to the right, so here's your right patient information. Over here to the right, this is all ways to filter down your do list, okay? So you can filter by order mode, start time and end time, and schedule types. So normally, BCMA was in basically inpatient units. We never really saw it in outpatient areas, okay? So this was never really that big of a deal, but now we've actually put it in a lot of different outpatient areas, and a lot of inpatient areas now have clinics within them for short stays and things like that. So you might have a patient, depending on where you go, depending on what kind of patient they're listed as, like for instance on 2S, if they're in their short stay clinic, but yet you're on 2S, which is normally a surgical area, you might have a patient that has clinic orders. Now this one doesn't, so I click it and there's nothing to show there, okay? But the green dot usually symbolizes that, hey, there's something in there, go ahead and check it out. Now you can also do it to time. You'll notice that it kind of defaulted from 8 to 10, and it's because we're right around 9. So it usually defaults to an hour before, hour after, and that's because our policy says you have an hour before to an hour after to give meds for that right time. Okay, we do that because we understand as nurses, you can't have 5 or 6 plus patients. Back in the day when we used to have teams of 12, you can't give all your patients all your meds at 9 a.m. So we give you an hour before, hour after. And I recommend, as I tell most nurses, make sure you start that hour before. You never know what's going to happen when you walk into that room the first time. So, schedule types. Continuous PRN on-call one time. The only ones that I actually have listed down here, obviously, is the continuous and the PRN. It's got the green dots. On-call, obviously, to OR, one time for one-time doses. If you uncheck it, it will not show those. So if I uncheck the continuous, you'll notice that the only thing I see is my PRN. Right? If I uncheck my PRN, only that goes missing. Everything else is still there. Be careful that you don't accidentally uncheck more than what you should so that you see this. This actually happened to me when I worked night shift one night. I do not know how I didn't catch it, but when I was doing my meds at midnight, I was pretty excited. I saw this and I thought I had the best patient in the world, no meds to give. I was like, sweet. And then 6 a.m. my charge nurse walks in the door and says, hey, she prints the missing med report and says, why didn't you give your meds on this guy? And then I was freaking out. So I always tell people, be careful when you start filtering things down. So, yeah. All right, so down here is your virtual do list, okay? The first column is status. For status, it's simple. The goal of BCMA is to give medications. So the first status is G for given. And you will see that populate along the sides when we actually start doing some things, okay? But you'll see G for given. You can also have H for held, M for missing dose, and R for refused, okay? The goal, obviously, of BCMA is by the end of your shift, if you change your start time and your stop time to when you begin your shift to when you end, is to see nothing but G's down the line. That's when you know everything's been done, okay? VER, verification. Verification simple. Obviously, here we're familiar with CPRS. Other individuals may not be, but they'll hopefully see it. In CPRS, the doctor writes the order. It becomes pending. BCMA will never show a pending order in here. BCMA doesn't care about pending orders, okay? Once the doctor puts that order in, it goes to pharmacy. You're going to have to wait a little bit of time because pharmacy has a list of orders that they have to activate, but it goes to pharmacy to get activated. Now, pharmacy does not get a nice little right-click, verify, right-click, chart review, right-click, activate, or anything like that. They work in Vista, which is like DOS, as you guys know. And it is a step-by-step process to activate medications. So it's not that simple. I know a lot of nurses get excited. They're like, oh my God, I have a medication due now. They call pharmacy and they want it now. It's not going to happen that way, okay? So pharmacy looks at that order, and the first thing the pharmacy does is they say, okay, well, great. This doctor wants this medication. Did he order it within a normal range of that medication being given, okay? If he did, great. It's within that milligrams that a normal patient could see, right? It's not something way outside the bounds, right? Great. Do we have it in stock? Do we have it in the dosage that they want? If not, we have to rebuild that order. For some of you who are familiar with CPRS, you'll see sometimes a doctor write an order for, like let's say, a pill for 1,000 milligrams, and then all of a sudden it's DC edited, and it comes in at 500 milligrams. And that's because pharmacy didn't have a 1,000 milligram pill, they had a 500, and they had to tell the system behind the scenes it took 2 of those in order to make that order correct, to fulfill that order, okay? Does that make sense? Perfect. Once pharmacy's excited with all that and they're happy, then they activate it. Now it will show in CPRS that it's active, and in BCMA, if you're NA patient, you can hit the F5 key. F5 will refresh it and bring it in, okay? But now you will see a new medication, and it'll have the asterisk on the verification, okay? The asterisk means that a nurse has not verified the order. Why would we want a nurse to verify the order? Make sure it's correct, right? So the doctors who never make mistakes, the pharmacy who never makes mistakes, why do we need the nurse to make sure there's no mistake?
We're all human.
We're all human, exactly. We are the last line of defense, right? Not only that, but I'm a nurse, you're a nurse. I want to be able to look at that order and say, do I agree with that order? Because I'm the one who's about to go give it. Does that not make sense? Okay. So, obviously here I have a lot of them that I have not verified. Some of them I have. Those are my initials. Now, you as a nurse do not have to verify every single time you're going to give a med. It's just when that order is first written, okay? A nurse has to verify it. So hopefully the previous nurse has verified all the orders, but if you get an order on your shift, you will have to verify it, okay? HSM, home self meds, we haven't really done that here. Most providers here, even if it's a non-VA med, will order them and we'll just provide it to the patient, scan them, and give it to them. If not, they'll put text. If it's something we do not scan or we have, obviously in our system, they'll put something and there's an order that says the patient can take this medication. Obviously, that's a rarity, so we usually don't look at that column. Type refers to these initials, the P, the C, abbreviations, whatever, are the same as what's on your schedule types up here, where it underlines for C continuous, underline the P for PRN, N for on call, and T for one time. The alert, down over here on the right side, you'll see your alert legend. High risk, high alert, and requires removal. So the requires removal is obviously going to be like a patch or something. I don't have a patch on my test patient, but I do have insulin just to kind of show you that caution symbol there. Whenever you see that, whenever you give that medication, it's going to ask for a second verifier. A nurse actually has to go to the computer you're at. They will have to enter in their access code and verify code, okay? Because they need to verify that medication. So for instance, insulin, they're going to have to look at the vial. Is it expired? Right? Is it the right kind of insulin? When they drew it up in the insulin syringe, is it the right amount based off of what you're showing them before they verify that, okay? We used to allow, before they instituted that, just being able to add a comment that was like, oh, verify with Nurse Jane Doe. The problem we found out was that Nurse Jane Doe worked 24/7, 7 days a week, 365 days a year. So now we ask for access and verify codes for many years now. All right, next thing, active medication. So here's another right medication. I'm just going to go down the column. So right medication, right dosage, right route. Next dose is technically the right time, last action, and last site. These are more of information for you. And these last two columns, whenever you do something, do not always update right away. If you need to force an update, always hit F5 if you have a question. It'll bring all that information back in, okay? And we'll scan some things just to kind of show you that. So, right medication. I'm going to ask this as a simple question. Most nurses should know this. Is the medication dosage always the same as the dosage you're going to give? I kind of already answered this earlier. No. The reason why I bring that up, the example was that 1,000 milligram pill, right? Doctor wants 1,000 milligrams. We don't have a 1,000 milligram pill. We're going to give a 500, but we're going to give a dosage of 1,000, so we got to give 2. That's one of the biggest medication errors that I see whenever there's a medication error when they call me and they say, hey, Mike, can you look in the system to see was this a systems error or a nursing error? Okay, obviously on this one it's a nursing error. So like, here we go, here's the perfect one right here. This is a 250 and you got to get 500. BCMA will pop up whenever you go to scan it and ask you to scan both pills. If, and I say this as an if because we are human, same thing with pharmacy, right? I bring this up because this did happen. If it doesn't ask you to scan both pills, you call pharmacy. Now, as a nurse, when you're giving your medications, using BCMA as a tool, right? It's not going to do your job for you. I keep asking it, just like Alexa to wash my car. I keep asking it, BCMA, can you pass my meds? And it hasn't done it yet for me. It requires a nurse, okay, in order to use it, because it still requires critical thinking. So if it's not doing what you expect it to do, call pharmacy. That's all I ask. Pharmacy normally is the one who sets the parameters and they'll see it instantly. Okay. Any questions on this page so far? You have dosage, route, next dose. Also look at your route. It's like literally on your screen, maybe a couple inches away. And I ask that because we have had in the past times where, I'll give you an example, was We had some eardrops, right? The order said otic, however you want to pronounce it, and it ended up in the eye. And they asked me, Mike, whoa, what's up with the system? Can we change that? And I looked at it, I was like, you want us? I said, you want us to change every otic suspension or drop that's in our system pharmacy file to do that? And that's something that's done by National, right? We can't just change that because every time they do an update, we'd have to change it. And they do it all the time. They update our files. But I looked over here to the route side of things, and the route in these nice big bold letters was both ears. And it was very clear. It's just they didn't pay attention to it. So a lot of times the information's on the screen, you just got to make sure you're looking at it, okay? Some nurses get in a rush, and I'll explain that. All right, next one, IV piggyback. So, IV piggybacks, love them. Obviously these are late, but for those of you who can read that, I usually have this blown up 125. I thought I had it at 125%, but I guess I didn't. How many parts are to this order? 2. Perfect. So in this order here, you have your cefazolin and you have your D5, okay, in 50 mLs. Everything has to match whenever you get your medication, okay? So I'm going to go ahead and switch it to the webcam because I do have some examples here of piggybacks. All right. So here's our example of the piggybacks. We also have a foil one that's out. I just haven't been able to procure one yet from pharmacy, where you actually break it in sections, mix it up, and then you hang it, okay? Is everyone familiar with the piggyback, right? Perfect. So both parts have to be correct. The additive and the solution have to be correct. You have to remember, we're giving medications to patients, and medications ultimately can cause an issue with your patient, right? All the way to the worst case possible scenario of death, right? We're not handing out M&Ms, but obviously here, even handing patients M&Ms could have a negative effect, right? In San Antonio especially. So, here's your piggybacks. Let me ask you a question. Which piggyback as a nurse would you prefer to give? Okay, hold on. This one right here, the pre-mixed, or this one here? This one. Why do you prefer this one? You gotta mix it yourself. I love it. You know exactly what you're giving. I love it. A lot of individuals get used to pharmacy. Pharmacy, whenever they activate that order, especially for piggybacks, it also asks how many labels they want to print. So pharmacy will actually print out these labels, and it's awesome because our system actually generates a serial number on here that's specific to that patient, that order. The bad news is, and I'm sure a lot of nurses here have seen this as well, anytime anything changes in the background, whether they change a time, they look at it, they modify it, all those serials get wiped and all new ones get generated. So here you are as a nurse, and they've already sent up 3 of these. You grab one off your shift, you go to scan, and it says not found. So then you're calling pharmacy, and they're like, oh, we got to send new labels. Yeah. So, but the other thing is I can technically take this label off, and I can slap it on anything I want to slap it and scan it. It's not the same thing. So you always, as a nurse, anything you can verify, make sure you're verifying, okay? Make sure you're verifying. That's why I like these. Even though they give me a sticky, I can turn it over and see my solution. I know my additive. I get to break it. I get to mix it. I know exactly what I'm giving for safety for that patient, okay? Make sure you're looking at that. All right. IVs. Normal saline. Ignore the morphine right now. That's something we were testing before all this happened, and we were supposed to get together, and it didn't happen. So, right here, normal saline, 100 mLs an hour. It's currently stopped. Okay? Nothing different there. You're going to scan your bag. We're actually going to show you that. But there is a different tab for IV. Is there any questions on the layout of BCMA so far? No. Perfect. All right. Let's actually get into doing what we're going to do. So, let's go ahead and let's give some medications. So I'm going to pretend. So here, let me switch my cam, okay? So here I have my patient band on, right? I'm in my room, I'm a patient. Normally I would have you guys come up here do this and actually play with scanning. Unfortunately, with current restrictions, we're not going to have that happen, okay? Unfortunately. So you're a nurse, you're on the floor, right? You're zooming around your floor, right? You're going to go give your patient some meds, and you're happy, you're smiling, right? Because you're trying to project positive, right? Positive feelings to your patient.
They can't tell I have a mask on.
You can't tell, yeah, I know right now. Everyone's got a mask on, right? Like, can you see my smile? No.
Right.
You might see the cheeks go up, but anyway, right? So anyway, you go to your room. What do you do? Introduce yourself, right? Everyone always says that, and that's true because we're dealing with medications, but I also want to step you back and let's go to basic nursing. Whenever you go to your room, right, you have your cart, you pull it in front of your room. Make sure you gel, right? Knock on your door still, right? None of those basic things come out. And the reason why I say that is because as a manager, what I used to see was that nurses towards the end of their shift who were happy, right? That's when you really see them smiling, right? Towards the end of their shift, man, they got like a bounce in their step, right? And they were coming over, they're gelling, knocking on the door. Hello, sir, ma'am, right? How are you doing? Just checking before I leave, right? The whole deal, right? But during the day, oh my God, like they're in and out of that room without gelling, no PPE. They got their wound care kits, they got their meds in their hands, they don't even care. All that still is important, especially right now. So I just want to make sure that you bring that back. Even though this is medications, that basic doesn't go away. That's why I always bring that back in there, okay? So, it's simple. I'm going to scan my band, right? You're going to verify with the patient, right? Let me ask you this. Do you walk in and say, hey, Mr. Jones, how's it going? No. Exactly. You're going to ask the patient for their name. You're going to verify it that way. On the inside, you're going to verify their social, okay? And then you're going to scan, right? That's simple. Let me switch to my actual screen. So now that you've scanned the band, you're going to verify this information. You're going to click, sure, that's him. Now we have to give some medications. Now, obviously, these are late because I did an hour before to an hour after. They were due at 8, so technically 9 o'clock, so these are really late. And BCMA will show you the late medications for that day, and they won't go away until an action's done because an action should have been done, okay? So, let's go ahead and let's scan. So I'm going to scan my DocuSave. Senna. And afterwards, if someone wants it, you can take it. No, I'm kidding. So I'm going to scan, and the first thing that pops up is it's 88 minutes after the scheduled time. So right time. So this is part of that right documentation. We're giving a medication late, and now we need to document why. So in this box, give me something. Give me a good valid reason why you would have a late medication. Patient is an x-ray. Awesome. So patient off floor to x-ray, right? Perfect. You press OK, and then now, probably doesn't take this long. Usually doesn't. Now we have our G. Okay, G given. First one's done. Perfect, right? All right. Let's go over another one. If you're not going to give, okay, so what I always say is that when you're giving, you're scanning. That is the goal, right? You're just going to scan. If you're not giving, you're going to be right-clicking, okay, or clicking your mouse. So you're either going to click the do list or you're going to right-click your medication. It's the same menu, okay? So let's go ahead and let's go to the Lisinopril, okay? So let's say their blood pressure is out of range. So now we're going to hold it. Okay? Now as a nurse, do you have the ability just to go, I'm just going to hold this? No! You don't, right? Hopefully the doctors put some parameters there, or protocol in your area, right? We don't like to say protocols, but hopefully you have some kind of standing order, right, that allows you to do that. But if not, you're going to call, you're going to call the provider, right? You're going to say, hey, here's the situation, here's the vitals, what do you want to do? They'll give you some instructions. Let's say he says to hold it. So you're going to right-click it, and you're going to go down to mark, okay? And we're going to go held. Now this order is not nurse verified. Any order that's not nurse verified and has those asterisks off to your left-hand side over here, any action we try and do, whether it's given, held, refused, missing dose, anything, it's going to pop up with this box that says, hey, are you sure you want to continue because it's not nurse order verified? Okay? You shouldn't see that on your floor because most orders are going to be verified. Okay? If not, you can verify it. But I put this in here just so you can see it. We don't prevent you from giving medications. Some sites, I think, have disabled that to where you can't give any medications until you've done it. But again, BCMA is a tool to give meds, and it doesn't account for every situation in the world you're ever going to encounter, right? So we leave it with some leeway. So it pops up with a standard set of reasons why. All right, I'm not a fan of any of these except for one, okay? Even though all these might describe something or some situation, what I like to do is go straight to provider order, because the only way you would hold it is with a provider order, right? Or something that says it. And then now you see the H, but you're not done. This is where you're able to actually document. Right click it again. Now that you actually have an action, you can add a comment. So again, it's going to bring up information about it. It's 91 minutes late. It was held. What kind of comment? So you've just held the medication. You've called the provider. What kind of information do you think we'd probably put in that box?
The question, the reason. You can put the reason back if it was a low or outline. I would put low BP for MD or to.
Okay, perfect. Let's do that. So low BP per MD, hold medication. I usually would put per MD.
Whatever.
Yeah, let's just put Johnson or whatever. Can't type today, it's all good. And then you have your documentation for that. Does that make sense? Awesome. Let's go with the refused. My good old buddy over here, I love to refuse. Lactulose. Because a lot of patients, a lot of chuckles in the crowd. Yes, a lot of people who work med surg. No, not your patient's most wanted item. I did have one patient, not lying, who actually followed me around in the morning one time because he wanted it ASAP because he was going to use it on his pancakes because it's real sweet. Seriously, I'm not lying to you. I was like, all right, well, you'll be my next patient. So let's go ahead and let's actually wait. We're not going to scan. We're gonna refuse this. So again, we right click. If we're not going to scan, we're going to go to mark and we're going to go to refused. Again, it's not nurse order verified. We press OK. And it comes up with some canned responses. Again, I am not a fan of these because diarrhea, emesis, nausea is not really a reason for a patient to refuse it. I mean, it may be the reason to refuse it, but usually a provider is going to have a protocol that prevents that. If a patient's technically refusing, it's going to be patient request in my mind, right? So I'm going to select patient request, and then I'm going to right click. It has the R now. I'm going to right click add a comment. Okay, now if a patient's refusing something, what do you think you should do as a nurse, right? Do you walk up there and you say, here's your meds, and then the patient says, I don't want them. You're like, sweet, and you turn around and walk out, right? You're thinking to yourself, woohoo, 5 more minutes on TikTok, Snapchat, Instagram, right? A couple more swipes to the left or right, anything like that? Yep, no, that's not what we do as nurses. Again, nurses are educators, right? We are going to educate our patient. Patient says, I don't want it. We're going to try to intervene. Sir, ma'am, this is on your care plan. This is why you need this medication. If they obviously still insist they do not want it, what are you going to do now?
Get refused.
You are going to call the provider, and you're going to say, hey, huh?
You going to call the provider?
Oh, yeah, you're going to call the provider because the provider's going to need to know they're refusing it because they have this on, especially this. I mean, usually if they're ordering this, it's not because the patient just loves the stuff and it's an extra little drink for them. They're ordering it because the patient needs it, right? Some patients, encephalopathy, things like that, right? So the doctor has written this order and is expecting a response. If every nurse is just going, refused, walking away and not saying anything, the providers are thinking everyone's having a great day. Now, hopefully they're checking their notes and their orders to see what's going on. But you don't want to catch them 3 days later and they're like, why is this patient still confused, out of it, combative? Oh, wait, nurses haven't been given this, right? So you call and you say, hey, Mr. So-and-so doesn't want to take this. He's refusing. Can you please come talk to this individual? And then hopefully you're right. They'll write something else.
I would just handle that situation just to, vet refusal or whatever. Strongly encourage, educated vet on why, taking the medication, and then, we'll request a substitution. You know what I'm saying? I just always thought it was like it's the patient's right to refuse something.
No, it is the patient's right to refuse. But you also in documentation want to make sure you're covering yourself. So this is what I would kind of write. Patient stated, I do not want it. Patient was educated. MD notified, stated he would educate or talk to the patient. Right? Because during the interaction, the doctor may find out the reason why he doesn't want it is because of X, Y, and Z. And that's when he could say, oh, well, we have a different medication, right? But in the documentation side of things, this completely removes you guys. Right? Comprehensive. Not only that, but it's charted. Because if something happens to this patient, I hate to say it, you guys know as well as I do, it's not necessarily always just the patient you're dealing with. Who else are you dealing with? The family, right? And I like to use this as an example, okay? My wife's family is Hispanic, okay? I can do this, okay? I do not mean this on anything else. This is how they are, right? Any one of our family that gets into the hospital and it's like everyone's jumping on a plane, they're driving in, right? And then what happens? They bust through that door, and it's like, and they're running. Well, the same thing happens if something happens to their family member. Ethics consuls, they want to speak to the docs. I was actually in one of them. And they want to know who, what, when, how, where, why, the whole deal. What I will tell you is I got to sit on one with a family member. It was amazing. As a nurse, I will be honest with you, and I'm going to have to edit this out of my video, but as a nurse on the floor, I honestly, a lot of times you think doctors don't know what the heck they're doing, okay? But I'll tell you right now, we got an ethics consult on a patient. As one of the managers, I had to attend. And it was like at 3:30, and so I was thinking, like, please let this be done by 4, that's my time to leave. 5:30, let me tell you, almost 6 o'clock. But let me tell you, A game. Those doctors walked in that room, and I was expecting it to be a bloodbath against the docs. What are you doing? Why are you doing? Because I had questions. What are you doing? Why are you doing? But I kid you not. They had notes of every single day, what they did, why they did, how the results came back, why they changed their interventions, what they did with those interventions, what's not working, what is working, and where they're trying to go with their plan of care. My mouth was dropped. I was like, what? It was amazing. It was amazing. I've seen that multiple times. You don't think that they're doing that on their end to cover themselves? They are doing that on their end to cover themselves. I'm telling you right now. Okay, I've seen it multiple times. So you as a nurse want to make sure you're covering yourself and doing everything appropriately. Because if something happens to that patient, we have all documentation at every interaction as you're giving the medication is being refused. Patient doesn't want it. Something happens to that patient, you're good. Because you're right, they have the right to refuse. So now the patient's doing it to themselves. Not that we want them to do that. Yes, but that was awesome.
Do you have one time you can add your notes when you come back?
No, you can add multiple notes anytime. I can add another note. Add comment. So no, good question. Can you add it another time? Yes, you can add as many as you want. And in CPRS, when you go to the medications and you actually look it up in the bottom of that order, you'll see like all the like the status of given or whatever, and then you'll see all the comments below it anytime there was one added. All right, so let's move on. The next one is a missing dose. So here you have a patient, let's say he needs something, right? And you don't have it. You've checked your drawer, you checked the Omnicell in your locations, and you don't have it. So how do you do a missing dose? Again, if you're not going to scan, you're going to right-click, exactly, or do list, but right-click, missing dose. Here it's going to pop up with location, drug information, when you need it. I always tell people, date and time needed is not the same thing as like Grubhub or any of those other, DoorDash or anything like that. You can't say, oh, I want this next Tuesday at 2 o'clock, right? Pharmacy will ignore it. What most people do is they hit the N key. N stands for now. Go to reason. As soon as you take focus off that box, it will fill in now, which is April 13th at 9:40. Reason. Dropped. Empty package. Not available. Wrong dose. Different ones. Choose the one that makes sense. Most of the time it's not available. Click submit. Your missing dose is submitted. It gets sent down to pharmacy on a printer. They get to go through it. Now, I always tell nurses, now especially, because pharmacy came to us saying, how can we prevent it in the system, and we can't reprogram, unfortunately, BCMA. But one of the biggest things that's a pet peeve for pharmacy is that a doctor will come in at like 7 a.m., right? Obviously, last minute, and they start writing last minute orders, right? Labs, they forgot to write, all those good things. But one of the things they'll add is like medications. So a nurse sees that and they're like, oh man, they just ordered this medication at 7 o'clock. It is 7:15 and I don't have it. And what do? They enter a missing dose. Pharmacy knows that it's a missing dose because the provider just put the order in. You submitting a missing dose is actually causing double work for pharmacy because they get the first one and they're rushing to get it done. And then later on they see your other one and they're like, wait, did I already do this? I thought I already sent something up for this guy. But if not, they'll do it again. Now, it doesn't seem that bad, because I'm the only nurse that works in this facility, so me doing that makes no deal to them, right? One extra couple of minutes to do another med. The problem is it's every nurse on every floor who does this. So you get every nurse on every floor who does this, and they have a stack that's like literally, when I was down there with them, it was like about 1.5 inches to 2 inches thick. And like the next half of that stack is basically the first half repeated because of missing doses. Pharmacy does not get excited. Okay, it actually puts them way behind. So now with missing doses, obviously we have the tube system. So you can actually, if you need it now, if it's a stat now, and it's a true now, like you're with the patient and they need it now kind of a situation, you can call pharmacy, be nice, and say, hey, how's it going? Explain the situation, and a lot of times they'll say, let me get that for you, okay? Same thing with activation, okay? Sometimes pharmacy can take up to 30 minutes to activate a med. Doctor puts it in, right? Biggest example is you have a patient in pain, you call the doc, doc says, oh my God, let me write this order. So he puts it in, and it's in pending state. Here your guy's screaming. You as a nurse have compassion, so you feel for that patient, and you're wanting that order now, right? You check every 5 minutes to refresh, and you're like, oh my God, oh my God, oh my God, it's not there, it's not there, it's not there, right? So you call pharmacy. Again, pharmacy's trying to activate everyone's orders, and it's not a simple right-click verify. Give them time. If it's that important, call and explain the situation. A lot of times the pharmacist will say, let me stop what I'm doing, let me activate it for you, give me 5 minutes, and then he'll move on. Okay? But be nice. It's the nice thing. So, now what do? You have H, G, R, and M. What do you do to change those to G's, right? So obviously the H, it's held, you may not change it. The R, it may never get changed to a G. But the M needs to be a G, right? Or held or something else. You never want to leave your shift with M's unless it was done right before you left, obviously, right? You're not going to have a 9 a.m. dose missing, and here it is 8 p.m. at night, and you're getting off your 12-hour shift, and you're like, woo, missing dose, I didn't have to worry about it. No, you're going to have to work with pharmacy to get that dose up there. You're still going to have to give it. So how do you give that medication now? How do we give medications? We scan it. That's all you're going to do. So, perfect example, I have my lactulose, right? I'm just going to grab it because it's an R. Any medication, no matter what is there, all you do is scan. When it finds it on that list, it's going to say, wait a minute, this was just refused 11 minutes ago. What's the deal? So this is again where you would add your comment. You would put in here, let's say the doctor came back and talked to the patient and convinced him to take it, right? So patient spoke to MD and stated he would take it, right? Or he was educated, however you want to put it in there. Right? So now we're going to go through the whole process of giving this medication. So here it's asking for how much. I have to give 5 mLs. So here I would put in 5 mLs, right? And I would give a portion of this cup. And now it's changed to a G, right? Well, let's do the reverse. Let's say earlier when we gave that DocuSate Senna, let's say the patient, you scanned it, you go to them, and then a lot of patients, they look at their pills and they see that big pill and they're like, oh, wait, ain't taking that one, right? I've had that happen a lot. So what do you think you're going to do? If you're not going to scan, right click, right? So we're going to right click, and now that it's already been given when you go to mark, it gives you the option to undo given. So you can undo that given. Okay? Is there any questions on giving medications? That's the basic. Yes, ma'am.
Let's say you are about to give it and the patient throws accidentally waste. How do you check those?
If he drops it, well, now it's a missing dose, and then on those options under missing dose, it dropped, wrong medications, all those. Yes. Yes. Now, if you have it in your Omnicell, then it's simple. Just go to your Omnicell and get another one. Okay? As long as it's not a narcotic. I have to specify narcotics are a little different. Okay? Those are watched on every single dosage. Okay? So you would have to get a witness and waste it, you know, the whole deal. And this doesn't go into that. That's on your floors. All right, IV piggyback. So I can't scan the IV piggyback. Obviously, I can right click and I can do another option, which is unable to scan kind of a situation. But this is the same thing. You're going to scan, you're going to give. IV. So this order is already going. So here I have my bag of, let me go ahead and put this here. I have my bag of normal saline, okay? Again, I told you guys, be careful when you're giving meds or when you're scanning, right? Make sure you're giving exactly what you're doing. And make sure that when you're scanning, a lot of nurses on that first part when I was on the unit dose section, remember how that last one I did with lactose actually popped up with a box asking for how much, okay? Be careful, okay? A lot of nurses who don't give meds or think they gave meds, they hope they did, they may have given the med, but they didn't scan it. And the reason why, and I've seen this, is a lot of nurses will grab their strand. Now, I've broken my strand up into little different pieces, but a lot of times from pharmacy, when they pre-fill, you'll get this like long strand. And I'll see nurses that take it and they set it down on their cart, and they're looking down at their meds, and they go, boop. And all they're listening for is the beeps, right? They weren't paying attention to their screen. I heard a yes. He's laughing because he's seen it. Look at your screen. Pharmacy has the ability to do pop-ups. It has the ability to obviously ask questions. Make sure as you're giving your med, you're looking at your screen, okay? Because it may not have actually scanned, okay? So look at that. I say that because a lot of nurses, again, at the end of their shift, their charge nurse is coming, and they're like, why didn't you give this med? And they're like, oh, I swear I've given it. And they might have scanned something, but it wasn't that. So a lot of times I'll go to the previous medication that has a box where you have to fill it in, and what I'll see is basically the exact same scan number in the box because they didn't look up. So then it says that they gave whatever that medication was, like on this 5,377, hopefully milligrams something, and it's not what they gave. So we can see some of those things. So just be careful when you're doing that. That's why I always say make sure you're looking at what you're given on anything. Okay, so here you have your normal saline. Now I already have an order that was active, okay? It's been active. I use this for my test patient. If it's a brand new order, again, we're just gonna scan it. On this one, it's stopped right now, and that's because of the last time. I'm gonna go ahead and, I'm actually gonna go ahead and start it again. So with IVs, when you click here, you're gonna see your bags available. So the one that stopped, I'm gonna go ahead and take an action, and I'm gonna go ahead and set it to infusing, okay? Now again, you'll notice those right two columns did not update, right? Remember we discussed that? So in order to update that, we can just hit F5 and it'll refresh. Let me switch back to the screen, okay? So again, all I did was click it, and then my bag that was stopped, I right clicked it and I took an action on it, which we'll get over later. So you have your bag. We're gonna do a scenario here, okay? You're a nurse. You're coming in on your shift, right? Obviously, people get here early. This used to happen to me. I would always be early, right? My partner, whoever I was going to get report from, was super excited. I'd walk in the door and they're running at me, Mike. When you're ready, I'm ready. And I'm like, it's like, I don't have to be here for like 30 minutes. And they're like, I know, but we can get it over now, right? I hear it, right? So I go give a report, right? And they're like, okay, blah, 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 nothing. They give me the report. They're running out the door. I'm like, sweet. It's actually early. I got a report early. I can actually get started looking at my orders, get my day planned, and then all of a sudden, coming from my area, I hear beep, 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 right? So what happens? I go over there and I find my bag almost empty, if not empty.
Right.
Air in the line, whatever. Right? Camera, exactly. No, either way, you have a bag and it is just nothing left. And now at the beginning of your shift, you gotta, oh my God, I gotta go get another bag, right? So you run, you get your bag. What do? You scan. That's all you're gonna do. Pick up your scanner, you're gonna scan it. Now obviously this one did not have a label that was created from pharmacy, so it's kind of like, hey, this is normal saline, right? Yes. It's gonna say that previous bag was running. Do you want to complete that previous bag? Yes, we do, unfortunately, at the beginning of my shift. So now I get to add comments on that bag if I need to. I get to change the location just in case I got it on a pick line or something. But I can press OK. So now that bag is done. And then we're going to start the process hanging the new bag. And this is the same process if it was a brand new order that just showed up. You would scan your bag. Obviously, it's not nurse order verified. You see your asterisks. It's going to ask you where you want to put it. So where's this IV going to go? A lot of nurses hit the I on the keyboard. It'll bring up the IV lock, but you can also do midlines, pick lines, portacaths, wherever you want to put it. We're going to select IV. And you press OK. Again, F5 for BCMA will refresh it all, and you're going to see now that it's infusing. So now you're infusing again. And if you actually click your order down here, you'll see that it has the bag infusing as of this date and time, right? So now you're infusing this bag, right? It's going 100 mLs an hour. You're going through your shift. You're checking on your patient, right? All of a sudden you walk in and you're like, hey, how's it going? And the patient sounds kind of crackly, a little wheezy. So you start doing some assessments on him, right? You get down to his legs and you start playing tic-tac-toe 2 inches deep in his ankle, right? Just kidding. But basically, obviously, you get my point, right? He's starting to third space, right? Fluid overload. So what do? You stop it. Technically, we don't have the ability just to stop as a nurse, so I'm going to tell you to pause it. Again, most nurses, yes, they would probably just stop it, but because they know what the order is going to be. But I would pause it, and I would call the doctor, and I'd say, hey, here's the situation. Come check your patient. Hopefully they would come check him ASAP. They would most likely tell you to stop the fluids, right? So back in the day when I was a nurse, whenever they would stop or DC or your patient's going to go home, let him go, I was never taught the proper way to do it in BCMA. So for all those years, which is probably about 13 or so years on the floor, anytime I had a patient who was going to stop fluids, DC, whatever, I would just walk in there and I would disconnect from their arms. I'd wipe my lines and put my Kuros caps, flush the line, and walk out. I never went back to BCMA to actually tell it that I stopped it, which is what we're supposed to do. Did you ever do that, Chris? Look at him. No, and neither did I.
It's been a while, Mike.
It's been a while, right? Exactly. Let me tell you right here.
Like, it's been a long time. We had nothing like this. Like, you just put your bags up, you did your thing, you took it down.
Correct.
It wasn't charted like this.
Correct. No. Believe it or not, it was. It just no one taught us.
I had paper chart. It was never charted like that.
Paper chart is a different story, right? You can put whatever you want on paper charting. All right? Trust me. That's why computer charting adds accountability. unfortunately. But, so we're gonna say infusing. So now you're gonna come to your infusing bag, you're gonna right click, and you can add comments, but you can take an action on the bag. So here, you can actually stop it, stopped. And you have to put a reason. So obviously, the only reason we're gonna stop it is MD order, per MD whoever, right? MD Johnson, whoever. And we're gonna stop it. Let's go ahead and F5 to bring the latest information. And you'll see that it is stopped. And if I click it, I see my little stopped here. And it will have what had happened. I can obviously start that infusing later on if the doctor changes the mind. But a lot of times, you're just going to stop it and then they're going to probably DC it anyway. Okay? So, I'm glad I taught you guys something new.
I would never throw my preceptor Larissa under the bus, so.
I like that. I like that. I like that. Loyalty. Loyalty. A lot of people didn't know that. I know. I'll be honest with you, neither did I, which is why some of my patients, according to our informatics nurse, Daryl, he said that to this day, there are still patients in our system who are 6 feet under who've had IVs running for like years. So, in informatics, if we were to try and run if we were to try and run a query on our system that says who currently has bags running right now in our system, the data would be wrong. So, exactly. All right. Is there any questions on how to give medications the proper way? Now, one thing I am going to go over here only because we have time here. The cover sheet. The cover sheet gives you like a basic overview. The cover sheet will also show you if a order is flagged. Now, normally what I'm going to tell you is that providers should not flag a medication if they don't want to give it. They should actually put it on hold. On hold, you will see your line actually grayed out across the whole section and it will not let you give the medication. A flag in a patient chart is just something that brings attention to that order. Anyone has the ability to go action flag. On the med-surg unit, sometimes they would flag a telemetry order to remind the provider to renew their tele orders. And in CPRS, you get this nice red block next to it, which would be kind of like in this area over here. BCMA does not bring that over. On the cover sheet, though, it will show red in this column here. Okay, but the only way you'll see that is if you go check the cover sheet. Most nurses obviously have CPRS open because that's their main program, and they only have BCMA open when they're going to give medications because that's the medication administration program or tool. So just as a heads up, okay? But you can't see it on the cover sheet, just as something to see. All right, so we just went over how to do it the correct way. All right, so now we're going to learn how to do BCMA the wrong way, okay? What I mean by the wrong way is bypassing, all right? So I'm going to go ahead and I'm going to switch back to camera. So I told you guys that for safety, BCMA is set up the way it's set up to scan. You scan your patient wristband, that prevents an error of entering it in, right? How many of you have a password that's like 8 to 10 characters long and you still type it in wrong? Most people, right? Imagine having different patients all the time, every day, 4, 5, 6, however many patients you have, all different socials, 9 digits long, and you're having to enter in them as families talking to you, as your call lights are going off, right? People are yelling, screaming, you might have a code green going on, something else, right? It's gonna be a big issue. We used to see a lot of errors. Again, scan the band. Same thing with medications, right? On your medications, you have your barcode. Every medication and every dosage of that medication has its own barcode, right? You're supposed to scan the medication. Now, BCMA has built-in ways to, I hate to say the word bypass, right? But it's a bypass. It's a way not to do that. And that's because sometimes, obviously, not everything's working correctly. So, the first way is wristbands. Under wristbands and under medications, the two bypasses are a keyed bypass and a unable to scan bypass. So I'm going to show you the first one. keyed. A scanner is literally just a it's like a keyboard. As soon as you scan that barcode, all it does is type the keys for you, basically imagine it in your head, and then I program it to press the enter key. So whenever you see that green little strip across the screen that says scanner ready, right? Let me switch back to here. So you see scanner ready, there is a hidden text box somewhere that has focus and it's waiting for you to scan in that social. In reality, I'm going to switch back to camera here. In reality, I can take my keyboard here and I can just start entering keys. And it's going to say invalid patient lookup, right? I can start entering. Those are key bypasses. If I actually enter in a social, and every time I do this, because I know the way our system, I always try to make up something. Oh, that is a new patient. So that is a patient, right? But is that my patient? No, that's not my patient, right? So that is a keyed entry. Let me go back. The other way to do it is to click unable to scan. This is the way we prefer you to do it, okay? So you don't have a mistake. Unable to scan, it's gonna pop up and ask, why can't you scan? You have damaged wristband, scanning equipment failure, unable to determine. Should you ever use damaged wristband? No. Why? What would you do as a nurse if you had a damaged wristband? You'd have your clerk get another one. Exactly. Scanning equipment failure. Get rid of that equipment, right? Throw it out the window. No. You're supposed to notify your manager. Okay? Now, normally I would say scanning equipment failure would not be a reason, just get another computer. But now, with the influx of people we're getting in the units and the number of wows, cows, miles, whatever you want to call them now, either a computer on wheels, which is no longer allowed because it offended someone, workstation on wheels, or MAW is medication administration workstation, right? Any computer that's used to give that is now, that's the term they're calling it at National, is medication administration workstation, a MAW, whatever, MAW. Hey, MAW. But anyway, it's what it is. There may not be enough. Make sure you're letting your manager know that something is wrong. Put a comment, okay? That's the key. And then unable to determine, I hate it, I'll be honest with you. I can't tell you how many people put that. Put a comment, let me read it. If you're unable to determine it, put a comment. All right? I always tell people, give me a story. Once upon a time, there was a nurse who was unable to determine why they could not scan a wristband. This is what the situation was. Let me know, because I work with the managers, I work with pharmacy, and we try to fix those issues. And I'll show you why in a second. So let's say it is unable to determine. I put a whole story in here, right? Type it all in. I press OK. Now BCMA says, well, that's great, but I don't know who you want. You can't scan a band. You have to tell me. So it uses the same principle as CPRS. You can do last initial. Since I know my guy is Twillen with a C, I know his last four. It's going to pull up patients that are similar, and I can select my patient. I can also enter their area. So obviously my guy was on KTCC1. It'll bring up all those patients. Again, my recommendation is something that really breaks it down to the minimum of patients, because you can accidentally select the wrong patient. Again, you press OK. In that same box, even when you scan, pops up that now it says I've confirmed this patient's identity using 2 acceptable forms of identity. What are the only 2 acceptable forms within BCMA? Full name, full social. There you go. Now it lets you into the system. All right, done. Now, same thing with meds. You'll notice in the bottom left-hand corner it says ready. Technically it's green. There is a hidden text box where it's waiting for me to scan my medication. Again, I can enter in manually the numbers. And actually, pharmacy, a lot of times, if you have the medication, you're staring at it, and it says exactly what you need to give, and you still can't scan it, pharmacy, when you call them, they'll say, oh, just enter in number, blah, 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 blah. We try not to do that. Honestly, I'd still prefer to use unable to scan and let me know pharmacy stated. But put in there that You talk to pharmacy and you want them to fix the issue. A lot of times when a medication won't scan, that's due to a new manufacturer's barcode, something new that came in, and procurement down in pharmacy is supposed to take those meds and they're supposed to enter in those barcodes as this barcode is equal to X, this barcode is equal to Y, whatever it is. Sometimes they may miss something, okay? So just tell them, can you fix it? Because they're supposed to fix it. And then that prevents any other nurse around the hospital from having an issue, okay? So, the next thing is unable to scan. So let's say I wanted to give this medication right here. Unable to scan. So you right click, right? We're not scanning, we're right clicking. Now you're unable to scan, okay? So it wants to do an action of given. It's telling you it's late, so obviously we have to give it a correct reason. So again, patient off floor, wherever they may be, to the ward, missing dose, whatever it may be. And I always tell nurses, be careful what you're putting in here. This is part of the chart. Back in the day, some nurses didn't realize that, and they would put things that weren't appropriate in there. Like, I don't want to mention right now since this is being recorded, but different things in there that aren't supposed to be, like for missing dose, they put pharmacy sucks or something like that, or whatever reasons, and that's part of the patient's chart. And My Healthy Vet, a lot of vets now know with My Healthy Vet, that information is viewable within 24 to 48 hours and they get to see everything. So make sure you're putting something correct in there. Reason, why can't you scan it? Again, pick the correct reason. I'm going to click unable to determine, but I hate that. Give me a reason. Press OK. It's going to ask you to verify the 5 rights. Now it's going to go into actually giving it. So we'll just say per order for now, but you could put 1 spray per nostril, whatever. Now you have a given. Let me ask you a question. What was easier, bypassing or scanning it? Scanning it, exactly. That's why we say fix it for other nurses. It's more efficient, it's faster, it helps prevent errors, all of the above. Scanning, okay? Now, let's go into the last thing, which is going to be PRNs. PRN medication. And I use this because I want to do my med key entry on this. Because I don't have a Tylenol, but I want to give a Tylenol, and so I have to med key in it. That's why I save it for this time frame. So you have a patient, he's in pain, right? You check his meds, you're like, oh, what do you have? So you just leave your PRN and say, oh, wow, you have a medication to give. Again, be careful what you're filtering. I know the number for Tylenol is 29, so I enter in 29. And it's going to pop up and tell me, last vitals, the last dates it was given, and it's going to ask me for a range. It says, wait, this is when it was last given. Does this match? Have you reviewed the order? Are you giving it correctly? Now, my order, I don't have every 4 hours, every 6 hours, things like that. But you would want to pay attention to that order and make sure you were giving it within that time frame, okay? That you have reviewed it. Now, it doesn't stop you because technically you could have a PRN and a scheduled, and yes, it would be kind of given close. But per the doctor, you were able to give that. So, select a reason. Pain medications aren't the only thing, obviously, we can give PRN, but we're going to do a pain medication. So we're going to select pain. Now, any option that you choose that deals with pain, discomfort, chest pain, anything like that, headache, it's going to ask you for a pain score. So you're going to come over to pain. And now it's going to require a pain score. So a lot of patients, when they're in pain, whether they're doing double backflips and a twist or no matter what it is, what do patients usually say their pain is? 10. Not always, but a lot of patients.
10.
Yeah, 8 to 10, yeah, a lot of them, 8 to 10, yeah. So you push OK, and now you get your G over here that says given, okay? Right next to your Tylenol. Now that you have a G, you can right-click it, you can add comments, right? But a PRN order is meant to recycle. It's not a specific order that has a specific time or date. It's meant to recycle. So as soon as I jump out of that chart or I F5 to refresh it, click the wrong button, F5, that G is going to go away. Okay? So if you need to add a comment to that or any other medication within your profile, go to File, go to Edit Medlog. Okay? And then Medlog will show everything you've done today, and you can actually click into it. You can add comments. You can even change the status to undo give it. Okay? So I give that as a tidbit to go over that. So File, Edit Medlog. Okay? That's your medication log for the day. You will not see anyone else's med log. Only certain people have that access. But now that you've given a PRN for pain, what is a nurse supposed to do? Reassess, right? We assess our patients all the time, right? When we walk in the room, right? When you go to say hi to your patient, you assess with your nostrils. Woo! You smell something, what happens? I'll tell you what I used to see. I'd see a nurse, literally, it's funny. They would start walking in the room. I'd see that sniff, and then I'd see them walking right out. And then they would be like, hey, nursing assistant, can you go check on my guy in room? Right? And you're like, no, you didn't. You did not just do that to your nursing assistant, right? I can tell you how many nurses I saw that with. It was funny as can be. I would see that, like, turn on a dime. I was like, oh. Right? And I was hoping, I'd watch him and I'd be like, go to the room, get some wipes, and no, they went straight to that nursing assistant. I do that joke because please love your nursing assistants too, okay? They're there to help you, right? Use their help because you still got to do your assessments, right? I used to love helping my nursing assistant when I had to change a patient because of my skin assessments. It's easy. You have help. They're available. Done. Anyway, we have to reassess our patient with pain meds, right? How long do you think you should give? Do you give your patient your Tylenol, walk up and be like, oh, here's your Tylenol. Oh, did that help? Aw, right? Awesome. Do you go then? No. Most people, if it's an IV, 30 minutes. If it's a pill, about an hour, right? Our policy says you have to clear your PRN, which is reassess your patient within 2 hours, okay? So, how do you reassess in BCMA? I'm going to show you. You can right click here. I like that. I don't know. She's like, why am I here to learn? No. You're gonna, again, if we're not going to scan, we're going to right click, right? You can do PR and effectiveness. But where I like to go is down here in the bottom right-hand corner where it says I have 1 PR and effectiveness. Double click that. It's going to come up with a box. And it's going to list your PRNs. Now, obviously this patient's been lucky. I've been his nurse. And I've been clearing my PRNs. You might see more of them there. Find the one with your name. Make sure it's highlighted blue, and then you can actually do an action. So here, let's say, an hour later you go check your patient. He's now at a 3. You can put a comment. Was it effective? Go to your pain assessment, right? Initial pain assessment, and what did they put as his baseline at home? If his baseline at home was a 3, you could actually put that patient at baseline, right? Or if it's not effective, you could put not effective, and you're going to call the doctor, right? Now, one other thing you could do is change the time. If you change the time, it's still late. So we have 2 hours, right? It's still technically late. Changing the time really only changes the time it's entered into the vitals package, but you can do that and enter a comment. And we allow you to do that because sometimes a patient goes to dialysis or they go to surgery and they want their pain med before, even though you educate them, but they may have to wait an hour before they get in there, right? So it could help. So you can actually, when your patient comes back, if they didn't clear it for you, dialysis uses BCMA now, right? The inpatient side of it. They can technically clear your PRNs, but if they don't, you can actually put a comment. Patient stated at this time or within that first 2 hours, his pain was at this, and you could change this time. Again, it's still going to count against us. But you clear it, it's gone, we're done. You've cleared your PRN. Is there any questions on PRNs at all? Okay. Perfect. So make sure you're clearing them. I think that's it. I'm here for questions. Go ahead, Chris.
Partial usages, again. I know with narcotics, we need to have a witness, they need to go back to the office cell and do the weights correctly, but in regards to, like, for instance, 50 milligram tablet of metoprolol, you give 25 milligrams. Is there a section that we need to put a partial usage comment in there, or is it automatic? I can't remember. Like when you scan the medication.
So usually pharmacy is going to order what's going to complete it.
Right.
Okay? If it's partial, like for instance that lactulose, it pops up with the box to ask how much you gave. Okay? If it requires multiple, like for instance the, let's take the valproic acid just to kind of show, like this one here, 250, 500, I'm supposed to scan both, right? When I scan the first one, it's going to come up, it's late, because Chris keeps asking questions. No, I'm just kidding. It's going to ask you to scan the second one. So you'll see the first one grayed out, right? It's going to ask me to scan the second one before it completes that order. Okay? It should ask you for both pills. Again, if it wants like a partial, then it's usually going to pop up the box to ask how much you gave. Okay? Is there any other questions? Yes, ma'am.
On the Carvedal, I noticed it had 6.25 and the 3.125. Which one was that?
Okay, she caught my, so again, this is a teaching. I do this, I set up a lot of errors, okay? So that is an error, but you caught it. Okay, so here, I have 6.25 and a 3.25, but I'm only asking for 6.25. Again, pharmacy, doctors, anyone can make a mistake. You caught it. I used to use that to catch people. The problem is no one caught it, so I stopped using it. I just haven't stopped ordering it. Again, make sure you're looking at what you're doing. So let's go ahead and I'm done with BCMA, but I'm going to get into reporting. So with bypasses, I don't want you to bypass. Every time you bypass, when you're unable to scan or you key in something, there's a potential for an error, which is why I run reports every month, and I turn those into your managers. So anytime you bypass, anytime you key in an entry, I know you're doing that, okay? And so, don't do it. Anything more than 10, I actually get with your manager. So I'm actually gonna go to the live site. I'll show you real quick where we stand. So this is the live version, just so I can show you guys. Before this year, we were amazing. We're recovering right now because of a printer that went down in Kerrville, as well as a couple of medications that came in new. I'm actually working with pharmacy as we speak, but we're slowly moving back up. Okay? So this is the live site. If I was actually to go into a patient's chart and actually start messing with medications, we'd have some nurses on the floor freaking out. They'd be like, I didn't give that narcotic. It says you gave it. No. So we're going to cancel out of that. So if you're a nurse who wants to look at your meds before you give it, right? If you want to get an idea of what you're getting throughout the day, then what you would use is file open limited access. Limited access does not count against your scanning rates. This allows you to enter a patient, jump into their chart, but you can't scan. This is how you would do that, okay? Because these are the reports. This is one of the reports that I run. Managers have, I give them the keys for this. We'll just do a summary. So I'm going to do way back in the day, unfortunately, not this year because it's getting better, but I'm going to go back to December. And I'm going to preview the data for, this is a summary for December. And what you're going to see here is that it breaks it down to wristbands and it breaks it down to medications. So wristbands, we scanned about 44,000 wristbands. And on bypasses, we had about 385. And it breaks it down to keyed entry and enable the scan option, numbers. Under medications, we get the same thing. We did about 179,000 whatever. Bypass 941, and it breaks it down to keyed entry, unable to scan, and then also Vista manual entry if you use the Vista package to manual enter something, which is usually a pharmacist when I check that out on the clinic. So overall, we're 99.1% on wristbands and 99.5% on medication scanning. Who in here would say that's amazing? That's pretty amazing. National says we have to be on wristbands. We have to be above 93. We're 99.1. Medications. National says we have to be above 97. We're 99.5. Last year when I ran data numbers based off of every VA, the average was about 96 to 97 on wristbands and 99 on medications. So we're like right within that range of medications because we shouldn't have an issue with medications. And then wristbands, we're like amazing. Would you be happy with that number? Yes. As a manager, when I used to look at those numbers and I was above 95, I was in the blue, I was excited. Woo! I'm done, move to the next thing. But in this position, obviously, I look at it a different way, right? I'm going to retwist this, okay? I'm going to twist this a different way, and I'm going to say, what if we put on our website, right, 385 bypasses, 941, let's say 13 to 1400 bypasses, right? Every time you bypass, there's a potential for patient harm. What if we were to put on our website, wow, we could have only killed 1,400 patients this month. Cha-ching! Exclamation point, smiley face. Would you send your family member to that hospital? No. That's the way I look at this data. I'm excited that we did that great, and it was like that for a long time until now. And I only say that because, again, we're recovering from all the bypasses from a lot of different medications and stuff, which I've checked into, obviously. And when I talk to nurse managers, things like that, that's the reasons why. And I'm also looking at comments when you put in comments. So that's how I'm able to narrow that down. And we got that printer fixed, but obviously pharmacy had sent out a lot of meds to stock in a certain area that uses a lot of medications, and it's caused an issue. But we're slowly moving back up. Same thing with wristbands. We had an issue with one of the inks that they sent in the settings in the wristband printers. We're working on that. But this is our average throughout the year with this last year. So that's why it becomes important. And so I run reports that actually break it down to who, what, when, how, and why. And I will send those. If you're greater than 10 on any bypass, I send that to the manager. So please do not bypass unless you have to.
All right, let's see. Give Mike a minute to answer a question. We'll close up here. If you have other questions, we'll let Mike answer those questions. So. All right, so we're catching up. It's always this little delay here. Thank you, Mike, answering the questions. All right. Yeah, we're gonna catch up here. Hold on. Give Mike a minute to answer a question. We'll close up here. If you have other questions, we'll let Mike answer those questions. So. Yeah, we're gonna catch up here. Hold on. Give Mike a minute to answer a question. We'll close it. All right, you guys out there? So, okay, so we got some more BCMA questions. And I should start popping up on your screen. Take your time. Hopefully you're hearing me now. All right, we're just giving Mike a minute to answer more questions. Hopefully you guys are going to hear me. Someone said they had echoes. Is that gone? No, Chris, they did. Mike answered that question up here earlier. I think he said, yes, at the VA we were using the Social Security number. Yes, Chris, full name and full social. That was from Mike. That was our earlier question. Okay. I hope Mike can answer that question from Sam. We just have to know it comes from pharmacy. And where's there some list somewhere? Okay. All right, so there you answered it. Were we still hearing an echo? Shouldn't be an echo. It's the end of the day, we're almost done. All I want to do is remind you what's happening tomorrow. Unless there's more questions for BCMA. All right, we'll let Mike finish these up. All right, we're going to do the best we can with this that we have left, because I really just want to make sure you know what to do tomorrow. Are we still hearing an echo? Can you hear what I'm saying? How about now? All right, tomorrow morning, I'll type this in the chat box for those of you who cannot hear what I'm saying. Tomorrow morning, we start back at 7:30 in the morning. We start out with another accountability. We always give ourselves a few minutes. Like this morning, we had all these little hiccups. And then at 8 o'clock, we start with CPRS, which is another video like this, and the CPRS informatics nurse will be online with you to answer your questions. And then we have a quality safety values, and then in palliative care overview, a very short video. It doesn't take as long as we've given it, and then you're released to come to units, and we'll talk more about that tomorrow. So if you have questions, really it's been a long day. We've given you a lot of information. So I really want to let you go right on time. No commute, you're home, rest, enjoy. Read the booklet, review those policies. We're going to talk tomorrow about how you get your AccuCheck access and how you get access into CPRS. So, it's bricks. We're building bricks. So, first we got your PID. Most of you got it. Minus one. I've already discussed that with that individual. So now we talk about how do I get access into CPRS. Okay? All right. I am going to log off here. Remember, tomorrow morning, 7:30, I'll be in the chat box for a few more minutes. If you have a question that you want to type to me, that's fine. All right, guys, good night. Thank you for all your patience today, and be safe, okay? Rest well.